As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Good morning. Good morning, Sophie. Hello. It's 7:30 now, and it's time for me to talk to my colleague about what happened to you this night. So I'm going to tell about you and about everything around you. Is that okay? Okay. This is Alessandro, and he will take care for you in this day. Okay. Well, Alessandro, this is Sophie. She came in here 3 days ago with a septic shock, and overall she is doing well. If we look, you see she's still intubated. It's in her lungs, yes, you can see. But I managed to build it down this night. So she's not on the pressure controlled, she is more doing for herself in the breathing. So I think that she can further go on today. So maybe you can manage to let her breathe for herself.
Okay, she goes better, yeah.
Yeah, and I think that will be a very good step forward for her that she can work on. Furthermore, the blood pressure, that is stable, and this night we lowered down the medication to keep it stable. So I think in this morning you could stop it.
Okay, well, so you decrease the ventilator and the medication support.
Yes.
Okay.
And well, that was because she was also a little bit agitated, so that gave her the push and to give her the stability to push forward. So I think she also needs your support today to be calm and to have enough comfort.
Okay. And did she receive the visit of her family member?
Yeah, yesterday they came. Her mother comes, and she has a friend, and he also comes. And I talked to her mother on the phone this morning, and well, she told me that she is worried, but she's not communicating well enough with her boyfriend.
Okay.
So it might so be that you could consult the social worker, so that the social worker can arrange, well, maybe a discussion or maybe talk to the mother and have reassurance for the mother.
Okay, later. Okay.
Yeah, I think that will do for her very good. For the rest, I think it would be nice for her to get out of the bed, and she needs that to get out, and that will be a good point.
Yeah, okay, I think so.
Have you any questions for me?
No, it's okay. Thank you.
Okay. What we have done is to turn over my shift in the night to the day shift. And what is needed, that I tell what happened this night to Sophie, to my colleague, so that he can take very good care for Sophie with all the machines around Sophie.
It is very important to share this information with every team members of the intensive care unit for the best care of Sophie. Good morning, Sophie. Hello. How are you? Well, now we'll do the round all together, in which we discuss your improvement and the goals for today. Okay? All right.
Good morning. So, Massimiliano, what can you tell me about Sophie?
Well, Sophie has been with us for 3 days now, and she has been here for a septic shock. I think her condition is generally improving. Her drug levels are going down, and also her organ function is improving.
How about the kidney?
The kidney are also going better, and she is able to have a good urinary output on herself. I think also we are on the 3rd day of antibiotic therapy, and the condition is generally improving.
Okay, and the antibiotics are correct?
Yes, we have identified one bacterium on the blood, and the antibiotic therapy is targeted on that.
Oh, perfect. Alessandro, anything from your side?
Well, during the night with a very, very light sedation, she slept well. She's comfortable. Now, no pain, actually, and a good bowel partner now.
Okay, perfect. So I would say we try to switch off the medication today.
Oh, completely? Okay.
Yeah. And then also later today, we will try if we can get her off the breathing machine and put the tube out. And
Wonderful.
before that, perhaps, Victoria, can we try to sit her at the edge of the bed?
Yes, I think we can try. Yesterday she was able to move arms and legs by herself, so why not?
Okay. It will be a little bit tough for you, but I think it's important. So the physiotherapy will help you to sit at the edge of the bed, and then we will see, yeah? And later on, we will try to get the tube out as well. We have no nutrition yet, but I think that's fine since we are improving anyway, and then perhaps we can try after the tube is out to start with normal food. I read something about family issues.
Yes, she had a complicated family situation, so I think it could useful call the social assistance for the round tour here.
Okay, Massimiliano, you will handle that?
Yeah, I will call the social assistant today and see what we can do on that.
Okay.
Okay, perfect. This was the very important interprofessional ward round. There, we discuss important information between the healthcare professionals of the ICU team. Furthermore, we discuss the goals for the patient of the day.
Communication with caregivers is one of the most highly valued aspects of care. Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow. Research has shown that families get frustrated or confused when clinicians use medical terminology or abbreviation without explaining them. Also, they get confused when they receive information from too many different clinicians. So don't hesitate as a family member to ask questions, to ask the nurse or the doctor to repeat the information, and more generally, don't hesitate to ask for a meeting with the ICU team.
Hello, Sophie. I'm your physiotherapist. Today, we're gonna try to put your legs out of the bed and to stay sit. We're gonna do that together, me and your nurse, okay? Let's try. Okay.
So, we check the length of the tube. Please check the length of the lines.
Everything's okay?
Okay.
Okay.
Well,
So,
together.
we can start. Come here with your legs. Okay.
Oh, good.
Sounds good. Okay. Okay. How are you, Sophie? Is it comfortable for you? Okay. Let's breathe normally.
Perfect.
Okay.
Pain? Okay. Small breath? Okay.
This step is very important for the weaning of the tube. Okay? Okay.
This collaboration between the nurse and the physiotherapist is a key feature for the best outcomes of the patient. And together we get off of the bed and sit Sofia on the bed.
Hi, Alessandro. How was your shift?
Hi, hello, Delia. Well, Sophie, all right?
She's awake today.
Yeah, she is. Well, morning shift was very good. We decreased all artificial supported, and now she goes very better. The goal is to remove the tube, so stop the ventilation by this evening.
Oh, nice.
Yeah.
Were you able to have a physiotherapy session?
Yes, this morning we put the leg outside the bed and she was good.
Okay.
Is it?
Perfect. So, Sophie, I am going to take care of you for the next few hours and we are going to remove the tube. Are you happy? So you are going to be able to speak again and we can hear your voice again.
Okay.
Perfect.
So, see you tomorrow.
See you. You're free to go, Alessandro.
Bye.
Bye.
Sophia, we're going to take the tube out now. Just breathe normally. It can be a little bit uncomfortable when I do the suctioning. Just breathe normally. Breathe normally. Okay, ready?
Ready?
on 3. 1, 2, 3. Perfect. Breathe normally. Everything fine? Perfect. Yes. So, Massimiliano, what can you tell me about Sophie?
Lady Sophie, she was extubated today because her condition has been improved in the last 2 days. Her septic shock is completely resolved, and she is not anymore on most of the effective drugs, so she's been improving in the last days.
So there's no organ insufficiency, so all organs are working normal, we have no organ support.
Yeah, exactly.
Okay.
Cardiac function is completely restored, and also the kidney function is going well.
Okay, perfect. Did she started eating already?
Yes, she started eating today, and also she has been mobilized out of bed in a chair.
Okay, perfect. Looks good. So she can be discharged tomorrow, right?
Yeah, the program is that one. If everything is like this tomorrow, she will be discharged in the ward.
Okay, okay. Good, perfect. Thanks. In the afternoon, we do a handover from the day shift to the night shift. Important information will be exchanged so that I can take care for the patients during the night.
In our ICUs, you will see the interprofessional team. You will see doctors, nurses, help nurses, physiotherapists, you will see social workers, and many people working in the ICU from other specialties like the consultants, or sometimes you can see people who are helping ICU patients for different things. We are an interprofessional team. The teamwork is important because any outcome in the ICU is the result of how we work together and how we are structured and able to deliver the best critical care for our patients.
Hi Silvia, how are you?
Fine, thank you. How are you?
Fine, thanks. And she is Sophia. Do you remember Sophia?
Yes, from yesterday.
Sophia, she is Silvia. She's the nurse who is going to take care of you for tonight.
Hi.
You could see she is really improving. We were able to stop her medications, all inotropes and vasopressor. We were able this morning to reduce ventilatory support, and then this afternoon to stop ventilatory support and remove the tube. And she is also able to swallow. We try with water and then with food. So we were able to remove her nasogastric tube. So she is really, I think, feeling better.
Yes. So tonight, it seems to be a quiet night. You will be able to have some rest. I will put the lights a little bit off and the sounds, the less sound of possible, so you can have some rest. And tomorrow you will be able perhaps to go out from the intensive care unit. Okay, if ever you need something, you call me, I will be there.
Okay, thank you very much. Perfect, I leave you in really good hands. See you tomorrow. See you tomorrow. Bye.
Bye.
During clinical rounds, we assess whether patients have symptoms that we need to control. We usually do that with doctors and nurses as well as all the professionals during clinical rounds. We are very much paying attention to whether patients are painful. We not only assess pain intensity and pain distress, but also response to pain therapy as to be sure that pain is controlled. Other symptoms like distress, anxiety, hunger, and thirst are also symptoms to which we pay attention, and we are making our best to control these symptoms several times a day.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Well, welcome to you all. This is the first session during our Congress, and I will start with the what to do today. And I hope to bring you some of information. This is our second digital Congress, where we will have 8 channels with a lot of sessions. And you have to make choices between VOD, the video on demands, and live sessions. We will start with daily groundbreaking releases, and we will have interactive parts. And what you have to decide is whether you are going to look at the VODs or join the live sessions. And what I can tell you is that everything will be available for you after the Congress. So then you will still have the possibility to watch all the VODs, but then you cannot take part anymore in the interactive part. So we will have an interactive part with Meet the Expert today. If you wanted to know everything about lactate, why not join Jan Bakker? And just join him, ask him your questions. You will have the possibility to discuss all kinds of interesting things you want to know about lactate. Or you want to speak to one of the leading experts on echocardiography. So why not speak to Antoine Vieillard-Baron about this and ask him all kinds of questions you could not read in his papers, or that you always wanted to know. Or speak to one of the experts in neuromonitoring, Chiara Robba. So that is all for you to decide today, and you will have a lot of choice to make. There are educational courses, and we introduced this year educational courses in perhaps one of your other languages or your primary language. We all speak English and everybody speaks English very well, but some of us perhaps do not speak English that well and rather hear it in their own language. So we will have today educational courses in French and in Portuguese. And tomorrow there will be also educational courses in Spanish and in English. If you want to see some of the new talents that we have found and see what they do and see the experts of tomorrow, then you can join the session what we call Rising Star. You can see people who are relatively new in their career of intensive care, but they have very important things to mention and also a lot of enthusiasm. There is a separate channel on education, and you have a separate channel for the next, that is the younger members of our society. You can join the nurses and the healthcare professionals, or you can go to the tech forum where you can hear everything and see everything about data science. Apart from that, I also want to draw your attention to the industry sessions that we have. It's always good to know what is considered important by the industry. And at the end of the day, I will have an interview with the chairs of different sections. And that is for you an easy opportunity to get the highlights as considered by the chairs of the sections. And today I will talk with the chair of the acute kidney injury, Marlies Osterman. I will talk to the section chair of the neuro, which is Geert Meijvoort, and to the chair of the trauma and emergency medicine, Claudio Sandroni. And they will talk with us and discuss what they considered as very important features and presentations of today. So it's a nice summary which makes life a little bit easier for you. I also hope to convince you that we have a lot of video on demands that you can see already in your program. And as far as I'm concerned, it really competes with Netflix, with Disney and Amazon. And it will probably make you busy for the next weeks to come. And I will talk with you again tomorrow about what today. Thank you very much for your attention, and have a very nice day, and find that what suits you best in the program. See you tomorrow.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. morning or good afternoon, wherever you are in the world. I am Maurizio Cecconi, the President of the European Society of Intensive Care Medicine, and I'm very excited to start the first groundbreaking release sessions where we will present groundbreaking studies. It's a pleasure to be with Nicole Uferman, also our Editor-in-Chief of ICM Experimental. How are you, Nicole?
Good morning. I'm very happy to be here. So welcome to all of you speakers and listeners from all over the world. Thanks, Maurizio. Looking forward to today.
And also with Giuseppe Citerio, our Editor-in-Chief of Intensive Care Medicine. How are you, Giuseppe?
I'm very fine. I think we will see a lot of people coming in intensive care in the next few days, and I'm happy about it.
Excellent. And just to remind everyone, the Society is streaming these sessions free for everyone. We think it's important that access to research should be available to everyone, so don't miss everything that will be released also from our social media channels in the next few days. Without losing any more time, I would like to introduce the first speaker for the first paper to be presented. I think we have with us, and we welcome Elena Garbero, the Clinical Project Manager of the Laboratory of Clinical Data Science at the Mario Negri Institute in Milan, and I believe that also Guido Bertolini, also the senior author of the paper presented today, will be with there. Hello, Elena. Hello.
Hello, can you hear me?
We can hear you very well. The stage is yours. Please start with your presentation. We'll look forward to it.
Thank you.
I think we can start with your talk, and then we will get questions at the end.
Yes, the presentation is pre-recorded.
Okay, I think we can then start it.
Good morning to everybody. I'm Elena Garbero, and today I'm very glad to present you the results of the COMPACT-2 study. COMPACT-2 was a randomized clinical trial about the use of high-dose coupled plasma filtration and absorption CPFA in septic shock patients. The study was led by GVT, an Italian intensive care unity network. To conduct the study, we received an unconditional grant from Belco, the CPFA patent holder. Belco had no role in the study. I don't have any conflict of interest. Septic shock is a complex condition in which there is an acute dysregulation between pro- and anti-inflammatory mediators. In the years, different extracorporeal depurative techniques have been developed to treat patients in septic shock. The rationale was to remove from the bloodstream inflammatory mediators and restore their immune homeostasis. The efficacy of this technique is still controversial. CPFA is one of such technology. The CPFA circuit uses a cartridge containing a synthetic resin designed to specifically absorb mediators from plasma. After the cartridge, there is a hemofilter. As you can understand from the name, COMPACT-2 wasn't the first study led by GVT. The first study, the first COMPACT, started in 2007. The study was interrupted for futility at the planned interim analysis. The hospital mortality in control group and CPFA group was not different. In the study, we recorded a high number of protocol violations in terms of a low volume of plasma treated with CPFA. The high number of protocol violations was due to the complexity of CPFA technique. However, a pre-planned subgroup analysis showed that patients receiving a CPFA dose at least of 0.18 liters per kilogram per day in the first 5 days had lower mortality than control. So, the first compact did raise the hypothesis that CPFA could be effective when treating high volume of plasma. In 2010, a new machine was available for CPFA. The new machine allowing regional anticoagulation with citrate. With this regional system, was easier to reach higher treated plasma volume compared to the system used in the first compact study. In the first compact, clinicians used anticoagulation, a systemic anticoagulation with heparin. Despite lack of satisfactory clinical evidence, several ICUs started to use citrate-based CPFA in their clinical practice. For all these reasons, GVT decided to launch the second compact study. Compact 2 trial was performed in 12 Italian ICUs, and the design of the trial was an adaptive design. We planned 2 interim analyses. The first about the feasibility of the technique. With this analysis, we wanted to understand if the high-dose CPFA was performable with the new machine and with the regional anticoagulation with citrate. The second interim analysis was about the activity, and with this analysis we want to evaluate the ability of CPFA to accelerate recovery from septic shock. Only if the result of these 2 analyses were positive, we could continue to recruit the patient to assess the mortality. Eligible patients were aged 14 years or more, and eligible patients were patients admitted to the ICU in septic shock or who developed septic shock during the ICU stay. Among exclusion criteria were pregnancy, contraindication to extracorporeal depurative technique, admission from another ICU where the patient had spent more than 24 hours, estimated life expectancy of less than 90 days, and absence of consent. About the treatment, the control groups were treated according to the current practice, the same for CPFA group, adding high-dose CPFA at least in the first 3 days. CPFA had to start as soon as possible and no later than 12 hours after diagnosis of septic shock. Then, the treatment with CPFA could be discontinued after 3 days if the patient was no longer in septic shock. For both arms, CRRT was permitted. The high-flow CVVH was not permitted. When we recruited the first 50 patients in CPFA arm, we could perform the first interim analysis about the feasibility. The primary endpoint was percentage of patients with more than 0.2 liters per kilogram per day of plasma treated with CPFA for at least 3 days. We could continue the study only if this percentage was greater than 90%. The result of this analysis was a percentage of 81 and a confidence interval compatible to continue the study. When we performed this first interim analysis, we found that some patients died very early in the experimental arm. When we reported our analysis to external data safety and monitoring committee, they requested us an unplanned interim analysis about the 3 days mortality. The 3 days mortality was higher in CPFA group compared to the control group. According to this result, we decided to prematurely stop the trial because we were worried about a possible harmful effect of CPFA. When we stopped the trial, the randomized patients were 115. Patients in the experimental arm were 63, and patients in the control arm 52. We had this imbalance between the two groups because we used a block randomization schedule, and in different centers, the randomization blocks were not closed. When the study was closed, we performed all the analysis planned by protocol. The second interim analysis was about the activity, and the primary endpoint was day free of septic shock in the first 15 days from randomization. We could continue the study only if high dose CPFA increased the time free of septic shock of at least 2.5 days in the first 15 days after randomization. Also, in this case, we found a result in favor of the control group. In fact, we found that the control group increased the time free of shock of 2.2 days. So this result is in favor of the control group. Also, with this analysis, we demonstrated a lack of activity. So we were within our stopping rule. The primary outcome of the study was the hospital mortality, and we don't find any difference between control and CPFA group. The secondary endpoint was mortality within 90 days from randomization. The survival curve diverged in favor of control group. We performed 2 different tests, the log rank test, not significant, and the PITO test, significant. In the PITO test, early events have higher weight. Since our findings were unexpected and opposite to our initial hypothesis, we also performed some unplanned analysis. The first was to evaluate a possible center effect on our result, but we didn't find it. The second unplanned analysis was to understand if the possible harmful of CPFA was in a particular subgroup. We divide the patient into different groups. patient with severe renal failure and patient without renal failure. We chose this subgroup because CPFA exposes to an extracorporeal treatment. Patients without renal failure don't need this kind of treatment, so CPFA could be detrimental. The survival curve show that there are not different in between control groups and CPFA group in patients with severe renal failure. But we have a difference in mortality when patients don't have severe renal failure. Another unplanned analysis we performed was to assess the presence of a dose-response relationship between treated plasma volume and mortality. We developed a COPS model on patients randomized to CPFA, and we take plasma volume treated with CPFA as time-varying correlate. In this analysis, we found a positive and significant association between treated plasma volume and mortality. Our study has some limitation. We have a lower number of patients because we decided to prematurely stop the trial and we didn't recruit all the patients performed by our protocol. Then we performed some unplanned analysis. All the results obtained with this analysis, we have to consider carefully all the results obtained with this analysis. And finally, we didn't dose cytokine in our patients. Our conclusion are that the COMPACT-2 was prematurely stopped due to the possible harmful effect of CPFA in patients with septic shock. The harmful effect, if present, is particularly marked in the early phase. Patients not requiring RRT seem most exposed to possible excess CPFA-related mortality. And there is evidence of a dose-response effect which could be related to the CPFA cartridge, the RRT, or both. According to all these results, we don't recommend the use of CPFA for the treatment of patients with septic shock. Thank you for your attention.
Thank you, Elena, for this very nice presentation, and congratulations on the paper. Not just a negative paper, but actually a paper that shows harm in the experimental group. I think Elena and maybe Guido Bertolini are also connected for some questions. But while they connect, hi Guido, hi Elena again. I would like to ask maybe Giuseppe, the editor-in-chief of Intensive Care Medicine, when you receive a paper like this, which clearly is also a bit controversial, how do you work and why was this particular paper important to publish?
Thank you, Maurizio. I think the idea to publish a negative trial is important because we need to send some information to the community, and what Elena and the group of GVT demonstrated is the negative effect of something that they planned that was beneficial to some patients. So we wanted to have this information published because negative trials usually have some difficulties in being published. And I would like also to ask Elena and Guido something about the process of the journal for, let's say, defining the final product that has been, the final manuscript that has been published, how they felt during this process, and if you think that it has been difficult to publish it, because also I noticed that the paper relies on data that are not so new. So, and I think the message...
To ask that question, because I think it's 2017 was the end of the study, and it took 4 years probably to publish. So.
Yeah, we received it in 2021, so we try to speed up the process, but I think that the message to the community needs to be sent as soon as possible because of the harm of this trial. Please, Elena or Guido, would you like to comment about the process, the idea to publish it, the delay we saw in the publication of the trial? Please.
Elena, would you like to answer, or?
No, you can answer, or Elena or you can answer and to comment about the process, about the idea, and also the delay we stress about this paper.
So the process was quite long because we review also the clinical record. So we took a time to be sure about our results, because our results are opposite versus our hypothesis. So we decided to review all the clinical record, and this was a long process.
Okay, we start to get some questions also from our chat and our platform. But before, I also would like maybe Nicole. You are the editor-in-chief of ICM Experimental. This is not the first time that something seems very plausible on paper, or maybe from basic studies, but then when we transfer that to clinical practice, the biological plausibility actually ends up in harm. What's your view on this specific paper, and how can basic science help this?
Thank you, Mauricio. I would like to congratulate the authors, and I agree with Giuseppe that it's very important to publish, let's say, negative trials, because they can also teach us a lot and ask us questions about the mechanisms. And I think that this study is actually a very good example of well-designed and a good rationale. And they had this positive Compact 1 study, which initiated the launch of Compact 2. But then it is negative, and then I think it is time, if it is negative at the bedside, that we go back to the bench and ask the question, what is going on here? So this is a good example of that study, and the authors, you offered already an explanation that is plausible, that there may be a removal of compounds that the body needs, such as antibiotics. And I would like to ask the authors the question whether they have other hypotheses of what is going on in this study, and perhaps if there is some blood sample left that they could measure some biomarkers. But please, Dr. Garbero, could you talk to us? What do you think, what would be the biomarkers of interest that you would have liked to measure, if at all possible?
No, in the study we didn't measure any marker, because we don't have found to disease.
Could you tell us a little bit about, perhaps, about the cause of death of the patients? Was it refractory shock, or?
Yeah, retrieve the cause of death, it was very difficult for us. We review all the clinical record, but it was very difficult to understand the cause of the death for the patient.
Thank you, Ellen. We are receiving some questions, and I think also as president of the society I have to ask, I think, an important question. This study, I think, or a study on this technique was stopped for futility in 2007, and this was another study because of a subgroup analysis that maybe showed that there was a potential for a subgroup of patients that could be treated. But again, it's negative, it's harmful. Is this the end of purification techniques in sepsis, do you think? Maybe Guido.
Yeah, well, this is a very difficult question, and I think is one of the questions of this trial. Honestly, this question pertains to the problem of generalizability of results. And it's this is something difficult to address because generalizability is a problem of the exportability of the mechanism that are underlying the effect we saw. And so the generalizability result is a matter of exportability of the representative of the physiopathological mechanism that are under the occurrence of a phenomenon, and we don't know much about the real mechanism that are underlying the septic shock and severe sepsis in humans. So. There are good reasons to say both that this trial is an evidence to stop these techniques at least in septic shock, but also there are reasons to say that this is just one technique and the others may act differently. The problem is that we don't know much about the physiopathological reason that caused these results. Unfortunately, we don't have the biobank, so we cannot study and analyze biomarkers. So it's difficult to say a final word. What we can state is that for now. To adopt in the clinical practice one of these techniques, we should be very cautious, and we should need and we have to have important evidence, high-level evidence to adopt any of this technique in the real practice. So I think that we think that CPFA should not be used in this kind of patient, but all the other techniques should be assessed with through randomized clinical trial with final endpoint as mortality or any way important endpoint, because otherwise it is very difficult to to be sure about it.
Okay, thank you for this. Just for the sake of time, and we have another question, and I think this relates also to what you were saying. Can you tell us the difficulties probably on trying to correct for confounders, especially during an interim analysis? Because you mentioned in the paper that maybe there are two potential mechanisms for harm. One was maybe the clearance of antibiotics. The other ones that maybe some patient didn't require renal replacement therapy, and maybe there was a signal for harm there. But I understand that on the review of the clinical notes, an inappropriate antibiotic was found, I think, in 8 patients, but I didn't understand where this was split equally between the two groups. How did you tackle this, and did you stratify for groups to see if this harm signal was specific about a very specific subgroup of patients?
But the problem is when you stop earlier the trial, you don't have statistical power to do many analyses. I think that one of the most important results of our analysis is that we found a dose-effect relationship between CPFA and mortality. This is quite important because it seems that the volume of treatment is related to the harmful effect. So this is quite interesting. It is really difficult to say if really antibiotic were the real problem in providing these results. We review all the clinical chart of these patients, and we saw that most of the patients were treated accordingly to the guidelines. But the problem is that in those patients with good renal function, probably to add another technique that clear antibiotic more than normal can reduce the amount of antibiotic circulating, and so the efficacy of this antibiotic. This was actually the case in most of our patients, because the dosage of the antibiotic was quite on the threshold of the effectiveness. So one possible hypothesis is that this can be the reason of our results, but it is really impossible to be sure about this mechanism. It's just an hypothesis generating.
Guido, thank you. Very clear and really very important study, and thank you for clarifying how difficult is also the analysis when you see these results. For me, it's another paper that shows maybe that less is more in what we do in intensive care sometimes, but we have one comment, I think, from Giuseppe and one from Nicole before we wrap up the session.
Okay, I thank Elena and Guido, and I think every time we start a new technique inside the intensive care unit, we need to think about the benefit that we have, and sometimes we are attracted by new technology and we start in the unit immediately something new because it's presented like something that could save lives, and we never think that something could produce also harm. And I thank the colleagues from Mario Negri to underline this problem. And I think we have to study more around this technique, and I think the field is open for new research. Please, Nicole, do you want to close?
Yes, I would urge people not to throw away the technique, not use it at this point, but do more investigations, and if at all possible, to collect blood samples to look at mechanisms.
Yeah. Thank you all, and really I would like to join my host here in congratulating the team at Mario Negri, because a very important study, and again showing the importance of randomized controlled trials in our field. It is possible to do them, and they are very important to do. Thank you very much for listening to the first groundbreaking release, and see you to the next.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
Welcome or welcome back to this session on the best oral presentations. My name is Nicole Jaffermans. I'm the editor-in-chief of ICM Experimental, and I will be moderating this session together with my co-moderator Jean-Louis Touboul. He's editor-in-chief of the Annals of Intensive Care Medicine. And I would like to congratulate all the speakers of being part of this session, as they have already achieved the prize of being the best oral, of having submitted the best oral abstract. So first of all, I would like to announce the first speaker, which is Dr. Azevedo. He's from the hospital São Domingo in São Luís in Brazil. And he will talk about the high protein intake and early exercise in adult ICU patients, a randomized controlled trial, phase 3 study on functional outcomes. Dr. Azevedo.
Mr. Chairman, they studied high protein intake and early exercise in adult intensive care patients, a prospective randomized controlled trial to evaluate the impact on functional outcomes was conducted in the ICU of the Hospital São Domingos in Brazil. Conflict of interest known to declare. Conclusion. This study showed that a high protein intake and resistance exercise improved the physical quality of life and the survival of critically ill patients. Objective. This trial compared the efficacy of high protein intake and early resistance exercise with lower protein intake and routine physiotherapy with similar energy delivery on the outcome of critically ill patients. Results. We did not notice any significant difference between the two groups in relation to the median percentage of calories received. However, the median amount of protein received by the HP group was significantly higher than that received by the control group. As determined by the protocol, on the third day, patients received 50% of the measured energy expenditure. On the fifth day, both groups received 80% of measured energy expended and reached their protein goal. At this point, the HP group and the control group received 1.90 gram kilogram day and 1.34 gram kilogram day of protein, respectively. The PCS score was significantly higher in the HP group at 3 months and 6 months. The ICU acquired weakness was higher in the control group, but the significance was borderline. The ICU in the hospital mortality was expressively higher in the control group. Take-home message. A high protein intake associated with resistance training led to an improvement in the physical quality of life of critically ill patients as measured by the physical component summary PCS score. Also resulted in reduction in mortality and a tendency to improvement in the ICU acquired weakness measured through hand grip strength in the study group.
Thank you, Dr. Azevedo. I believe, are you online? Are you connected with us? Yes, hello. Hello from Brazil. Congratulations with your study. And I think it's a very important study, and I would like to ask you some question about it, because you did actually a combined intervention of increasing the amount of protein levels as well as increasing the exercising of the patients. So which one of these components do you think really did the trick, or do you think that it is the combination?
Well, we have a few information in the literature about the association of high protein intake and
resisted exercise. And this is the objective of this study.
Yes, and you found that the physical score improved with your intervention, but you also found that the mortality was decreased. So was this a surprise to you? What are your thoughts?
Yes, sure. We were a bit surprised with the results in mortality, but if we intend that the primary objective also was obtained, we could imagine that the mortality also would have an impact.
Yes, and what I can imagine, if you want to do a lot of exercise with your patients, that they need to be awake. Is that true? Or can you also do this with the more severely ill?
Most of the time. Some patients initially were sedated, and the resistive exercise was passive, but as soon as possible, the active movements were initiated.
Thank you.
Thank you very much. So we have to move on to the next presentation, but we'll make a little change. We'll first listen to Julien Textoris speaking about outcomes, costs, and healthcare resource utilization related to acute kidney injury among patients hospitalized with COVID-19. And Julien, are you here?
Yes. Hi, my name is Julien Textoris. I'm VP Global Medical Affairs at bioMérieux, an in vitro diagnostic company, and it's my pleasure to present today our results on outcome, cost, and healthcare resource utilization related to acute kidney injury among hospitalized patients with COVID-19. This was a collaboration between Premier Applied Sciences, University of Chicago, and bioMérieux. Several reports highlighted that AKI is frequent among hospitalized COVID-19 patients and is associated with poor outcomes. However, data on healthcare resource utilization and cost are scarce in this COVID-19 context. We performed an observational retrospective study using hospital discharge data from Premier Healthcare database, which contains 20 to 25% of all US inpatient discharges between April 1st and October the 31st of 2020, with a 30-day follow-up and a one-year look-back period for comorbidities. We included all patients with a COVID-19 ICD-10 diagnosis, excluding those with history of renal transplant, end-stage renal disease, receiving dialysis in the previous year, or with a stage 5 CKD diagnostic code during the index hospitalization. AKI was defined here through ICD-10 diagnostic codes. Among the 208,000 COVID-19 hospitalized patients that we included in this analysis, 30% had AKI, of whom 9.7% required dialysis during the index hospitalization. 24% had an ICU stay, so 1 out of 4, and among those, AKI rate was 52%. Patients with AKI were therefore more likely to have an ICU stay with an adjusted odds ratio of 3.7. Mortality among those with AKI was 31% compared to 6% for those without AKI. This translated into an adjusted odds ratio of 5.1 for in-hospital mortality. There was a trend toward higher rates of 30-day readmission, but more importantly, among survivors of index hospitalization, rates of 30-day dialysis, including rates of new dialysis, were significantly higher for COVID-19 patients with AKI during the index hospitalization. Index hospitalization length of stay, ICU length of stay, and 30-day readmission length of stay were also significantly higher for those with AKI. We observed in fully adjusted models that COVID-19 patients with AKI had a 1.94 higher relative total hospitalization cost, on average $39,000 for those with AKI, and a 1.74 times higher relative ICU cost, on average $52,000. These results show for the first time the huge impact on healthcare resource utilization and cost of AKI among COVID-19 patients, and it confirms the major impact of AKI on patient outcomes.
Thank you very much, Julien, for this very clear presentation. So you included many patients, but of course, I think that the weakness, the small weakness of your study is the way you diagnose AKI, because it was based on the diagnosis code, so we do not, it is a retrospective study. We cannot control everything. Can you comment about this?
Yeah, indeed. Thank you very much for this question. Because it's a database and retrospective study, we had to make some choices, and we decided to use ICD-10 codes because it was the most easier way to first tackle this issue. But we realized that, of course, we can have underdiagnosis of AKI, in particular for the less severe stages, such as CADIGO stage 1. And of course, it would be really interesting to reproduce such results, trying to have, an assessment of AKI rates by serum creatinine and urine outputs. Of course, urine outputs is difficult to have outside of the ICU, which also limits the assessment when you want to have a study which is hospital-wide.
Thank you. Finally, your results are more or less similar to results we could expect in non-COVID-19 patients, longer lengths of stay, mortality, etc. Okay. This is more or less the same.
Yeah, that's true, and it's probably more related, to the sepsis and to the inflammatory response that we see in these COVID-19 patients. We don't have many data to try to explain if there would be some specific links between COVID-19, SARS-CoV-2 and the kidney, but definitely these show an important message showing, the huge impact and also the huge impact on healthcare resource utilization and cost of AKI. And this hint, of more new dialysis for those that were survivors for the index hospitalization should trigger something in our colleagues to really care about AKI in these patients.
And do you have results on post-ICU period about persistence or not of acute kidney injury?
Yeah, that's one of the results that is interesting, seeing that for those that survived the index hospitalization, we see a significantly higher rates of new dialysis in the 30 days after the index admission at the hospital. So it means that AKI is not just one single event in the hospitalization or in the ICU, and you will have mid and long-term consequences of these events.
Okay, thank you very much.
Thanks a lot, Dr. Textoris.
Thank you for your presentation.
Okay, we move on. I'd like to remind the audience that you can actually interact with us. If you put your question via the live chat function, we will receive it here and we will ask the question. Okay, we will continue with Dr. Eggman, who is a physiotherapist and a neurorehabilitator, and she is from Bern in Switzerland and also works in the Netherlands. And Dr. Eggman will talk about the cardiorespiratory response to early rehabilitation in ICU patients. Dr. Eggman.
Good morning, and thank you for listening to the results of our study. I have no conflict of interests. Guidelines advocate early rehab in critically ill adults. However, the physiological response to exercise is poorly understood. With this secondary analysis of a randomized controlled trial, we aim to determine the cardiorespiratory response to early rehab and to investigate the effect of explanatory variables on physiological changes during training and recovery. We found that there was a large range of variation for cardiorespiratory parameters during both training and recovery, within and across participant session. Clinically relevant changes occurred in approximately 1 out of 4 sessions, despite overall changes not being statistically significant. The key modifiable explanatory training variables were session type,
treatment modality, session duration, and mobilization level. We further found that daily medication, age, gender, body mass index, and the SOFA score on the day of rehab affected physiological changes. Our results are based on 716 rehab sessions from 108 participants with a median age of 67 years and a SOFA score of 8 on the day of therapy. We analyzed a median of 3 sessions per subject using mixed effect models. Sessions had a large range of variation as shown in this graph that illustrates the trajectory of oxygen consumption from before to during and after rehab based on different session types. This table reports the estimated effect on physiological parameters for relevant training variables adjusted for measured values before rehab. For example, for oxygen consumption, we found a decrease of 0.6 milliliters per minute per each additional minute of therapy and an increase by 23 milliliters per minute for active patient participation when compared to passive therapy. In contrast, recovery was mostly affected by session type, whereby mobilization when compared to in-bed exercises led to a significant increase in heart rate of 7 beats per minute in the recovery phase. In summary, our findings indicate that physiological parameters should be closely monitored during and after rehab because individual variation is common, as shown in this example of a 70-year-old performing an active out-of-bed mobilization over 45 minutes. Accordingly, interventions should be individually tailored. The identified explanatory variables could guide decision-making by estimating the physiological response to type, intensity, and duration in advance. Clinicians should consider that shorter sessions and active treatment increase this response, while sufficient time for recovery is particularly necessary after mobilization. Thank you for listening. Do not hesitate to contact me with questions.
Dr. Eggman, thank you for your presentation. Good to see you online. Hi. I think I have a little bit of a difficult question because I always interact with my physiotherapists in my ICU. And, you know, exercising with ICU patients obviously is different than from healthy individuals. So what you show is that actually the parameters don't change that much during exercise. And my question would be, is that good or bad? Should we train more or is it okay?
That's an excellent question, and we don't know the definitive answer about that yet. I think we are still under-training our patients at the moment. The difference is the changes in respiratory parameters we found were not that high, though sometimes they were, as we told in my talk, that they were pretty high. So there's a wide variation. So sometimes we might be overtraining, but I think most of the time we are undertraining our patients at the moment.
Yes, there could be. So, and you are advising us that we should closely monitor all these parameters. So what should we do when we see an increase in heart rate of 6 or 10 or 20? Do you have any advice on that?
So first, I think we shouldn't worry, but we should also monitor patients and ask them, is it still doable for you? How heavy is the load? How fatigued are you? So we need the subjective feelings of the patient as well. And then we need to remember that patients need to recover like every other person. When we've done some sports, we also need to recover. And actually exactly in this recovery phase, it's when the muscles are built. So we need to remember that for our patients as well.
Let's say if we have a little bit of an increase in lactate, do you think would this be bad or not so bad in a patient who is recovering, right? It's out of septic shock, out of the sepsis. Would it be acceptable or not?
So completely stable, you say. Well, we do not measure usually lactate, but of course in sports it also increases slightly. So, but it would be a sign of anaerobic training. So it should not be too long. I would caution against it because we don't know at the moment, but it could be a normal reaction to exercise.
So not too long. What is the optimal duration of exercise in rehabilitating ICU patients?
Well, we found the longer the sessions, the more breaks there were in between. So shorter sessions are likely more higher in intensity, but then again, you can have more breaks over the day. So I would rather recommend to do 20-minute session and then 2 to 3 times a day.
Okay, there's a question coming in here. Did you look at minute ventilation and recovery times? Can you use the parameters to predict fatigue over exercise?
We looked at minute ventilation, and it was actually very well correlated with oxygen consumption. So minute ventilation could be a surrogate measure for oxygen consumption to measure how much oxygen our intervention costs. We did not measure in our study, we did not have enough data for fatigue from patients, so I cannot answer the second part. But I think it is very important to listen to the patients. From qualitative studies, we know that exercise is very exhausting and difficult or challenging for our patients. So we need to go together with them. We need to include them.
There is another question, how long is an average session of exercise in your study?
In my study, I think it was about 20 minutes, around that one, yeah.
Okay, thank you, Dr. Eggman. We move over to the next speaker.
Thank you. The next speaker is Dr. Jonas Tirkkonen from Finland. And the abstract is about National Early Warning Score, the news, and the respiratory component, a prospective 3-center study with many general ward patients, 18,899 general ward patients. So it is a big study. And Dr. Tirkkonen, if you are here, we can listen to your presentation.
Hello everyone, my name is Jonas Tirkkonen from Tampere University Hospital, and thank you for the opportunity to present our data here in ESICMLIV 2021. So, to conclude, the National Early Warning Score has mostly been studied among the emergency department patients and in pre-hospital care, but our results now externally validate that the news has excellent discriminative capability to detect one-day survivors and non-survivors among the general ward patients. And we further found out that among the respiratory and hemodynamic subcomponents of the news, the respiratory rate component score was especially strongly associated with one-day mortality. And our conclusions are based on the following. So we conducted a prospective 3-center study in Tampere, Finland, and including a total of 45 different, very heterogeneous mixed general wards. And the vital signs were captured among the nurses' normal patient care and routine. So it was a very pragmatic design. And the vital signs were the first vital signs measured when the ward admission began. And moreover, we only had to exclude 0.5% of the patients because the vital signs were very comprehensively collected in the 3 centers. So we had a total near 19,000 patients in our cohort. And what we found out that the news ARC for one-day mortality in the general wards was 0.91, so very high. And further, when studying the different subcomponents, we found out that the respiratory rate subcomponent score had an ARC of 0.78, which was statistically significantly much more higher as compared with the other hemodynamic and respiratory subcomponents of the new score. So the take-home message from our study we suggest is that we now externally validated in a very pragmatic, large, 3-center design study the capability of the new score to detect patient deterioration in general wards. And we further want to remind you that pay extra attention to the respiratory rate component of the new score when assessing a potentially critically ill patient in the general wards of the hospital. Thank you very much.
Thank you very much for this presentation. So many patients. There are many studies about the news score, and what is the difference, finally, for your study compared to previous ones, except the number of patients?
Sorry, please come again.
Compared to the previous ones, to previous studies about this.
The previous studies,
yeah.
So yes, basically, so the previous studies have mostly been conducted in emergency department patients, or then in a small sub-cohorts of patients, like 600 septic patients, or etc. So basically, from our point of view, to our knowledge, this is the first study, prospective study, a 3-center study, a multi-center study, including a really large set of different patients with different backgrounds. So we can now validate the new score for a very heterogeneous population of patients among the hospital's general wards.
And you emphasize on the interest of respiratory rate and the change during the stay of the patient. And do you think that it is enough, or we have to measure or to calculate the total score, the entire score?
Yeah, so that's a good question. So to clarify, of course, we have to calculate the whole score as we saw in our study. It's a reliable score when we have like the whole score and all the vital signs components measured and calculated, with them calculated the whole score. But what we saw and what the previous, some studies have shown that the respiratory abnormalities are the most dangerous one in hospitals when the patient deterioration starts. So while we are, of course, calculating the total score, we must really pay attention to the respiratory parameters, and especially the respiratory rate parameters if they are elevated, for example.
You included 3 centers, right? 3 centers in Finland. And did you observe some differences among centers, or more or less the same results?
So basically, the results were constant between the centers. At this stage, we had 1 university-level hospital and then 2 local hospitals. So most of the patients, I think 75% of the patients were from the 1 university hospital, and then the other 1/4 were from the 2 local hospitals, so smaller hospitals, but the results were constant among those subpopulations also.
Okay, thank you very much.
Yes,
thank you
for... from the audience?
Yes.
From Luigi Pisani. Hello, Luigi. You're asking, is respiratory rate sufficient, or oxygenation metrics needed to increase discrimination?
So the new score as whole, it includes the dichotomized parameter, are you receiving supplementary oxygen or not? And then of course the peripheral blood oxygen saturation. And of course, as I said, it's important to measure all the vital signs from the patients routinely, that we capture early on those patients that are deteriorating. But while you are looking at the total score, I suggest that we should pay extra attention to the respiratory rate, at least when we are in the mildly elevated scores, like 4 to 5 or 6. Because that way we can maybe earlier capture those patients that are going to really feel unwell.
I agree. Congratulations with your work. We're moving to the last video of this session, which is by Dr. Effat from Cairo, Egypt. And we will watch his video about fluid management in ICU patients with acute kidney injury and the role of non-invasive assessment of stroke volume.
Welcome everybody. I would like to share with you this study about fluid management in critically ill patients with acute kidney injury, role of non-invasive assessment of stroke volume. Statistics tell us that 50% of patients treated in the intensive care unit developed acute kidney injury. In many cases due to generalized infection or sepsis. Assessment of volume status is in critically ill patients, especially with acute kidney injury, is challenging and crucial. Though central venous pressure CVP is not accurate tool to assess volume status is still widely used. The present study was intended to investigate and compare the use of CVP over delta CVP group A versus stroke volume variation detected by transthoracic echocardiography group B in guiding fluid therapy in both patients. The study shows that fluid balance was statistically significant more positive in group A. In group A, more patients need mechanical ventilation with less number of patients successfully with both with statistically significant p-value, and there was a statistically difference between the two groups more in group A regarding length of stay in mechanical ventilation. The study shows a statistically significant p-value between the two groups regarding mortality rate, which was higher in group A. Fluid administration serves no useful purpose in those patients whose stroke volume fails to increase. Following a fluid challenge, they are non-responders, and many prove to be harmful by causing volume overload. In clinical practice, a fluid responder is generally defined as someone who increases their stroke volume by 15% after 500 mol of fluid challenge. Knowing that only 50% of hemodynamically unstable patients in ICU are volume responders, a technique to determine fluid responsiveness with a high degree of accuracy named passive flag raising maneuver, sometimes called virtual fluid challenge, in our virtual world of today has evolved, in which a volume around 300 mol of venous blood is transferred from the lower body toward the right heart. Passive flag raising mimic a fluid challenge without giving a drop of fluid. Echocardiography is an evidence-based approach ideally suited to address, predict fluid responsiveness and stroke volume variation. Measurement of stroke volume is relatively simple with echocardiography. Stroke volume variation can be determined by a technique based on heart-lung interaction during mechanical ventilation. Stroke volume variation more than 12% accurately predicts fluid responsiveness with values over 14% having positive predictive value, and less than 10 is a highly negative predictor of fluid responder. In conclusion, fluids is a drug, and before giving any drug to any critically ill patient must be based on solid facts. And in this study, it was clear to us that passive leg raising and real fluid challenge induced stroke volume variation in guiding fluid responsiveness is much better for those patients and easily determined by non-invasive echocardiography, and this is reflected on morbidity and mortality in those.
Thank you very much. Unfortunately, Dr. Effat is not here with us to answer questions, so we'll close this best oral presentation session, and it was a very nice session, and I hope that you enjoy this session. Thank you very much.
Thank you. Bye-bye.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community. Hello everyone, and hello Eli.
Good morning everyone.
How are you?
I'm perfect.
So Eli, we're going to spend a few minutes together, and I was having some reflections actually about the opening yesterday, and it's been great finally to connect again with the members and with everyone about intensive care. But if there is something that really still gives me goosebumps thinking about it, it was the testimonies from the patients and families.
There's a very important word about it, which is the qualitative research that Judy Nelson from the Memorial Sloan Kettering says. You should listen to patients and family members in their own words. And I think that it was very qualitative, and we learned from the patients and the family members a lot of things. I remember a lot of things that said the patient from Italy, from your ICU, about buying a car when he was in the ICU. So these delusional memories. So we give words, we give medical words on ICU experiences, and this is how we can understand, for example, that we should reduce benzo, or maybe have rehab strategies that take into account that. And this is very important to reconnect.
It's very important also because sometimes if we are so busy with our work that we have this disconnect of not thinking how the perception of our patients is there, and the perception in this moment for them is reality. So
it is reality. Importantly, I think that it nourishes how we should be and behave at the bedside, but also about research, because this is how we have and we can identify targets for improving the practices, and we are committed to change the practices at the bedside. And this is why all these testimonies are very important for us, not only to listen, but also to think of, and maybe in all our ICUs to debrief on, to identify how we can improve the way we speak and we communicate with family members.
Yeah, and especially this pandemic has been very challenging for that, because it, at least during the first wave, it put us back 25, 30 years, not having families at the bedside. I personally remember that as the most stressful thing for my team. You know, everyone was looking at intubations and proning on the media, but actually if you ask every one of us, of course, on top of the extra work, it was actually this fact that we didn't have the same amount of family time at the bedside.
Yeah, this is true. We have the feeling that it's new, but actually in the nursing literature, the importance of family members, which is obvious for us, that it's good for family members, for the patients, but this importance for the healthcare providers, the way it allows them to have normal patient-physician relationship is not something new, but it's good that we can go to that again and understand how important it is for the nurses. There's a very nursing concept that is called moral distress that is quite different from burnout or from other symptoms in healthcare providers. And I think that not having the family members actually causes moral distress to ICU nurses, and we are here to address this very specifically.
It was causing a lot, I think, of moral distress, of moral injuries. When we all share these experiences, but I remember speaking with some of my nurses during the peak, and you know, the stressful part was actually saying, I don't have the time to shave my patient today, or I don't have the time to take care of the nails as I normally do. And you know, that level of quality that you provide normally, and you cannot in that moment, is being very, very difficult.
It's very likely that these qualitative aspects also translate into outcomes.
Yeah.
Maybe length of stay, maybe ICU acquired events, and maybe survival. And I think we need to work on that.
Yeah, I think you're absolutely right. Ellie, you've done research in this field for forever, I would say.
Not forever.
But now we're doing some research together with ESIP. Can you maybe summarize what are the key research questions that we can help answering with our community?
I think that the key research question is learning from variability. We know that inside one ICU, not every doctor and every nurses do the same, but between two different ICUs in the same country, it's different. Between two countries, it's different. Between all of our countries, but we should not say, oh, it's different, we should learn from each other. There is plenty of what you do in your ICU that I need to take to mind, and certainly the opposite way. So we just want to understand variability and to see how it can translate into improving the global management. This is observational. So there is now a study that is called ESICM Family 1, because it's the first one, that is observational. It's a survey, and the link is available on the ESICM website, where everyone can go and complete a survey to teach us about practices. From this, we will then go to ESICM Family 2 in 2022 to go more into the bedside. So what is performed at the bedside, which is not intentional. It's not something that you complete. It is what is the real situation, relationship between nurses and doctors, nurses and patients and family members, consultants, everyone. And hopefully, based on these results, later on, we will do the ESICM Family 3, with a very simple, we discussed a lot together, Maurizio, on this, a very simple intervention that could be performed everywhere and improve the practices by doing things very simple. I'm sure you're going to ask me, like saying hello. I'm sure that if we were saying hello to everyone in the ICU, if we were saying hello to each other, of course, to each other, doctors and nurses, healthcare providers, and every allied professional, but also take time to say hello to the patients. Let's take an example. If I had a very long discussion on Tuesday with a family member, maybe hello would be enough on Wednesday, and unless they have questions. I think that the hello is one of the interventions.
It's very interesting. We've always been fascinated by your research, but also now we practice at the bedside because, you know, we learn so much technical skills about intubation, putting a chest drain, doing a tracheostomy, and we focus on that part, which of course is a very important part of what we do. The reality, when you're proficient in it, it probably takes 5-10 minutes to do that. But actually communication to do it properly with families, even when you become proficient, maybe you will spend even more time sometimes because you realize the value. And that's not just being nice to patients, I think it's really part of clinical care.
Yeah, certainly more time for family information that takes 30 minutes per day in average than for intubation, that is much faster. But ESICM has always considered family communication, family outcomes, patients' comfort and satisfaction as plain and major outcomes. So I think that we are in line with the philosophy of ESICM. We are just now putting research into the hope that we are going to improve the practice at the bedside.
I'm very proud of what we're doing with that, and I'm sure that all members that will help us by joining this research, the more the better. So we really need every unit to be on this. On top of research, we've done another project this year, which is actually building up this resource page, which is the first time we have actually something in our portal. And again, I invite everyone to go to our website, and you will find now a patient and family resource page where actually you can use it to explain to maybe patients or even to families that are coming to the intensive care what an intensive care is. We focus so much on technical terms, but they're very scary for people, and sometimes it's very difficult to understand the difference between a tube or a nasogastric tube. A lot of confusion there, and we hope that this can help really at the bedside, helping with that communication as well.
I think that there is a very important catchword there. If we go to the website, we are going to see the family page, and there is a video, and there is diversity in this video. And for family members in my ICU, they are themselves very diverse. We live in a normal country where people come from everywhere, and they are very interested by seeing that other people from other countries that are maybe their own culture, languages, etc. Even the subtitles can help, but only seeing faces, mimics that are close to them is something very important. We are diverse, and we are serving a diverse population, diverse community of family members and of patients, of course.
Yeah, no, I completely agree with you. Another thing that I wanted to discuss with you today is, of course, patients and families really been the focus of our opening, the focus of a lot of activities this year, but there are also our members and the intensive care community. And at the bedside, what we are doing and what we're trying to do as a society now is to provide more and more practical tools, from guidelines and airspace, for instance, which is this new application that we are developing to help. And we always have this phrase with Jan de Waal that has been coordinating with me and a group of experts this development. We want to help somebody at 3 o'clock at night when you're alone in the intensive care trying to diagnose and what to do with a severe infection.
This is true, and even when you are not alone and it's not 3 in the morning, I think that using this, and I think that ESICM has really done something important, and Jan should be commended for having led this work. I believe that to de-escalate, to apply concept of antibiotic stewardship that purely translate into patient outcome, is very important that together with the residents, with the entire multi-professional team, we can look at that, and we also have the references. We can decide to go to the journal club and read 2 or 3 papers that are really in relation with the patient situation. I think it's an important tool that guides also the academics.
It's important also because we're all busy. We cannot be experts in everything, and even when you are president or president-elect of the society, society, you have to rely on other people digesting the information and bringing that information at the bedside. And that's why another very important project that we started this year was actually having the guideline group and developing more and more guidelines. One will be released in these days at LICE, which is the ultrasound in intensive care, talking about ultrasound. But of course, guidelines are going to be a very important part of what the society offers to the intensive care community.
And very importantly, I was fascinated by how this group of experts who have impressive track records of publications were dedicated, devoted their time to the society, making the brand of ESICM very obvious, because this is ESICM products, but made by experts who are giving all their time. And I'm really thankful for all these people who are spending time to guide the practices, because we know that these guidelines are actually very much read. They are also very much consulted for specific situations. So we are going to improve also how the delivery of critical care at the bedside, which is one of the major goals of ESICM.
It is, and it is very important that I think we help people, as we said, because there is so much information and it's impossible for anyone now to be up to speed with this. And we have other ones that are on the pipeline: fluid management in intensive care, ARDS treatment, antibiotics, just to name a few. What do you think we should do next? What do you think should be something that our members are asking, or the intensive care community is asking?
Well, you are giving me an opportunity maybe to say to the members that they are very free to come to us and make suggestions, because we are very much listening to that. I think there is plenty to do. Guidelines is important because it provides a high level of evidence. We are also able to adjust guidelines from year to year when a new paper comes and may provide some controversial issues. I think that next is one thing that is very important is also how we can continue to change and improve the practices at the bedside. Maybe by improving communication, should we do guidelines on that, or maybe by thinking on other aspects and the fields of critical care to improve at the bedside?
Yes, and without forgetting that we are a global intensive care community, and we are also very happy that we have a global intensive care group, which I remind everyone is not about teaching in low and middle income countries what to do, is about creating a network to learn from each other and to decide how to globally intensive care standards can rise. And we're very happy that we're also working on that side of things. We did, for instance, the Alive course on COVID. Thousands of people register for that. And I think we have to be more and more open also to listen to those parts of the world, because we're becoming more and more an international society.
I absolutely agree, Mauricio. And the COVID is typically the opportunity to understand that not only we learn a lot from each other, but the only way to go forward and forget COVID is that the entire world has to implement the best strategies, of course vaccination, because we know that ESICM has promoted the vaccine much more than anyone else, but also everything that provides a high level of evidence at the bedside for COVID-19 is also the true opportunity to learn that we can learn from every country, but we will get out of this only if it's a global method.
Completely, and I think we just have a few seconds left, and you remind me that people are watching us not just on our platform, but actually everywhere on our social media channels. And really, what you said about vaccinations for us is very important. We need to work, really, everyone, scientific societies, everyone that has a possible voice to ask for global vaccinations. It's the only way out of the pandemic. It's not fair that healthcare workers in low middle income countries and the population do not have the same access that we have to vaccines. So it really is going to be our plea. You will hear more from us on this, so we all have to be together on this.
Together we are intensive care. I just want to thank you, Mauricio, because you taught us that an ICU bed is not a furniture. An ICU bed is an environment with human people, human resources, as well as technical resources.
Well, a ventilator is not an ICU bed, but I think we've learned that with each other and with the teams and patients and families. Bye-bye, everyone.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Because your patients can't wait. Because your mission is to buy time and save lives, we are here. To face emergency, we have adapted our manufacturing facilities and increased our production capacities. We are here to support you, offering access all around the world to the latest articles and sharing recommendations from the most experienced experts. Assisting the ICU community on how to manage critical patients is always our priority. Aspen delivers more than anesthetic products. It is because you are there for your patients that we are here for you.
Innovation drives breakthroughs in healthcare every day the world over. Thankfully so, because as the world urbanizes and ages, and as lifestyle disease grows at serious rates, the need for healthcare innovations that support quality of life has never been greater. This kind of life-changing innovation is what we live for here at Fisher & Paykel Healthcare. We're invested in problem-solving that changes clinical practice for the better, reduces healthcare costs, and ensures better patient outcomes. There are two words that mean everything to us: care and design. We care passionately about improving lives. Care focuses and inspires our people to put patients first, to purposefully keep innovating and simplifying until we create an original solution that answers a human need. Design enables our researchers, scientists, engineers, and designers to apply their inherent curiosity and desire to do meaningful work.
One big hello, dear friends, dear colleagues. It is my honor and my pleasure today to be with my friend Maurizio Cecconi, the president of the European Society of Intensive Care Medicine from Milan, Humanitas Research Hospital and Humanitas University. We have been now almost 1.5 years and even more with COVID-19 situation, with the pandemic. And Maurizio will just, in the coming minutes, will take us back to the very first days of the pandemics and bring it all the way to today and explain the leadership during the pandemics. Maurizio, take
Hi, Joseph, and hello, everyone. And indeed, I think it's the story of our society. I will take a few minutes just to go through our story. And if I think about the date, I remember the date very well. It was the 20th of February 2020 that a patient tested positive for a coronavirus in Italy. If you remember, up to that moment, everyone was looking at what was happening in China, but that moment for us was really the crisis was starting. It was a secondary transmission. It meant that a lot of infections were in the community, probably undetected. And I remember during the very first night, I gave a call actually to Joseph, saying, look, something is happening exactly where I work, in the region where I work, and we're collecting data. This is much faster than what everyone else was expecting. I remember we were talking with colleagues from America just a few weeks before and meeting with people. Everyone was looking at how to get ready in case the pandemic was coming to our countries. The reality, I can tell you, I think we were not prepared and no one was really prepared. The exponential rise is something everyone has seen. But during those days, it was something very new. And I remember vividly when we were speaking to each other, still a lot of fake news, a lot of even colleagues on media, maybe from other specialties, saying, you know, this is just a normal flu, it will not be a problem. And that's usually what you see in crisis. When a new crisis comes out, the classic reaction of leaders is actually to downplay the threat. You think, maybe let's wait for more data, maybe this is just an unusual cluster in Lombardy. But the reality is that rather than downplaying the data and downplay the threat, we thought we have a duty to share whatever is happening here. Because in case this is real, and we knew later, just a few weeks later, this was real, communicating with transparency, showing what was happening there, was really crucial to give hours and maybe days or weeks of preparation to other parts of Europe and the world. So together with Joseph, we spoke and we said we need to go out with this information. Even if the media, they still give very confusing information, our role as a scientific society is to pass this information. We need to filter it and go out there in our network. So you may remember this letter. It was sent by Joseph on the 5th of March 2020. It was a letter from me, Giacomo Grasselli and Antonio Pesenti, basically stating very briefly but in a clear way what was the first 10 days of the pandemic and our learning there. That letter went around the world. It was picked up by news outlets and probably started the beginning of how we wanted to give information as a society. So it was basically a get ready. This is real, get ready, because if you're not ready when the pandemic comes, you may be even more unprepared and maybe find it even more difficult to save lives that you can. Our role, I think, at that moment was to completely change what we were doing as a society. It was the days, if you remember, where suddenly all the meetings were stopped and a lot of activities were paused. But I think what I am proud of having been part of the society during those times is that with Joseph, the office, and I would say the leadership of ESIC in general, we said we need to provide our services for the global community. So we decided to open all our streams of information with platforms, even without memberships, and started to develop webinars on the first week of the pandemic. Initially with speakers from China. You may remember this marathon where we connected people from everywhere in the world. We had more than 130,000 clinicians connecting during those days, and since then, basically, we have completely changed the way we are trying to connect with the rest of the world. We will go back to face-to-face meetings, but we've learned so much from these, and now we can stay together as a global intensive care community that I think it will be a learning that we keep with us. Our contribution was also trying to help bedside clinicians also try to understand that this is not just an issue about ventilators and drugs, and we had to explain institutions, governments, that this was exactly the case. Just buying ventilators and CPAP machines would have not been enough. It was about creating a system of psychological safety where healthcare workers that often not working regularly in intensive care were deployed to intensive care teams to help during a surge could work in the safest way as possible. And during those days, a very important partner, a very important institution for us was the European Commission in Europe. We were very happy that they came to us asking for help, and again the first questions were which drug shall we store, which ventilator shall we buy in case there is a second wave. Our answer was very simple: you can buy this, but this will not solve the problem. The biggest problem is going to be that we are not going to have time to train specialists just in a few weeks. It's impossible. But what we can do, we can provide some education and some training to people not working regularly in intensive care. And this is the background of probably the largest ever done training in a sanitary crisis, which is Synenting Space. I have a short video before we can go and talk a little bit more about this.
Suggestion. The CAM ICU Scotland with the facial mask is the system that we use.
Okay, I think the video stopped there, but it doesn't matter because the training is finished by now.
Okay, Maurizio, thank you very much for this presentation. And if I remember those days, we also had a very short period of hesitation, but somehow we were able to take very quick action, and and were able to change the whole way of thinking. I think this is one of the most important issues. So can you comment?
Absolutely, I think is that's where I think we will be proud to tell our story in 20 years, is how the society got together as a community, reacting, but not just reacting, proactively change completely the way we wanted to, to go on this challenge of the pandemic. So it was not just creating one webinar, it was actually putting completely our services for the global community, sharing the information which was not out there at the time, even with the risk of being considered someone that was saying something against what was given by some other news outlets. I think we demonstrated that that was the right thing to do. But importantly, also focusing on people. Everyone was focusing on machines, on personal protective equipment, and I think our motto was really from the beginning that a ventilator is not an ICU bed. We need to help healthcare workers, we need to help to understand that this is going to be a crisis about the healthcare workforce, not just about devices.
Yes. And I think it's a very well-known situation that although it is a sad happening for the last 18 months, but COVID-19 helped for the intensive care to be known by the whole world, actually. I remember if I took a taxi from my university in Utrecht to the center of the city, people knew that I was working there, but they didn't know what intensive care was. But I think what could be done at that moment was not only intensive care, but also the Society of Intensive Care Medicine, our European society, has been moving to the political areas as well for the benefit of the intensive care.
Yeah, absolutely. And indeed, I have to say, we spend a lot of time going out of the walls of the intensive care, a little bit like what we do in our intensive care units, which we spend a lot of time working outside the intensive care unit, and we still do intensive care there with our outreach. We went on an outreach with institutions. We said, we are here, we have a large network of people that want to help, we have a lot of knowledge that we want to share, we are at your service to understand how to evolve and how to move forward. And indeed, with the European institutions particularly, but we collaborated also with the WHO that came to several of our meetings, and also in low-middle income countries with programs and education that we did there. We really wanted to provide our service ultimately to grow intensive care for the future, because you're absolutely right. People didn't know what intensive care was. I think my parents suddenly realized what I do for a living. And everyone was very much amazed about patients that were prone and intubation, but actually that's our daily business.
Yeah.
And what was different in the pandemic was the amount of patients that were coming at once.
Yeah, and of course we also perhaps can touch a little bit to the impact that this made to our medical and nursing personnel, especially the nursing personnel. We asked from them so much normally, and now we were asking even more and also pushing them to the field where they were not used to operate that way. And I think it was very important that most of us have explained that these are not normal times, and we have to change our modus to adjust ourselves, because if you don't do it, then nobody has a chance. With this, at least we gave a fair chance to all of our patients.
Completely, and I think you and I, we were discussing a lot on the phone how to speak with our teams, also to reassure them that this is the right thing to do at the moment. But when you have so many more patients with the same staff, basically, it's impossible to provide the same quality.
Yeah.
And I think it's very important, we talk about leadership today, that leaders take the responsibility to be very clear about the common goals that you have in this crisis, and even to say, look, the quality that we may provide now is different. It may not feel the same one that you were providing before. It's about saving an extra life, and that's real quality in this time. If you don't do that, you may cause stress, moral distress, moral injury to the team.
The moral injury indeed, and I must also stress one more point, that you remember we were worried a lot about the financial situation of the society when the crisis began. All the activities had to be cancelled, there were money being paid to the congresses which didn't occur, and at the end we have managed it in such a way that society didn't lose money. Society was also having a very healthy, positive financial balance at the end of the year.
Yes, keeping in mind that the role of a society is not to make profit, because we are a not-for-profit organization, but is to be sustainable. But with being sustainable, increasing the activity activities, and I think that's something that we're very proud. And I have to
changing it, the format.
And I have to say, I really would like to thank again the office of our society, the executive committee, all sections, committees, educations, and the social media and so on. I really don't want to forget about anyone, but everyone got together in working in a completely different way to increase the activities that we were doing, and we were able to do it, as you said, in a sustainable way.
In the last minute of our presentation, maybe we can try to look a little bit to the future. Maybe you can give a little bit of comments. How do we see the future? Do we have a future? I'm sure we have a future, but how will they?
Well, we need to adapt to the situation. I have to say thanks also to citizens uptaking the vaccinations and adhering to public health measures. I would say we're in a different situation now than a year and a half ago. Even if we have to do more at global level for vaccination, we will not stop talking about this. But the society is ready now to go to the next phase of the pandemic, so we will have more face-to-face meetings. But don't worry, we will not forget the good learning that we had about these formats, virtual, hybrid formats. We have access people that we would not access normally with face-to-face events. So we will resume face-to-face events. It's important, you know, the emotions are not just on Zoom. We need to get together again and have a coffee together, but we will also use what we've learned about virtual presence to be connected with the rest of the world.
Thank you very much, Maurizio. Thank you, Mr. President, and it was a big joy to have this session with you.
Thank you, Joseph. It was great to have you as president last year.
Thank you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community. Hello again, everyone. I am very excited about starting this session together with my friend and President-elect of the Society, Eli Azoulay. Hi, Eli. And it's a very important moment because we are about to release the guidelines of the Surviving Sepsis campaign. This is a very important project in partnership between the European Society of Intensive Care Medicine and the Society of Critical Care Medicine, also with representations of many other societies and groups. It's a massive task with a lot of experts, and it would not be possible without the leadership of the co-chairs of the guideline that are going to be with us for the next 45 minutes. So it's a great pleasure to welcome Dr. Laura Evans and Professor Andrew Rhodes. I know that Laura will give the first presentation. Laura is a professor of medicine at the University of Washington and the medical director of critical care at the University of Washington Medical Center. She's the co-chair of the Surviving Sepsis Campaign Adult Sepsis Guidelines. The Surviving Sepsis Campaign COVID Management Guidelines is on the SCCM Council. Welcome, Laura. And we also have Professor Andrew Rhodes that will be with us for the question. And is a consultant and professor in intensive care medicine and anesthesia at St. George's Hospital, one of my mentors. We worked together for many years. He has research interest in the fields of surgery, sepsis, hemodynamics and outcomes related to perioperative and intensive care medicine. He's widely published in this area and is regularly invited to lecture on this subject all around the world. Andy has held leadership roles at national and international level. He's an elected council member of the Faculty of Intensive Care Medicine, a past president of the European Society of Intensive Care Medicine, and of course also the ESIC co-chair of the adult guidelines. So welcome both, and everyone is waiting for your presentation, Laura.
Hi, I'm Laura Evans from the University of Washington, and it's my distinct pleasure to be here on behalf of the Surviving Sepsis Campaign Adult Sepsis Guidelines panel to present just some highlights from our brand new release of the 2021 update of the International Guidelines for the Management of Sepsis and Septic Shock. I don't have any financial conflicts of interest to disclose, but I did want to just note that I'm the co-chair of the Adult Surviving Sepsis Campaign Guidelines, a member of the SSC Steering Committee, co-chair of the SSC COVID-19 Management Guidelines, and a member of the US NIH COVID-19 Management Guidelines. Before I get into the guidelines development process and recommendations, I want to take this opportunity to gratefully acknowledge the support of ESICM and SCCM, the two sponsoring societies of the Surviving Sepsis Campaign, and also acknowledge and thank all the participating societies and their representatives to the guidelines panel, the vice chairs, the group leads, the methodologists, as well as all of the panelists for their hours of tireless work on this guideline and bringing it to fruition. I want to recognize our public members for their incredibly valuable contributions. And lastly, I want to specifically recognize Ms. Lori Harmon and Ms. Julie Hyam for their invaluable support in helping us produce this guideline. Without them, we could not have done this. Many of you will remember that the Surviving Sepsis Campaign was started nearly 20 years ago now in 2002 with a declaration from ESICM, SCCM, and the International Sepsis Forum to participate in international quality improvement to try to reduce mortality from sepsis. We are now on the 5th revision of the adult guidelines. It happens on about an every 4-year cycle from 2004 until this most recent release in 2021. The guideline development process is rigorous, and this is why it takes a long time to do these big guideline updates. So we start with constituting the panel, which is identifying members from different realms of expertise, different geographic areas, reviewing their potential conflicts of interest, getting all of our participating societies and their representatives together. Once we have the panel constituted, we begin an evaluation of the evidence. This time we started with a survey of current practice, and we'll go into that in a little bit more detail in a subsequent slide, and develop PICO questions, prioritize outcomes, do a systematic literature search, use existing systematic reviews when they are present and they're high quality, or we conduct our own when we need to. We develop evidence profiles and grade the evidence, which then leads us into the phase of developing recommendations. Again, the framework of this, which maybe should be even further up in the guidelines process, is about rigorous management of potential conflicts of interest. We used a transparent evidence to decision framework to grade and draft the recommendations. The panel then voted on the recommendations and came to consensus agreement. Manuscript was then drafted and has gone through peer review by both all of our participating societies as well as at the journal level. Manuscript is now going to be published officially, which we're delighted about, and we hope that the findings will be disseminated, and we'll be working on implementation tools to help implement the recommendations. I want to highlight who's on the Surviving Sepsis Campaign guidelines panel, the adult guidelines panel. We have 53 subject matter experts who are composed of both at-large subject matter experts as well as 24 professional society representatives, 7 methodologists, and 6 members of the public on this revision. You can see the gender balance there. Men are still outnumber women on the guidelines panel, but I think compared to prior revisions, we are making some progress there. And we have representation from every continent in the world with the exception of Antarctica. So overall, we are moving to a more diverse guidelines panel. This lists all of our participating panelists and methodologists on that. And I'm not, obviously can't read them all or recognize them all by name, but I do want to thank everyone for their participation in this and bringing this guideline to its conclusion. Our Conflict of Interest Subcommittee was co-chaired by Dr. Massimo Antonelli and Dr. Craig Cooper-Smith, who reviewed all potential conflicts of interest and decided on management plans when necessary to help manage potential conflicts of interest. We did not permit direct financial or industry-related COI and asked those with potential intellectual COI, for example, those leading clinical trials relevant to a recommendation, they were not allowed to vote on recommendations where they had a potential conflict of interest. This was a new development with this revision of the guidelines where we did a formal process to prioritize our PICO questions. We used a systematic approach that incorporated 3 real elements: 1 of practice variability, 2 of expert input, and 3 of the assessment of an evidence gap. And then we determined practice variability based on an international survey that we conducted of about 800 ICU providers that gave us a sense of where practice may vary internationally. And it would be interesting to be able to discuss that in more depth. We don't have time today to do that as well, but there's quite a bit of practice variability, which would probably surprise nobody. We then incorporated panel members' assessments of the question's importance, that's that expert input component, and looked at previous iterations of the guidelines and whether a question was included and whether the evidence gap still persisted. The final decision about PICO questions was achieved by discussion and consensus between panelists and the SSC leadership to come up with our final list. So in the terms of the approach to the 2021 guidelines, what's different about it this time? Well, we had greater emphasis on panel diversity, including gender diversity, geographic diversity, and economic diversity. We did, again, formally select questions based on part of this evaluation of practice and uncertainty and clinical equipoise. We added several PICO questions that you'll see about long-term outcomes after sepsis. This was really important to the panel that we start to include not just what happens to patients in the hospital, but what happens to patients after they leave the hospital. And for the first time, we used a formal evidence to decision framework as a transparent and structured system for formulating recommendations. So with that, I'm going to move into some of the recommendations here. Again, it's a very short presentation today. So I'm really just going to focus on sort of like 1 recommendation from each of our guidelines groups and highlight those recommendations that are either new to this revision or changed significantly from the last revision. Again, there are many more recommendations that we don't have time to go over in depth today, but I encourage you to go to the website and the publication to get more detail on all of those. So let me start here with the first recommendation for discussion today, which is about screening for sepsis. And this was a new PICO question. We did not ask this in 2016. We just asked this for the first time in this guideline revision. And the question is, in acutely ill patients who should we use QSOFA criteria to screen for the presence of sepsis? We ended up issuing a strong recommendation based on moderate quality of evidence that says we recommend against using QSOFA compared with SIRS, NEWS, or MUSE as a single screening tool for sepsis or septic shock. And I want to highlight that as a single screening tool for sepsis or septic shock. We didn't ask, as part of the PICO question, does QSOFA have a role as part of another screening process, but using QSOFA alone to screen for sepsis, we recommend against that. So here, for example, is one of these high-quality systematic reviews that we used to inform this recommendation. And this systematic review looked at both mortality and sepsis and the comparison of QSOFA with SIRS for the diagnosis of sepsis. And you can see that QSOFA, perhaps unsurprisingly, outperformed SIRS with prediction of mortality, but SIRS outperformed QSOFA, at least in these meta-analysis, with regards to the diagnosis of sepsis. So when the panel came together to discuss these findings and to formulate the recommendation, the panel's consideration was weighted that when we're talking about a screening test, what are the consequences of a false negative, or in this case, what is the consequence of missing a diagnosis of sepsis in a patient? And the panel weighted pretty heavily that the consequence to the patient of potentially missing a diagnosis of sepsis can be very high. And thus, we issued a strong recommendation based on low quality of evidence against using QSOFA as a sole screening tool for sepsis. Next up, I want to talk a little bit about our recommendation around initial resuscitation. So our PICO question here was in patients with known or suspected infection and hypotension and or an elevated lactate, should we administer 30 milliliters per kilogram body weight of crystalloids or a rapid small volume fluid challenge and reassess? We concluded for patients with sepsis-induced hypoperfusion or septic shock, we suggest that at least 30 milliliters per kilogram of IV crystalloid fluid should be given within the first 3 hours of resuscitation. And that in the 2021 guideline is a weak recommendation based on low quality of evidence. The change from 2016 is that's been downgraded from a strong recommendation based on low quality of evidence. So again, what informed this discussion? And for this, I'm going to use the opportunity to show you a little bit of what the evidence decision tool looks like so you can see the considerations that the panel took into account when formulating this recommendation. So these are some of the studies that, including multiple high-quality systematic reviews that inform this recommendation. And of course, we also used the patient-level meta-analysis from the Process, Arise, and Promise trials that you'll remember. The median volume administered in these 3 trials on the patient-level meta-analysis was about 27.5 milliliters per kilogram. So certainly around 30 milliliters per kilogram was common practice, including in these large multi-center international randomized controlled trials. When the panel took all of this data, sum total, and puts it into this evidence to decision framework, to be explicit about the judgment that we're making, you're looking at how you weight all of these different things. So is the issue a problem? Yes. What are the desirable effects of the intervention? What are the desirable, undesirable effects of an intervention? How certain are we in the evidence? What is the balance of effects? What are the resources required? And so on. So there are many factors that go into this from that. And the panel has to be explicit about the choices that they're making. Using this tool, on the summary of judgments here, the panel arrived at a conditional recommendation for the intervention. Again, so a weak recommendation for 30 milliliters per kilogram of crystalloid fluid given for patients who are hypotensive or have sepsis-induced hypoperfusion. Next up, we'll go right into the timing of initiation of antimicrobials. And these recommendations are slightly different from our previous guideline recommendation. And I want to call your attention to this figure here, which is available within the guideline publication. And so the timing around the antimicrobial administration now really tries to take into account 2 elements. It tries to take into account how sick a patient is and manifest as shock is present or shock is absent, and how likely the diagnosis of sepsis is, with this idea that the sicker a patient is and the more likely that the patient has sepsis, obviously the more clear it is to give antimicrobials immediately. And then as the diagnosis of sepsis is either less likely or the patient is less sick, your time window may get a little bit longer from that. So the recommendations around this were for adults with possible septic shock or a high likelihood of sepsis. So patients who are quite sick, who might have sepsis, or patients who have high likelihood of sepsis, we recommend administering antimicrobials immediately, ideally within 1 hour. And it's a strong recommendation based on low quality of evidence for shock and very low quality of evidence for sepsis without shock. Then, for this other group, for patients or adults with possible sepsis without shock, we suggest a time-limited course of rapid investigation, and if concern for infection persists, so if you haven't ruled out infection very quickly, give it administering antimicrobials within 3 hours from the time sepsis was recognized. And that's a weak recommendation based on low quality of evidence. We also looked at the really important question of liberal or restrictive fluid strategies. So in patients with sepsis and septic shock, should we use a restrictive fluid management strategy in the first 24 hours of resuscitation? And to jump to the conclusion, the panel issued no recommendation. We said there's insufficient evidence to make a recommendation on the use of restrictive versus liberal fluid strategies in the first 24 hours of resuscitation for patients with sepsis and septic shock who still have signs of hypoperfusion volume depletion after the initial resuscitation. And let's go, and that's a new PICO question for this. There's no change from the 2016 recommendation because we didn't look at that particular question in 2016 guidelines. So let's look at the data that inform this a little bit. There were multiple outcomes considered as part of our assessment around this recommendation. The outcomes that we looked at were mortality, renal replacement therapy, cardiovascular organ dysfunction, respiratory organ dysfunction, or new hemodialysis. And what you can see from this is, at least if you take the mortality piece of our evidence table here, there were 5 randomized trials that used a fluid restrictive versus non-restrictive fluid strategy. And trials admittedly did just define these strategies somewhat differently. So the comparison was not necessarily straightforward. Different trials define these approaches somewhat differently. But when you look at the mortality outcome for this, you can see that the relative risk of mortality for a restrictive fluid strategy compared to a non-restrictive fluid strategy was 0.98 with a confidence interval that clearly spanned 1. And you can see as you go down that column that the confidence interval for each of these outcomes of new onset organ dysfunctions also spans 1 when using a restrictive versus a non-restrictive fluid strategy. The panel had a lot of debate as to whether to say that we could demonstrate equivalency, which would mean essentially making a recommendation that you can use either, that we know that they are the same, versus saying we think there's insufficient evidence to make a recommendation. And the panel, after much consideration, the consensus of the panel was that there's insufficient evidence to make a recommendation about fluid restrictive versus fluid liberal fluid strategies after initial resuscitation. Moving on to our ventilation section, we had a new PICO question in this section as well. And that PICO question was, in adults with sepsis-induced hypoxemic respiratory failure, should we use high-flow nasal oxygen compared to non-invasive ventilation? And the panel concluded that for adults with sepsis-induced hypoxemic respiratory failure, we suggest the use of high-flow nasal oxygen over non-invasive ventilation. That's a weak recommendation based on low quality of evidence, and again, is a new recommendation to the 2021 guidelines. The evidence profile you'll see here includes just one study. The evidence profile is based on the single randomized controlled trial, the Flora-Lee trial, looking at this particular outcome from that. And that's part of the reason, even though the effect is marked, part of the reason that the panel issued a weak recommendation based on low quality of evidence is because it still is a single trial. So that may be something that changes over time or becomes reinforced with additional evidence. We also looked at the vitamin C question. So the PICO question for vitamin C was, in adults with sepsis and septic shock, should we use IV vitamin C? And we concluded for adults with sepsis or septic shock, we suggest against using IV vitamin C. And so it's a weak recommendation based on low quality of evidence, and again, is a new recommendation for this guideline revision. Here we see the evidence profile for the vitamin C recommendation. The asterisk in the title of the slide is there because I wanted to note that the Victus trial was published after the conclusion of the literature review period for these guidelines, so we did not include data from the Victus trial in this evidence profile. We did, however, have mortality data from 7 randomized controlled trials that were downgraded for inconsistency and imprecision, and that had a relative risk of mortality that spanned 1. There was no significant difference in organ failure, and a risk of vasopressor use that clearly spanned 1 with a point estimate of increased vasopressor use. And that, based on the sum total of the evidence, the panel issued a weak recommendation against vitamin C based on low quality of evidence. I mentioned earlier that one of the key elements that came up with the panel as we were scoping out the PICO questions for this guideline was this emphasis on what happens to patients after they survive sepsis and after they leave the hospital, and how what we do in the hospital may change those ultimate outcomes or accelerate or potentially impede their further recovery. So one of the PICO questions we asked in this domain was, in adult sepsis survivors and family members, does providing sepsis education, for example, booklets, apps, websites, during hospitalization or at hospital discharge, does that increase satisfaction? Does that increase knowledge about sepsis? Does it improve psychological outcomes? And does it reduce ICU or hospital readmission? And after reviewing the literature, the panel concluded that for adults with sepsis or septic shock in their families, we suggest offering written and verbal sepsis education on the diagnosis, treatment, and post-ICU or post-sepsis syndrome prior to hospital discharge and in the follow-up setting. And that's a weak recommendation based on very low quality of evidence. It is a new recommendation for this revision of the guidelines. So this looks at some of the data that we looked at to come up with this recommendation. So, for example, here, where the outcome is patient anxiety, there really was, in terms of comparison to usual care, there was some signal that providing education might reduce patient anxiety compared to usual care. Compared to an intervention of coping skills, there was no signal of difference there. Similarly, in terms of providing family education with regards to satisfaction and care, families there was a strong signal that education improved family satisfaction with care. So again, a weak recommendation or a suggestion to provide sepsis education at discharge and on follow-up for patients and families. So to sum it up, the guideline in its entirety has 93 total recommendations. We've only gone through a brief overview of some new ones in this presentation. There are also other additional new recommendations that we didn't have time to present today regarding capillary refill time, empiric MRSA coverage, empiric fungal coverage, peripheral vasopressor use, levosimendan, the use of ECMO, and additional recommendations around post-ICU follow-up. And we really look forward to the discussion period. And again, thank you to everybody who participated in this process. And thank you to ESICM for the opportunity to be here today.
Thank you very much, Laura, and welcome back on stage, Laura, and also welcome, Andy. First of all, really, on behalf of the Society, let me thank you for your leadership in this. I know it's been a massive task. And also, I think it has shown how important it was to have the Surviving Sepsis campaign as a framework of preparedness during the pandemic. Today, we will not focus on COVID, but your leadership during COVID times and how you've been able to use the structure of the Surviving Sepsis campaign to provide evidence during the pandemic. I think it's very commendable, and really thank you for that, first of all. We have a lot of questions. We have a full room. We have more than 700 people in the room, plus hundreds of people seeing us on social media, so we got lots of questions. And I will start with one first question, which is, it seems like the new guideline is focusing also a lot on performance management. There is, for the first time, a recommendation on setting up processes in hospital. How strong was the evidence there, and how important do you think actually this part of the recommendation, this recommendation should be taken by bedside clinicians?
So Maurizio, let me start, if I may. And good morning, everyone, and thank you for the opportunity to be here to discuss some of these issues. Actually, one of the main advances I think we've seen in sepsis over the years is the increased recognition and awareness of that it's a problem, and that means us going out and looking for it and being aware of it, and having it at the forefront of our mind when we're seeing patients and assessing them for this condition. And there's one thing about just building the awareness, and there's another thing about doing that in a systematic way. And often that needs screening tools and some sort of performance framework around those screening tools to make sure that they're implemented. Continuous improvement, quality improvement are well known, well understood, and well studied in the literature, not just in sepsis, but broadly in many facets of what we do, and they're really, really important. So what we're trying to say is actually, there's one thing about giving out a whole lot of guidance and recommendations, but there's another thing about actually formally making sure that we're implementing that in our practice. And that requires a systematic way of looking at quality improvement, measuring our performance, and then actually implementing tools to change in order to drive the quality improvements that actually usually are necessary when we really dig down and see what actually we're doing as opposed to what we think we're doing. So Mauricio, I'm going to stop it there, and maybe Laura wants to come in.
Sure, I'll add a little comment to that. Thanks, Andy. And thanks, Mauricio, for the opportunity to be here. We did actually have a prior best practice statement about the use of sepsis performance improvement. And the change from the 2016 guideline to this current one is we now felt the evidence was able to be graded. And so the recommendation in the current guidelines both recommends having a systematic screening process, like Andy was saying, to look for sepsis, because we do think the evidence supports that having structured processes in place does make a difference in terms of how we treat patients. It does make a difference in terms of patient outcomes. And then we also make a comment about the use of standard operating procedures, or you could use protocol as the other term for that. But we separate out both the point of having a structured performance improvement program and then having standard operating procedures in place from that. And the evidence base, Mauricio, as you asked, was a little bit different for each component of that. So we felt that we issued a strong recommendation, and we felt this evidence base was actually moderate quality for the use of screening for sepsis, whereas we issued a strong recommendation based on very low quality of evidence for the use of standard operating procedures. The evidence base was not quite as strong around there. And Andy, I don't know if you'd like to add anything else.
No.
Thank you for that. I think Ellie has a question, but I see lots of questions coming from the audience, which is really buzzing. Maybe one related to this. In these new guidelines, there is a recommendation or a suggestion about you could wait antibiotics if the patient is not in shock. Isn't that going actually against what we just say about making sure that we implement everything we can deliver this? Are you not worried that this could delay antibiotics in some patients?
One of the new things that we've tried to bring into this guideline, Mauricio, is the paradox between if a patient's sick with sepsis, they need antibiotics, and therefore we should probably get on and give them very quickly, as opposed to some of those patients who are a little bit more of a diagnostic puzzle. We're not quite sure whether they're septic or not. And if they're in a category that's perhaps lower risk for dying, actually there is a little bit more time to work it through. So for those patients, what we're saying is for those patients who are presenting with sepsis, we think there's a high likelihood they have got sepsis, and they've got sepsis or septic shock, get on and give the antibiotics quickly. However, if we're not quite sure whether they're septic or they've got heart failure or some other inflammatory condition, and they're not shocked, so they're not in a position where actually it's going to make a material impact if we get on and treat them immediately, then we've got a bit more time to actually get to the bottom of what's going on, work through whether or not the patients have got infections or not, and then start the antibiotics a little bit later. And this is driving, and is being driven also by the literature on antimicrobial stewardship and the desire not to give antibiotics when they're not needed, but to target those patients most at risk for those antibiotics. And if you need it and you're at risk, getting it on and giving it quickly.
Excellent. Ellie.
Thank you very much, Laura and Andy, for this impressive effort and for showing also that our two societies can work together and provide these very important data. One question that is coming from the audience, and that also is something that is discussed all the time, is whether these guidelines that are applicable to the big numbers can actually be focused on subgroups. And when we say subgroups, it's about subgroups of patients like burns in immunocompromised or any other groups, but also to diversity groups inside one country or between different countries, and this addresses the LMIC's issues, and how we can get from what is published here to a more individualized approach.
Oh, I think that's a super important question, Ellie, and thank you for it. You're right that these guidelines do apply to a broad population, and whether they apply to every member of every subgroup, I think we all know that that's probably not the case with clinical practice guidelines. And they're certainly not meant to replace clinical judgment. And if you think the guideline doesn't apply to your patient, you should be able to justify that. I think that Andy and I think, and Andy, please weigh in. I think we both sort of see a future where we have a process like the Surviving Sepsis Campaign guidelines that have a really rigorous methodology, look really at the broad-based literature and offer guidance, and then have a process where those guidelines become locally adapted to whatever environment makes sense. So that's a sort of, to me, the sort of implementation piece of that recommendation around having a structured performance improvement program for improving the care of patients with sepsis. And so if you are in a lower middle income country, some of these guidelines may not apply, but I think they can still be used as a framework to structure your local performance improvement program that's locally adapted to the context and the resources. And similarly, if you're in specialty populations like obstetrics or immunocompromised hosts. So I think that they can be used as a framework and then locally adapted. And I think that, to me, would be the application of this recommendation around performance improvement.
This is a very important point to provide teaching based on these guidelines, a global framework and a local adaptation wherever you are addressing a specific clinical issue. Thank you.
So, Laura, Andy, never like in the last 2 years, we're seeing how fast we can actually build evidence as an ACM community. The balanced crystalloids, there is a recommendation there. There is a recent study that came out, probably not in time to be put in the guideline. Maybe you can comment on this, but I was wondering also if you can tell us, how do you see the evolution of the Surviving Sepsis campaign? Will we have revisions every 4 years, or do you see that we need to find a way to bring new evidence to the bedside clinicians in between? Probably it's a difficult question, but I'm sure you can answer.
Thanks, Marissa. I mean, there's two separate questions there, isn't there? One on balanced crystalloids and the second one really on how we evolve the guideline development process. You're right, the balanced crystalloid, the data when we cut it off actually came out with a weak suggestion towards using balanced crystalloids over normal crystalloids. Whereas the Brazilian data that came out just a couple of months ago now, during the peer review process and at a time when it was too late to change his guidance, seems to be pushing back a little bit and moving back to that equipoise issue. And that cuts to the fore of kind of what we're looking at when we're looking at the guidelines, and we're looking for that wide applicability across a whole series of different kind of settings. As Eddie suggested, we've got diversity in terms of disease. So sepsis in Europe may be different to sepsis in sub-Saharan Africa, both in terms of the resource that you can deploy against the disease, but also from the etiology of the microorganism. So malaria might be more common in some settings, and pneumococcal pneumonia in others. And we need to, when we're providing the guidance, we're trying to make sure that it's applicable across most of those settings, apart from some of the small subgroups, for instance, children, where we're beginning to bring out more specific areas applicable to the small subgroups. So the balanced crystalloids, I think the evidence is actually moving back into the midline a little bit more now with the Brazilian data, and we'll have to look at updating that. And that plays into your second question, is how often we update the guidelines. And I think this has been really interesting during the COVID period, because we got out really quickly when COVID started and produced the COVID guidance and the COVID guidelines. And what we saw subsequent to that was there were studies coming out almost on a weekly or 2 weekly basis, and not all of the studies are consistent, and not all of the studies give the same message. And there's a great danger if we move too quickly when the data comes out, that we flip-flop the recommendations and flip-flop the guidance, and that doesn't help anyone. So we may be saying on a Monday of 1 week, we recommend for something, on a Tuesday of 2 weeks later, we recommend against something, and that causes confusion amongst the readers. So there's something about allowing the guidelines to develop and evolve more slowly than actually sometimes the evidence comes through. Clearly, we have to take some sort of riders in that, in terms of if there's very significant, very important practice-changing and outcome-changing evidence, then we need to move quickly. And we did do that in the past when activated protein C changed, and when some of the early goal-directed therapy kind of studies came through. But actually, on the whole, taking a more slow, leisurely, measured approach, actually balancing the pros and the cons, looking at how it's applied across all different parts of the world and all different settings, is actually a more useful tool. So we are looking at how we can update these guidelines on a more frequent basis than the 4 years. But first of all, it requires an awful lot of resource to be deployed to actually manage the meta-analytical, the search process and get the guidance. But also, we just need to bear in mind that we don't want to move so quickly that we change whenever every new fad comes out and every new data stream comes through, because there's a danger that we move too quickly and provide confusion rather than guidance and homogenizing kind of the way of practicing.
Very clear. Thank you, Andy. Laura, do you want to say something?
No, I agree with everything Andy said there. I think there is a balance, as Andy already articulated so well, between offering guidance that people can have the time to implement and look at the effect of, and being obviously responsible to new published literature. So we are looking actively at the processes around Surviving Sepsis campaign and trying to make it as nimble as possible while balancing those considerations from that. I think the other, obviously, question with regards to guideline development, and it's been less prominent obviously with the sepsis guidelines, has been the use of the preprint literature in COVID, and that I think has been a massive consideration around the development of guidance for COVID with that. So I think we probably don't have time to go into that today, but I think with at least regards to the sepsis guidelines, obviously we are waiting for everything to be fully peer reviewed prior to considering it for guideline inclusion.
Thank you. I have a question. There are many questions from the audience about not only the things that should be updated or the things that should be added, and of course the tremendous work that you did cannot cover everything, but still some recommendations are provided based on not a weak evidence sometimes, but sometimes an evidence that should be improved. So I have a question for the two of you. If you were to recommend one specific study or trial to add, and that was very much lacking for you to provide guidelines, what would be this specific study for each of you? Please, Laura, and please, Andy.
Oh, that's a great question, a really hard one. I think you're right. I think the areas where the recommendations are weak or the evidence base is of low or very low quality can serve as a call to what we think is the research agenda or what we think are research gaps currently in sepsis. And I think the inclusion of those PICO questions is an important one because we did go through the structured process of deciding what questions to include in the guideline. And so I think when we thought the questions were important enough to include, but the evidence base was weak, that can obviously be a reflection of a research gap from that. To me, I think one of the most critical questions, and that we still are not able to offer specific guidance, is we do have a strong recommendation around screening for sepsis. We do think that having a screening process to identify patients systematically is important and that it improves patient outcomes, but we don't have, other than the recommendation not to use QSOFA as a single screening tool, we do not recommend any particular screening tool. So I do feel like if I had to pick one study, I would pick a cluster randomized controlled trials of different screening processes to identify patients with sepsis so that we could offer some more specific guidance around what can we do to actually screen for sepsis.
Really great idea, and I hope that this will be done in our ICUs all over the world. Maybe the same question for Andy?
Yeah, thanks, Eli. I think there's three areas I'm going to pick out actually, which I think remain controversial, and the reality is that they remain controversial partly because we've tried to provide guidance and tried to provide it in a way that's simple enough to use, but also because the literature really isn't there to be able to really back up some of these concepts. And I'm going to pick out how we give fluids, about how we give antibiotics, but also the new area that the guidelines focused on this time, which is a little bit more about the longer-term outcome and follow-up of some of these patients. And in each of these areas, there's a gap. So if I look at the fluids, there's an awful lot of, there's a kind of cognitive dissonance and a dichotomy of thought in how we develop the recommendations for fluids. And a lot of people say that they want to have that individualized approach where they're going to use all of the clinical, physiological, hemodynamic measures they've got to in their armamentarium and develop a way of giving fluids which everyone can feel comfortable with. The reality is the data for that is not really there to be able to demonstrate an outcome improvement with a lot of these measures. So the other side to that is people say, well, just give us a recipe. We want to know whether it's a liberal way of giving fluid or a conservative way. We want to know whether to give a little fluid or a lot of fluid, which is completely different from the physiological individualized approach. And we brought that in as a PICO question this time to try and look at the literature to say, actually, in the first 24 hours of resuscitation, should we have a liberal approach, or should we be more tightly kind of controlling our fluid balance? And I know there's a number of studies going on in this, which hopefully will play through to the next updates to guidelines. But when we went into it, the data really wasn't there in any consistent framework or format to be able to make any kind of guidance at all, which is why we stepped back and refused or didn't provide a recommendation in that area. So I think that's one area. The second one was antibiotics. We're still saying that there's a time measure for antibiotics and that we're likely to give the antibiotics within an hour for a sick patient. But when you step back from it, the data really isn't there solidly to be able to say the 1 hour as opposed to 30 minutes or an hour and a half is exactly the right measure. And that really does kind of need, I think, a tightly performed study to really look at that question, as opposed to us having to work through the implications of observational and adjusted analysis. And the third area we really were keen to look at this time was the impact on some of the longer term, perhaps softer measures, perhaps Ellie, more akin to a lot of your research that you've done over the years. But what is the impact of those ethical conversations, setting goals for therapy, and actually transitioning patients when they're getting better out of intensive care through to other healthcare settings, either on the ward or after the ward in terms of rehabilitation? And we've tried to provide some guidance and focus some areas and some thoughts in these type of areas to demonstrate actually we think it's important, and for the patients it clearly probably does make a difference. But actually the data there isn't solid enough to really make solid, firm recommendations, which have implications when we're delivering care in the hospital, because it's quite costly to set some of these services up. So I'm going to pick those three things and I'll stop there.
Andy, Laura, the group has never been as diverse as it has been this time, and I think that was one of the important things, and where the guidelines came, I'm sure it was also due to that. But is this enough? We have questions about low and middle income countries. How transferable is this knowledge and these recommendations to low and middle income countries? And does the Surviving Sepsis campaign have to do more about it?
Yeah, so let me start off and then Laura can pick up. We came to the conclusion a number of years ago that diversity is really important, and diversity can be looked at in terms of gender. It can be looked at, we were looking at it in terms of geographical representation, but it can also be in the resource type settings. And we put a lot of play into trying improving the diversity, but I think there's still a long way that we can go to improve it further. One of the things we were trying to do is that every one of the subgroups have representation from participants who come and represent lower middle income settings. And that's played through, but I think actually that could be strengthened going forward. It is actually a challenge in how we craft these guidelines to cover all the settings. So it's very easy to say that we're going to do X, Y, and Z, and we're going to put a ventilator on a patient, we're going to use this very expensive drug. But that's only applicable to certain parts of the world where either the resource is there to provide that kind of intervention, or in some parts of the world the intervention isn't even available. So some drugs are available in North America that aren't available in Europe or South America, and vice versa. So I think there's a real question as these guidelines go forward as to whether we carry on trying to cover both parts of that aspect in the same set of guidance, or we split the recommendations of the guidance up into two documents, one for the resource rich and one for perhaps the less privileged, the populations less able to get some of these resource intense interventions. But it is a challenge, and I think that can be further improved going forward.
Thank you, Andy. Lots of questions. Maybe Ellie, one question, and then I have another one coming from here.
I just want to ask you about the way we should teach these guidelines to the multidisciplinary team. And do you believe that there are specific words and specific concern and maybe specific guidelines or recommendations that should be provided to the nursing team, which is a question that comes often: what is the role of a nurse, not only, as you said, Laura, in detecting, screening routinely patients for the diagnosis of sepsis, but also for management? What would you say?
Well, I think one of the strengths of this guideline is, Andy was just talking about the diversity of the panel, and I would add one other aspect of diversity of the panel, which is it really is a multi-professional panel that developed these guidelines. It's physicians, it's nurses, it's clinical pharmacists, physical therapy. So I think it does bring a broad base of the multi-professional hospital team to it. Not every member, and we probably could do better on that diversity as well. But I think the composition of the panel helps to create a guideline that really does have a role for everybody to play in the care for patients with sepsis. As we know that's functionally how we take care of patients with sepsis, is that all members of the team have an important role to play from that. How do we teach it? I think, I'm a big fan also of multi-professional education. So I think the guideline to me would be a great structure to do team-based education as well, where you educate nurses, physicians, pharmacists, and other members of the intensive care unit team or the broader hospital team. So simultaneously, when we're talking about what is the evidence base, what are the recommendations, and then how are we going to apply them locally? So again, it's sort of, you can use, I think, a team-based education strategy in the application of these guidelines to your particular environment.
Thank you, Laura.
Laura, stay there. Maybe we have a very practical question. Could you give us a sneak peek to the bundles? What will be in the bundles? Maybe you cannot give us this answer, but you can tell us where we are looking at.
I'm afraid I can't give you any answers on that. What the process is now that we have a new published guidelines, there will be a group convened with stakeholders from different disciplines and different backgrounds to look at these guidelines and make a determination if the bundle needs to be updated or not. So now that we have a new published guideline, we'll begin that process of looking at the bundles and making a determination as to whether they need to be updated or not. So it's even too early for a sneak peek because we haven't even engaged fully in that process yet.
Andy, can I grab some information from you?
About the bundle, yeah, absolutely, Mr. So we changed the bundle last time about 4 years ago when it became the Hour 1 bundle, and I think it's fair to say that was quite a controversial change, and it definitely caused quite a bit of debate in the literature and in social media. Our view in the past has been that we'd only really change bundles if there's a reason to change them. So what we're keen to do is to actually formally evaluate the Hour 1 bundle, and that's a process that's ongoing. And then when we've got some data as to what's right or wrong about it, whether it's working or whether it isn't, then we change accordingly. And I think that's a scientific approach as opposed to just simply changing it for change's sake. And what we found in the past is that actually when you change some of these metrics, if you're not careful, it can have quite profound implications for hospitals, infrastructures. Now many of us have got electronic health records and electronic sepsis alerts. Simply changing it isn't a benign intervention because actually it can have impacts onto all of these issues as it rolls through. So we're keen to, first of all, make sure we fully understand what's right and wrong about the Hour 1 bundle, and that data's still coming through. If there's a problem, then we need to address that problem and change it. But it needs to be a fully worked out, fully engaged, open process to make sure that we've listened to all the views before we change it so that everyone's considerations are taken into account. So as Laura said, I think that's for the next few months, if not a bit longer, to really understand what the impacts of this guidance and recommendations are on the bundle, where the bundle's failing or succeeding, and bringing all that together with the appropriate consultation before changing it.
Thank you, Andy. Laura, Andy, it has been an absolute pleasure, and really thank you again for your amazing leadership in this.
Thank you.
It's really wonderful, and thank you on behalf of all the intensive care community. Thank you all.
Thank you.
Thank you so much.
Thank you, Monsieur. And one last comment, if I may.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Good morning. Good morning, Sophie. Hello. It's 7:30 now, and it's time for me to talk to my colleague about what happened to you this night. So I'm going to tell about you and about everything around you. Is that okay? Okay. This is Alessandro, and he will take care for you in this day. Okay. Well, Alessandro, this is Sophie. She came in here 3 days ago with a septic shock, and overall she is doing well. If we look, you see she's still intubated. It's in her lungs, yes, you can see. But I managed to build it down this night. So she's not on the pressure control, she is more doing for herself in the breathing. So I think that she can further go on today. So maybe you can manage to let her breathe for herself.
Okay, she goes better, yeah.
Yeah, and I think that will be a very good step forward for her that she can work on. Furthermore, the blood pressure, that is stable, and this night we lowered down the medication to keep it stable. So I think in this morning you could stop it.
Okay, well, so you decrease the ventilator and the medication support.
Yes.
Okay.
And well, that was because she was also a little bit agitated, so that gave her the push and to give her the stability to push forward. So I think she also needs your support today to be calm and to have enough comfort.
Okay. And did she receive the visit of her family member?
Yeah, yesterday they came. Her mother comes, and she has a friend, and he also comes. And I talked to her mother on the phone this morning, and well, she told me that she is worried, but she's not communicating well enough with her boyfriend.
Okay.
So it might so be that you could consult the social worker, so that the social worker can arrange, well, maybe a discussion or maybe talk to the mother and have reassurance for the mother.
Okay, later. Okay.
Yeah, I think that will do for her very good. For the rest, I think it would be nice for her to get out of the bed, and she needs that to get out, and that will be a good point.
Yeah, okay, I think so.
Have you any questions for me?
No, it's okay. Thank you.
Okay. What we have done is to turn over my shift in the night to the day shift. And what is needed that I tell what happened this night to Sophie, to my colleague, so that he can take very good care for Sophie with all the machines around Sophie.
It is very important to share this information with every team members of the intensive care unit for the best care of Sophie. Good morning, Sophie. Hello. How are you? Well, now we'll do the round all together, in which we discuss your improvement and the goals for today. Okay? All right.
Good morning. So, Massimiliano, what can you tell me about Sophie?
Well, Sophie has been with us for 3 days now, and she has been here for a septic shock. I think her condition is generally improving. Her drug levels are going down, and also her organ function is improving.
How about the kidney?
The kidney are also going better, and she is able to have a good urinary output on herself. I think also we are on the 3rd day of antibiotic therapy, and the condition is generally improving.
Okay, and the antibiotics are correct?
Yes, we have identified one bacterium on the blood, and the antibiotic therapy is targeted on that.
Oh, perfect. Alessandro, anything from your side?
Well, during the night with a very, very light sedation, she slept well. She's comfortable. Now, no pain, actually, and a good bowel partner now.
Okay, perfect. So I would say we try to switch off the medication today.
Completely? Okay.
Yeah. And then also later today, we will try if we can get her off the breathing machine and put the tube out. And
Wonderful.
before that, perhaps, Victoria, can we try to sit her at the edge of the bed?
Yes, I think we can try. Yesterday she was able to move arms and legs by herself, so why not?
Okay. It will be a little bit tough for you, but I think it's important. So the physiotherapy will help you to sit at the edge of the bed, and then we will see, yeah? And later on, we will try to get the tube out as well. We have no nutrition yet, but I think that's fine since we are improving anyway, and then perhaps we can try after the tube is out to start with normal food. I read something about family issues.
Yes, she had a complicated family situation, so I think it could useful call the social assistance for the round tour, yeah.
Okay, Massimiliano, you will handle that?
Yeah, I will call the social assistant today and see what we can do on that.
Okay.
Okay, perfect. This was the very important interprofessional ward round. There, we discuss important information between the healthcare professionals of the ICU team. Furthermore, we discuss the goals for the patient of the day.
Communication with caregivers is one of the most highly valued aspects of care. Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow. Research has shown that families get frustrated or confused when clinicians use medical terminology or abbreviation without explaining them. Also, they get confused when they receive information from too many different clinicians. So don't hesitate as a family member to ask questions, to ask the nurse or the doctor to repeat the information, and more generally, don't hesitate to ask for a meeting with the ICU team.
Hello, Sophie. I'm your physiotherapist. Today, we're gonna try to put your legs out of the bed and to stay sit. We're gonna do that together, me and your nurse, okay? Let's try. Okay.
So, we check the length of the tube. Please check the length of the lines.
Everything's okay?
Okay.
Okay.
Well,
so
together.
We can start. Come here with your legs. Okay.
Oh, good.
Sounds good. Okay. Okay. How are you, Sophie? Is it comfortable for you? Okay. Let's breathe normally.
Perfect.
Okay.
Pain? Okay. Small breath? Okay.
This step is very important for the weaning of the tube, okay? Okay.
This collaboration between the nurse and the physiotherapist is a key feature for the best outcomes of the patient. And together, we get off of the bed and sit Sofia on the bed.
Hi, Alessandro. How was your shift?
Hi. Hello, Velia. Well, Sophie, all right?
She's awake today.
Yeah, she is. Well, morning shift was very good. We decreased all artificial supported, and now she goes very better. The goal is to remove the tube, so stop the ventilation by this evening.
Oh, nice.
Yeah.
Were you able to add a physiotherapy session?
Yes, this morning we put the leg outside the bed and she was good.
Okay.
Is it?
Perfect. So, Sophie, I am going to take care of you for the next few hours and we are going to remove the tube. Are you happy? So you are going to be able to speak again and we can hear your voice again.
Okay. Perfect. So, see you tomorrow.
See you. You're free to go, Alessandro.
Bye.
Bye.
Sophia, we are going to take the tube out now. Just breathe normally. It can be a little bit uncomfortable when I do the suctioning. Just breathe normally. Breathe normally. Okay, ready?
Ready?
on 3. 1, 2, 3. Perfect. Breathe normally. Everything fine? Perfect. Yes. So, Massimiliano, what can you tell me about Sophie?
Lady Sophie, she was extubated today because her condition has been improved in the last 2 days. Her septic shock is completely resolved, and she is not anymore on most of the effective drugs, so she's been improving in the last days.
So there's no organ insufficiency, so all organs are working normal, we have no organ support.
Yeah, exactly.
Okay.
Cardiac function is completely restored, and also the kidney function is going well.
Okay, perfect. Did she started eating already?
Yes, she started eating today, and also she has been mobilized out of bed in a chair.
Okay, perfect. Looks good. So she can be discharged tomorrow, right?
Yeah, the program is that one. If everything is like this tomorrow, she will be discharged in the ward.
Okay. Good, perfect. Thanks. In the afternoon, we do a handover from the day shift to the night shift. Important information will be exchanged so that I can take care for the patients during the night.
In our ICUs, you will see the interprofessional team. You will see doctors, nurses, health nurses, physiotherapists, you will see social workers, and many people working in the ICU from other specialties like the consultants, or sometimes you can see people who are helping ICU patients for different things. We are an interprofessional team. The teamwork is important because any outcome in the ICU is the result of how we work together and how we are structured and able to deliver the best critical care for our patients.
Hi Silvia, how are you?
Fine, thank you. How are you?
Fine, thanks. And she is Sophia? Do you remember Sophia?
Yes, from yesterday.
Sophia, she is Silvia. She's the nurse who is going to take care of you for tonight.
Hi.
You could see she is really improving. We were able to stop her medications, all inotropes vasopressor. We were able this morning to reduce ventilatory support, and then this afternoon to stop ventilatory support and remove the tube. And she is also able to swallow. We try with water and then with food. So we were able to remove her nasogastric tube. So she is really, I think, feeling better.
Yes. So tonight, it seems to be a quiet night. You will be able to have some rest. I will put the lights a little bit off and the sounds, the less sound of possible, so you can have some rest. And tomorrow you will be able perhaps to go out from the intensive care unit. Okay, if ever you need something, you call me, I will be there.
Okay, thank you very much. Perfect, I leave you in really good hands. See you tomorrow. See you tomorrow. Bye.
Bye.
During clinical rounds, we assess whether patients have symptoms that we need to control. We usually do that with doctors and nurses, as well as all the professionals during clinical rounds. We are very much paying attention to whether patients are painful. We not only assess pain intensity and pain distress, but also response to pain therapy as to be sure that pain is controlled. Other symptoms like distress, anxiety, hunger, and thirst are also symptoms to which we pay attention, and we are making our best to control these symptoms several times a day.
high-flow nasal oxygen as first-line treatment of acute hypoxemic respiratory failure in ARDS.
The second speaker, thank you, Lise, will be Stéphane Herman from the University of Tours in France, and he will be addressing high-flow nasal cannula, awake, prone position, randomized evidence.
And the third speaker is going to be Oriol Roca from Barcelona, Spain, and he's going to speak about the monitoring of patients under nasal high-flow cannula, and more specifically, about the utility of the ROX index. We're now going to listen to the 3 presentations, and after that, there will be 15 minutes period for question and answer. And during all the talks, you can use the chat to write your questions, and we are going to ask those questions to our speakers in the end. Let's go with the first presentation.
Good morning, my name is Domenico Grieco. I'm a staff intensivist in Rome. Thank you to ESICM and Fisher & Paykel for organizing this important session on the role of non-invasive respiratory support and high-flow nasal oxygen for the treatment of acute hypoxemic respiratory failure and ARDS. So these are my conflict of interests. And looking at the guidelines published in 2017, we see that unfortunately there is the panel of experts who reviewed the literature were unable to provide a final recommendation of about the use of non-invasive ventilation for the acute hypoxemic respiratory failure. Most of the data available so far were involving face mask non-invasive ventilation. And I think that this comes from an issue about NIV that has been highlighted by research in the last 20 years. This is the fact that if the patient avoids intubation with non-invasive respiratory support, the outcome is improved. However, if patients require intubation after a failing trial of non-invasive support, the outcome is worsened. And the time of exposure to non-invasive support before intubation in failing patients is strongly associated to a worse clinical outcome. And this has led to the concept that the patient who is spontaneously breathing with hypoxemic respiratory failure may have an increasing respiratory drive that, together with lung inhomogeneity, can yield a high inspiratory effort, pendulum between lung regions, and increases in transpulmonary pressure swings, tidal volume, respiratory rate, all leading to a progression of lung damage during non-invasive support, which worsens the original lung injury caused by the disease process. So I think at this time, the recommendation that we can make from clinicians is that any form of non-invasive respiratory support should be used with caution. And the treatment can be beneficial, and we have seen this in the COVID-19 pandemic, since non-invasive support techniques have been widely applied with variable success rates. But I think careful clinical judgment is needed to optimize the treatment, mitigate lung injury and the risk of self-inflicted lung injury, and improve the success rate of the technique. At the same time, careful monitoring should be made in patients who are treated with non-invasive support, both NIV and high-flow nasal oxygen, to early detect treatment failure, not delay intubation, because delays in intubation can worsen clinical outcome. The techniques that we have today for the treatment of hypoxemic patients in a non-invasive manner are the face mask, so the interfaces, the helmet, which is a hood that covers the entire face of the patient. And in the last 10 years, we've seen and we have welcomed the introduction of high-flow nasal oxygen, which is a technique that provides a high flow through specific nasal prongs. So I think that the physiology of high flow nasal oxygen is complex, and it puts together a lot of other facts, and they are very interesting for the treatment of patients who are hypoxemic in the ICU and outside the ICU. I think that the most important effects of high flow for hypoxemic patients is the fact that you are capable of delivering the set FiO2 because the high flow matches the peak inspiratory flow of the patient. You have a washout of the CO2 from the upper airways, and this allows to reduce the inspiratory effort and work of breathing in isocapnic conditions. So for the same level of CO2, you have less intense inspiratory effort, and the patient's expiration against the continuous flow generates a PEEP effect that may provide some other recruitment and improve oxygenation together with reducing lung strain, which is the ratio of tidal volume to functional residual capacity, so FRC. And looking at the randomized controlled trial published in the last 5 years, the first study to address the role of, in a large-scale trial of high-flow nasal oxygen was the Florali study published by Jean-Pierre Frat and the REVA network, in which patients with PF ratio below 300 in the intensive care unit were randomized to receive either high-flow nasal oxygen or standard oxygen through a face mask, or a face mask NIV in pressure support mode, PEEP 5, between 5 and 7, and low pressure support. And they actually found that there was no difference in the rate of endotracheal intubation in the patient in the whole cohort, but importantly, in the most delicate population, so the most hypoxemic patients, so moderate to severe hypoxemia, PF ratio below 200, the high flow oxygen could reduce the rate of endotracheal intubation and improve survival. But non-invasive ventilation can be delivered with different techniques and different settings, not only with face mask, and the helmet could be an alternative for the treatment of patients with hypoxemic respiratory failure. In this pilot study by Bhakti Patel and the group of Chicago, patients with ARDS were essentially randomized to receive either face mask NIV or helmet NIV. And the primary endpoint of the study was the rate of endotracheal intubation, which was significantly lower in the helmet group, with a huge reduction in the rate of endotracheal intubation from 60 to 20%. Small study, pilot data, but interesting signal about the possible benefit of helmet NIV. And this obviously was associated to improved survival because of avoidance of endotracheal intubation. But looking at details of the study, you clearly see that, well, the big difference between groups was the use of a higher PEEP in the helmet group. And this occurred despite the protocol for PEEP setting was the same in both groups, because as stated by the authors, titration of PEEP to higher levels per protocol in the face mask group was limited because of intolerance of the patient and excess leaks. So the helmet is an interface that allows to provide high PEEP with good tolerance. So it's not only the interface that we are discussing in the settings that we are providing with the delivered with the interface. And the importance of high PEEP in spontaneously breathing patient could be crucial. In this milestone study by Caio Moraes, Takeshi Yoshida, Marcelo Amato, and Brian Kamana, and a large group of investigators in which they systematically assessed in an animal and patients the effect of high PEEP during spontaneous breathing, they actually found that PEEP was a tool that could be essential to reduce the inspiratory effort. Look at this slide, you see the airway pressure during pressure assist control mode, so it's the same as pressure support. with PEEP 5 and pressure support of 10. And here you have the airway pressure tracing. This is the esophageal pressure tracing, and this is the negative deflection in esophageal pressure, which is the inspiratory effort. You see that after 30 seconds, if PEEP is abruptly increased, this yields to a reduction in the inspiratory effort, so in the negative deflection of the esophageal pressure. And putting together data from different settings and patients, you see that the results are consistent among subjects, and the increasing PEEP during spontaneous breathing allows to reduce the negative deflection in esophageal pressure. So less negative deflection means lower inspiratory effort, reduction in tidal volume, so lung protection, reduction in transpulmonary driving pressure, so again, lung protection. And you see that there is no difference in the electrical activity of the diaphragm, and this explains that the mechanism for which PEEP allows to reduce the inspiratory effort is neuromechanical uncoupling. Essentially, for the same neural stimulus, the diaphragm is flattened and produce a less strong effort. And most importantly, after analyzing patients, animals ventilated for a while with high and low PEEP and spontaneous breathing, you clearly see that the use of high PEEP prevents the inflammation in the edge between the dorsal and ventral regions of the lung, so the edge between dependent and non-dependent lung, which is the area most exposed to patients' self-inflicted lung injury during spontaneous breathing. So we knew that high flow could be better than face mask NIV. We knew that helmet NIV could be better than face mask NIV. We decided to run a pilot randomized trial to compare helmet NIV with specific settings, so IPEEP, because of this, it's with the rationale to protect the lung and lessen the effort, and high flow nasal oxygen. The study was designed to include patients with hypoxemic respiratory failure due to all causes, but unfortunately due to the COVID-19 pandemic ended up included on patient with COVID-19. So patients were randomized to receive these two treatments. A helmet was provided with PEEP between 10 and 12 and pressure support between 10 and 12, which is somehow low because part of the pressure support is dissipated to distend the interface, while high flow was delivered with 60 liters per minute of flow. The primary endpoint of the study was not different between groups. So I think that both helmet NIV and high flow nasal oxygen alone are safe, and the primary endpoint was the median respiratory support 3 days within 28 days from enrollment, so the number of days in which patient could breathe spontaneously without any assistance from the ventilator or high flow nasal oxygen. But looking at the secondary outcome, which was endotracheal intubation according to predefined criteria, we found a significant reduction in the rate of endotracheal intubation in the patients treated with helmet NIV as compared to those treated with high flow nasal oxygen alone. And this is this is a secondary outcome. Indeed, results are preliminary and hypothesis generating. And we definitely share the editorial, the concepts highlighted in the editorial accompanying the ANIVOT trial by Lavina Mushi and Jesse Hall, in which they highlighted the importance of trying to personalize treatments based on the individual response and specific phenotypes. So we tried to look at the data of the ANIVOT study and reanalyze the data to identify subphenotypes, and we think that we know from previous physiological data that the benefit of helmet NIV over high flow nasal oxygen is marked in case the patient has a strong inspiratory effort. And usually in patients with acute hypoxemic respiratory failure, a strong inspiratory effort is reflected by a reduction in the PaCO2. And we reanalyzed the data of the trial after stratifying patients, classifying patients according to whether the CO2 was normal, so between 35 and 45 millimeters of mercury. And you see here that there was absolutely no difference between helmet non-invasive ventilation and high-flow nasal oxygen in terms of the endotracheal intubation. But in patients who were hypocapnic before treatment starts, so patients in which that were likely to have a strong inspiratory effort, the effect of helmet NIV on the rate of endotracheal intubation was huge, with a 50% reduction in the rate of endotracheal intubation in this subgroup of patients granted by 48 hours of treatment of helmet NIV as compared to high-flow nasal oxygen alone. So this leads to my conclusion, and I think that high-flow nasal oxygen and IPEEP helmet NIV represent the most promising techniques for the non-invasive treatment of hypoxemic patients in the intensive care unit. And I think that our data suggests that high-flow and helmet NIV may be essentially equivalent in case of hypoxemia and concomitant normocapnia, because normocapnia could reflect normal inspiratory effort, and in this case high-flow nasal oxygen could be preferred to improve comfort, while if hypoxemia is accompanied by hypocapnia, helmet NIV may significantly reduce the need for endotracheal intubation over the other techniques, in this case high-flow nasal oxygen, and could be the preferred technique. My last is a word of caution, because during any treatment, careful monitoring is always needed, not to delay intubation and protective ventilation that we know can worsen clinical outcome. Thank you.
Hello, my name is Stefan Ehrmann. I'm professor of critical care at Tours University Hospital. I thank the organizer and Fischer and Peckel for giving me the opportunity to present in this symposium about awake prone positioning among patients undergoing nasal high-flow therapy. Here are my disclosures. I sincerely thank Fischer and Peckel for their help, their financial support to launch a study dedicated to awake prone positioning in the midst of the first wave of the pandemic, where the situation was difficult for everyone, and I think we could not have launched the trial we did without this industrial support at the beginning. We complemented that with some academic funding later on. So the rationale and background is to benefit of both nasal high flow, which may reduce intubation among non-intubated patients, and prone positioning, which reduces mortality among intubated patients. And basically, when you combine nasal high flow and prone positioning, you improve ventilation perfusion matching, you have a dead space washout, you have high FiO2, you reduce the lung strain through more homogeneous pleural pressure gradients, and you may reduce respiratory drive through all those mechanisms coming together. And if you look at this vicious circle of patient self-inflicted lung injury, where lung edema induces impaired gas exchange, which induces increased respiratory drive, leading to this self-inflicted lung injury, implementing awake prone positioning and nasal high flow has the ability to stop that vicious circle, and you could even imagine to move towards a virtuous circle where you have better lung function, inducing less respiratory drive, less lung strain, which then induces less lung stress, less injury, and leading to a better lung function. Early on in the first wave of the pandemic, here Chinese colleagues presented their experience with awake prone positioning in COVID patients, and all this drove a great interest. There have been many observational studies published on the topic. We performed a meta-analysis, and in the systematic review, we found 25 of such observational studies, which included patients who, at least in part, performed awake-prone positioning. The detail of those studies, there are about 1,000 patients who underwent APP, awake prone positioning, in those observational studies, and even 1,200 more if you add the studies where not all the patients underwent prone positioning. And we compared those patients to patients managed without prone positioning in studies evaluating patients spontaneously breathing but not undergoing prone positioning. And if you look at the results on intubation, for example, in the no prone studies compared to the prone studies, while the intubation rate is relatively similar. If you look at the death rate, it's 22% in the no prone studies and 11% in the prone studies. Of course, that is not indicative of a strong, dramatic reduction in death induced by prone positioning. No, this is illustrative of the limits of observational studies and the obvious bias that the patients who are prone are less severe than the patients who are not prone. Despite those limits of observational data, this expert consensus statement showed that at that time in spring 2020, 91% of the experts agreed that prone positioning can improve oxygenation. That is well documented in the observational studies, but more interestingly, more than half of the experts, 54%, agreed to say that based on their experience, awake self-proning may prevent the need for invasive mechanical ventilation. And that was even stated in the abstract, where awake self-proning was recommended to improve oxygenation. Facing this lack of randomized evidence, we launched this awake prone positioning for COVID-19 acute hypoxemic respiratory failure randomized controlled multinational open label meta trial. And the objective was to determine whether APP reduces the rate of treatment failure at 28 days, defined as death or intubation, in patients with severe COVID-19 hypoxemic respiratory failure requiring high flow nasal cannula. I will detail the meta trial concept later on. I would like to thank all the investigators of this work. It was a great professional collaborative experience. I met a great group of people, and I really thank them for having made possible to conduct that work all together. So basically, we met the first time, the 29th of April 2020, 5 principal investigators of randomized trials on awake prone positioning, a 6th group joined later on. We had monthly web meetings starting in April 2020. We harmonized the inclusion-exclusion criteria and the planned intervention in the trial as much as feasible between the different trials. We identified a common set of core data to be extracted from each trial. We drafted a collaborative interim and final statistical analysis plan. We wrote a protocol of collaborative prospective meta-analysis. The meta trial, on a methodological point of view, it's a prospective meta-analysis on individual patient data. We agreed to publish jointly and to stop the recruitment in case of loss of equipoise. Very important, we published the meta-trial concept and the protocol, and as this is a relatively new methodology, the meta-trial had not been implemented so far to the best of our knowledge before. So we wrote what we would do, and we did what we wrote, and this is very important for the validity of the results, I believe. So inclusion criteria were COVID-19 pneumonia under high flow therapy with a PF ratio below 300. We had some exclusion criteria, in particular high BMI, which may compromise proning. The procedure, which were harmonized between the trials, the patients in the intervention group were instructed and assisted to prone as long and as frequently as possible each day. The and assisted is very important. It's not strictly a self-proning study. The nurse and staff were helping and stimulating the patients to prone as long as possible. Proning was not allowed in the control group, not even as a rescue therapy. This was considered as a protocol violation. High flow nasal therapy was protocolized, and we had predefined criteria for intubation. Outcome, treatment failure within 28 days, as I said, intubation or death, and we had some secondary outcomes I will present. The interim analysis plan, we planned to have an interim analysis at the meta-trial level every 200 patients, so putting aggregated data together from the 6 trials, every 200 patients in total. That means that some trials had just a few patients, others had more, and when the total was at 200, we would launch an interim analysis. We had an upper boundary for efficacy, a lower boundary for futility, and the first interim analysis came between those boundaries, so that means the trial goes on. And then we had a second interim analysis at more than 400 patients, which again fall in between the boundaries. We then had the second surge in late 2020 in the world, and the recruitment increased dramatically in all the centers. And so actually by the time we had the results of the second interim analysis, we already were beyond 600 patients included in the trials. And so we skipped the third interim analysis at 600. We plan to do it at 800. Actually, at the time we did the third interim analysis, we already had included 828 patients, and this third interim analysis crossed the upper boundary for efficacy of prone positioning, awake prone positioning in those patients, so recruitment stopped. By the time those decisions were made, we had included and randomized 1,126 patients, which were analyzed in an intention to treat. Here the details of patients included, and we had 5 consent withdrawal in the groups. Patients' characteristics, PF ratio of 150 in average. The vast majority of patients were in ICU or intermediate care. Steroids were used in most of the patients, and patients were enrolled within 1 day of hospital admission. Physiological response to awake prone positioning, you see oxygenation improves. Here the respiratory rate decreases and remains low after going back on the back of the patient, and that is indicative of a reduced respiratory drive, and as I said, eventually moving from the vicious circle of Thiele to a virtuous circle of improved oxygenation and less stress and strain. Primary outcome, intubation or death at day 28, was significantly reduced from 46 to 40%. That was mainly driven by intubation, which was significantly reduced from 40 to 33% in the intervention group. That made a number needed to treat of 14 patients undergoing awake prone positioning to avoid 1 intubation. Death at day 28 was also reduced from 24 to 21%, but this difference did not reach statistical significance. Secondary outcomes, very important. The time to intubation was slightly longer in the awake prone positioning group, 2.3 days compared to 2 days. But among intubated patients, the mortality at day 28 was the same, 43% among awake prone positioning patients who were intubated versus 44% among those in the control group. Similarly, the duration of mechanical ventilation among the patients who are intubated was similar in both groups. So that means that patients in the wake-prone positioning are intubated slightly later, but there is absolutely no signal of harm, because once intubated, they do exactly the same in both groups in terms of duration of mechanical ventilation and mortality. Predetermined safety outcomes were mild, they were infrequent and equal in both groups. We had no cardiac arrest during APP or in relation with APP in more than 1,000 patients in this trial. APP duration is an important question, and we observed that treatment failure occurred in only 17% of patients who remained in APP for more than 8 hours a day. So a very high efficacy of APP in those patients who do it really intensively, more than 8 hours, whereas it was only 50% treatment failure and success, so a very low success rate and a high failure rate in the patients who did not do 8 hours of proning every day. So in conclusion, this meta-trial shows that upright prone positioning is safe and has a favorable effect on intubation or death within 28 days of enrollment. I would like to thank all the people who participated in this work, in particular the Independent Advisory Board, Rich Callet and Paolo Biselli, the funding and the networks who helped us set up this work. Thank you very much for your attention.
Good afternoon, and thank you very much for the invitation to talk a little bit about a topic which I clearly like, which is predicting high flow failure, and specifically about the utility of the ROX index. These are my disclosures, and this is more or less the agenda that we will follow. Well, one of the main concerns when we use non-invasive respiratory supportive therapy is the fact that late intubation may be related with worse outcomes. This was firstly described for NIV, but it has been also reproduced when we use high flow. And this raises the importance of close monitoring. Here you have two different exit ray of two patients with lower pneumonia with practically an identical impairment in the oxygenation. But if you go outside the ray and you look to the patient, they look clearly different. On the left side, you have a patient with a subarachnoidal hemorrhage that was intubated due to the low level of consciousness, and he had a bronchoaspirative pneumonia and was monitored with AIT, with esophageal pressure, and practically all the devices that we have in the ICU. And on the right side, you have a patient treated with high flow that was only monitored with a pulse oximeter and non-invasive arterial tension. And the obvious question is the patient on your right side under monitor? Because our aim is to detect as early as possible any clinical deterioration, and therefore this type of monitoring is enough to detect this clinical deterioration. Well, there are several variables that have been associated with high flow failure, but they come from studies with a small sample size that included an heterogeneous population of acute respiratory failure patients, and therefore they were not discriminant enough to identify those patients who will fail. And in this context, we decide that we need to go one step further, and we define the ROX index. But where the idea of the ROX index comes from? Well, we went back to the roots, and we took the paper from Martin Tobin that was published 30 years ago in New England Journal of Medicine, and we read again the paper. And if you do that, you will find very interesting ideas, even in the introduction. One thing that Martin Tobin says is that one reason why a predictive index does perform poorly is that it does not accurately reflect the true pathophysiological determinants of the outcome, which in our case is intubation. And why patients with high flow needs to be intubated? Well, it has been recently described the concept of patient self-inflicted lung injury. And if we think about how high flow works, you will see that it is able to interrupt the vicious circle of lung injury at different points. But it does not occur in all patients. In fact, in those patients where high flow is not able to interrupt the circle are the ones that will need to be intubated. And if we look to the variables that are in this circle, maybe the easiest variables to measure are the ones related with the gas exchange. And if we continue reading the paper from Martin Tobin, they give you more information about how to do it. Well, an accurate prediction, he says that an accurate prediction is more likely with an index that integrates a number of physiologic functions. And if we take again the paper, the Florali paper, and we look to respiratory criteria for intubation, which is our outcome, you would need at least 2 of the following criteria. And maybe from this list, the ones that are easiest to measure are respiratory rate and SpO2. So what we try to do is to build an index using the measured respiratory variables that assess respiratory failure that were significantly different among groups. And we combine them aiming to obtain an additive effect, a synergistic effect, increasing their capacity to discriminate between those patients who would succeed on high flow to those patients who would fail. And we put in the numerator the variables that have a positive association with high flow success, and in the denominator those variables that has an inverse association with high flow success. And we defined the ROX index, which was defined by the ratio between SpO2 and FiO2 and respiratory rate. And we found that the ROX index above 4.8 was consistently associated with a lower risk of mechanical ventilation, even after adjusting for potential conforming. And more interestingly was that it outperformed the diagnostic accuracy of the 2 variables that compound the index when they were considered separately. But we also defined some thresholds for failure. Thresholds that were different at different time points, but they were highly specific for failure. And you would say, okay, you say me that you have a threshold for failure and another threshold for success. But what happens in between these 2 thresholds? Well, there is a gray zone. And what can I do with these patients that are in the gray zone? First, I have to say that there is only a small amount of patients that are real in the clinical practice in this gray zone. But what you can do is to reassess the ROX index and estimate the delta ROX. Because if you estimate the delta ROX and you measure the delta ROX, you will see that this delta ROX is significantly higher in those patients who succeed on high flow compared to those patients who fail. And the other question is, what occurs first, traditional criteria or ROX criteria? Because if they occur at the same time, there is no room for improvement by using ROX. I already have the traditional criteria, and if it works and works at the same time, there is no reason to change. Well, here you have represented those patients that they did not meet the traditional criteria at 2, at 6, and at 12 hours, but they met the ROX criteria for intubation at these times. And what happened to these patients? Well, 90% of these patients were finally intubated, which means that if we had used the ROX criteria in spite of the traditional criteria, they would have been intubated earlier. The second question that we have to clarify is, okay, you have said me that there is a threshold at 2, at 6, and at 12 hours, but this is time enough to take any decision with my patient? Can I wait more, or what happens with that? And the only way that we had to analyze that, which is the risk of death related with the timing of intubation, is to take as a reference the mortality that the patients who were intubated in the first 6 hours had, and compare the relative risk of death of these patients with the patients who were intubated between 6 and 12 hours, 12 and 24 hours, 1 and 3 days, and beyond these 3 days. And what we can say is that at least in the first 12 hours, there is no increase on risk of death related with the timing of intubation. Okay, this is what we have, but how we can implement at the bedside. And this is an algorithm that we published with Jean-Damien in intensive care medicine 1 year ago. And as you can see, the algorithm is practically the same at 2, 6, and 12 hours. The only thing that changes is the threshold to consider intubate the patient. And if you are in the gray zone, you have to increase the support and estimate the delta rocks, and then you will take a decision according to the value of the delta rocks. But we have to emphasize the fact that the level of flow that you are using clearly influence the rocks index value that you get. And the rocks index measurements that I have shown you were all performed with the maximum tolerated flow, because they were performed at the beginning of the technique, and the medium flow use was 50 liters per minute. And there were, and this was the reason why we did not include the flow on the formula of the rocks, because all the patients were treated with the maximum tolerated flow, and therefore there were no difference between the flow used between those patients who fail and those patients who succeed. But if you increase the flow from 30 to 60, you may get some change in the ROX index value. In fact, it increased in 70% of the patients. And it is also, this variation of the ROX is nicely correlated with the change in N-expiratory lung volume, which suggests that these delta ROX could be a surrogate of lung recruitment. And what happens with COVID-19 patients, which is another question of interest, because the data that I have shown you is all pre-pandemic data. But this is the first report that was published in intensive care medicine by the group of Jean-Damien Ricard, that reproduced practically the results that we published previously with the ROX in order to predict those patients who are going to fail with high flow, with a very similar threshold that the one that was described before in non-COVID patients. And I want to show you that the ROX index, it's not only useful to predict the intubation in those patients who are critically ill, it has been also used in this retrospective study that included more than 700 patients to predict the occurrence of an adverse outcome of those patients who are admitted in the ward. And they compare this predicting capacity with the new early warning score. And what they show is that applying the ROX index triggered this adverse evolution 4 hours earlier compared with the use of new early warning score. So to summarize, I think that when we use a non-invasive respiratory supportive therapy, any kind of non-invasive respiratory supportive therapy, we need to clearly predefine the criteria for treatment escalation before starting this non-invasive respiratory supportive therapy. Because this will be the only way to be sure that we minimize the risk of late intubation of those patients who are going to fail. And in this sense, these patients need to be closely monitored to detect, as we said, as early as possible, any clinical deterioration. And in this setting, the ROX index may help to predict the outcome of high-flow nasal cannula therapy patients with acute respiratory failure caused by pneumonia. It can be easily and repeatedly measured at the bedside, and therefore it can contribute to the day-to-day clinical decision-making process of critically ill patients treated with high-flow nasal cannula. Thank you very much, and I will be very happy to take any questions you may have.
Thank you very much, Domenico, Stefan, and Oriol, for these very good talks. So we have several questions on the chat. And perhaps I'll start, Lise, if you agree on the first one. Pascal Beret from Roanne, France, was asking how, with the use of the helmet, how do we monitor the tidal volume and hence the risk of ventilator-induced lung injury due to the high dead space of the device?
Okay, thanks for this question, which is pretty interesting. So during helmet NIV and also during CPAP, it's not simple to measure tidal volume because part of the inflated gas from the ventilator in case of NIV is dissipated to the standing interface. So I would say that unless you have specific tools, it is impossible to measure tidal volume with helmet NIV. And indeed, this is a drawback of the technique because we know that one of the advantages of NIV provided with face mask is that if we measure exhaled tidal volume, we can have a predictor of treatment failure and provide early intubation in case the tidal volume exceeds 9 milliliters per kilo, as highlighted in a paper some years ago from Guillaume Cartot. So it is impossible to measure tidal volume with conventional techniques during helmet NIV. So we should rely on the clinical signs that we use for treatment failure in other conditions. Also, there are no at the same point, there is no possibility to measure tidal volume with high flow. I think that one possible tool for the future could be the EIT, so the impedance tomography, to monitor the extent of tidal volume during spontaneous breathing. But I think this is for research, and we should focus on this aspect. Indeed, thank you.
Thanks a lot. And this can lead to the second questions to Oriol Roca. And it was related to the ROX index. Should we use the ROX index as a unique argument for intubation? Or should we combine maybe with signs of respiratory distress or maybe with other index as, for example, the rapid shallow breathing index? And someone asked whether there is a relationship between the ROX and the RSVI index.
Thank you very much for the question. I would not suggest to use the ROX index as a unique criteria to decide to intubate the patient or not, because the data that we have currently is purely observational, and therefore we have to test, and indeed actually is what we are doing now, to in a randomized controlled trial to compare traditional criteria versus an algorithm that contemplates the use of ROC plus the traditional criteria that we have. But the clinical judgment should be always taken into account in order to decide the correct timing of intubation of any patient. Regarding the use of rapid shallow breathing index, The problem is what Domenico commented before, is that we cannot measure tidal volume with high flow, and therefore the index cannot be applied, at least at the bedside in a normal clinical setting. The use of VIT has been used in research in order to at least be sure that you are not increasing so much tidal volume when you are increasing the flow, which was one of the concerns that we had at the beginning of the use of high flow. But this is something that we have to do more research to answer this question better.
Okay, thank you very much, Oriol. I have a question for our three speakers, expanding on a question from Anna Villagra, explaining why, despite the fact that all three techniques that you have shown, high flow, prone positioning, and the helmet, reduce significantly the incidence of intubation, there is no impact on mortality. And we know that there is a link between intubation and mortality. So is it a lack of power of these studies? Perhaps, Stefan, you can start. What's your opinion?
Yeah, thank you very much. It's a very good question. I think there is a part of lack of power, and there's also a timing question, because we looked at 28 days after inclusion. But that means that you have already a certain amount of time where the patient is not intubated. Most patients who would die intubated. It's a different case if they die not intubated. So after a mean of 5 days, the patient gets intubated. So when you look at 28 days of inclusion, you're already missing like 5 days of ventilation. So I think there's a need to look at longer term outcomes to look at mortality, because it's probably within 28 or 90 days of intubation and not of inclusion. And also, intubation, as I said, all dead patients are intubated, so intubation is a sort of a surrogate, and so there is a need for greater sample size to address the mortality issue, certainly.
Okay, Domenico, what's your interpretation?
Well, at least in the Florali, we have the signal of mortality in the old cohort. So this is something in favor of high flow. Regarding the results of our study on helmet NIV versus high flow as first-time treatment in COVID-19, indeed there was a 20% reduction in the rate on the tracheal intubation, but absolutely the same percentage of mortality. So at 60 days. I think there may be two explanations for this. One is that the study obviously is underpowered to detect a reduction in mortality. And just consider that if we want to reduce by 5% mortality, we would need something about 4,000 patients in a study like this. So this could be an explanation. The second explanation is that most of the data showing the benefit of non-invasive support by avoiding endotracheal intubation are, I think, back to the late 90s and the first decade to 2000. And I think that a great step ahead has been done in the last 20 years in the management of mechanically ventilated patients with low tidal volume, prone position, and maybe the optimal amount of PEEP. So it is possible that intubation itself is not so bad. So avoidance of intubation is not so good in that case, because we improved a lot the care of intubated patients with bundles. Also bundles to reduce the rate of ventilator-associated events like pneumonia. So there may be so many factors affecting the outcome of intubated patients, and I think a great step has been done in 20 years on this. And this may explain why avoidance of intubation is not so beneficial in terms of outcome.
But this does not mean that it is not beneficial, because we should see long-term outcome, because we know that sedation and mechanical ventilation paralysis could affect long-term outcomes, so physical and psychological status after the ICU discharge. And I think the effort should be done in this direction.
We have a lot of techniques for non-invasive support of those patients: high flow, awake prone positioning, NIV, CPAP, helmet. What should we use as first line? Should we combine? And when should we stop? For all of you.
I think that we combine all the therapies. I mean, we design randomized control trials comparing one technique with another technique, but it's perfectly possible that one single patient could benefit from all the non-invasive respiratory therapies during his or her course in the ICU, because the effort could change, as Domenico had pointed out before, and maybe there's a time for helmet, and then you can move to high flow in between helmet sessions. So randomized control trials are a way to provide more information about which patients could benefit the most from different therapies, but in the real life, probably combining therapies. And this is a problem for the crossovers in the randomized control trials design. In the real life, it should be combined for sure, or it could be combined for at least.
I think it's very important to use techniques you're familiar with, and if you're not, you have a learning curve, and you probably cannot have the learning curve for all the techniques at the same time. So if you did not do any awake prone positioning in your unit and you want to start that could be a good thing. If you have never used a helmet, maybe don't start both at the same time. Start with one, and once your team is confident with one technique, you can add another one. It's important to do things one has a knowledge of and a good practice, because the whole issue of this non-invasive management is that it's kind of falsely reassuring, because the patients, they don't look that severely ill because they're awake, they're not intubated, but they actually are very severe patients. So it's something we all need to learn progressively.
Okay, there's one question, Oriol, for you. Can the ROX index be used for other non-invasive respiratory support modalities, CPAP or NIV?
Maybe Domenico should answer that, because we try to use it with his cord of the Henibot, and it does not work as well with high flow. I think that when you are using NIV, you have better signals that you are monitoring that provide more information that is useful to predict failure than using high flow. But because when you are using high flow in the real life, you only put a pulse oximeter in your finger, and that's all you have in most of cases. But if you are using NIV, you have exhale tidal volume. If you are using helmet, you can also have other parameters, because most of them you have an ABG, and therefore you can take decisions with other parameters that may reflect even better the real state of the patient. But maybe the other speakers could have their opinion as well.
Well, there was one technical question for you, Domenico, asking if patients can eat and talk and drink during helmet. Can you comment?
Yes, they do. They do. We were surprised, because we use it a lot in the pandemic, and they eat. More often in the very early phase, we try to provide continuous treatment. So no interruptions for 48 hours to exert the most beneficial effects, but definitely they can drink through the part of the helmet. They are fed usually with enteral nutrition for the initial 48 hours. But they use their phone, they watch TV, and they interact with the environment. So comfort is good. And one comment regarding previous question. We did a study. The specific study was not to compare two tools. It was a study in which we compared two protocols, because we had one arm only with a high flow, and that we considered the standard treatment, and the other arm was the helmet for 48 hours, and in case some criteria were met for discontinuation of treatment, the patient was switched to high flow. So the real questions that I think we need to ask ourselves, that once we have the high flow, which is the standard treatment, in the very early phase of the disease, in the most severe patients, could there be a benefit by other techniques besides prone positioning, which I think we all agree it works? There could be a space for, in the early phase, for techniques that provide some more support in terms of PEEP and pressure support, starting from the idea that the standard treatment, I think the gold standard for this is the high flow, because it is the best way to provide oxygen supplementation to patients with high respiratory demand. And I think we have physiologic and clinical data to show this. I'm not sure if you agree on this point.
Okay, thank you very much, all three of you. I'll let Lise conclude the session, and thank you once again.
Thank you for this very good presentation and this very interesting discussion. And we wish you all the best for the Congress during the next 3 days.
Thank you very much.
Have a good day.
Bye-bye. Bye-bye. Thank you very much. Bye.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety or depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community.
Welcome to this Best of the Best oral presentation number 2. My name is Stefan Schaller. I'm the next chair of the committee. And this is Josef Cezikoglu, our past president of the society. We're looking forward to these next presentations. Each presentation has 3 minutes, and we invite you to ask questions online. So let's start with the third one from Nijmegen, Netherlands, body mass index and mortality in COVID-19 and other diseases.
Good afternoon, everyone. My name is Emma Koistra, and I'm a PhD student in the Department of Critical Care of the Radboud University Medical Center. And I'm very pleased that I got the opportunity to present you our study named Body Mass Index and Mortality in COVID-19 and Other Diseases. And I have no conflicts of interest. So in this study, we use data of 4 cohorts with a total of 35,506 ICU patients who were registered in the Dutch National Intensive Care Evaluation Database. And within each of those 4 cohorts, we investigated the associations between BMI and mortality. I was asked to start with the conclusions, so here we go. In the first 2 cohorts, the non-SARS-CoV-2 viral pneumonia and the bacterial pneumonia patients, we observed that the obesity paradox was present, and this is an inverse association between BMI and mortality. However, in COVID-19 and multiple trauma patients in the ICU, BMI was not associated with mortality. Now, I would like to show you some relevant data. Patients with COVID-19 were significantly younger, had a higher BMI, were more likely male, had a lower PF ratio on the day of ICU admission, and suffered from less comorbidities compared to the other cohorts. Within each of the 4 cohorts, we performed a multivariable logistic regression analysis. And when we first look at the non-SARS-CoV-2 viral pneumonia and the bacterial pneumonia patients, we observed significantly lower odds ratios for in-hospital mortality in the higher BMI groups. In the other 2 cohorts, so in COVID-19 and multiple trauma patients, we did not observe an association between BMI and mortality. After that, we created this graph with BMI as a continuous variable on the x-axis and the relative and hospital mortality risk on the y-axis. And when we first look at the other 3 cohorts, we see lower mortality risks with an increase of BMI. However, in COVID-19, we observed an increase again from a BMI of 34 onwards. So the take-home messages of our study are that the obesity paradox is present in non-SARS-CoV-2 viral pneumonia and bacterial pneumonia patients. And although obesity is a risk factor for the development of severe COVID-19, BMI was not associated with mortality in critically ill COVID-19 patients. So Tride's decisions for ICU admission of COVID-19 patients should not be based on BMI. And now I would like to thank you very much for your attention.
Thank you very much, Emma. My first question to you is, how did you choose your covariates, and did you also check for collinearity? For example, mechanical ventilation and PO2 FeO2 ratio. I would assume that there is a collinearity in there.
Thank you very much for your question. We discussed with several intensivists and data scientists which covariates could be of influence on our endpoints, and based on that we choose our covariates. And we also tested differences in all the variables we had in the database. And when there were differences in those covariates between the cohorts or between BMI groups, we also used it as covariates in our logistic regression analysis.
Okay, thank you very much. My second question would be, you know, the obesity paradox, there's the discussion that it's not only about obesity, it's actually about muscle. So did you check any muscle parameters in your patients or the body composition?
Yes, that's indeed one of the important points of discussion, I think. Unfortunately, we did not have any data about status of muscles or something, so we only had BMI. But I think something like abdominal fat or waist measurements would be better than BMI in this study.
Okay, thank you very much. So my last question to you, how are you going to plan to go forward?
So I think it's really interesting to investigate why the obesity paradox is not present in COVID-19 patients, and it is present, while it is present in other viral pneumonia like influenza. And it's also interesting to investigate why BMI is not of influence anymore in only critically ill COVID-19 patients, while we know it is a very important risk factor for patients with COVID-19 in the ward. So I think that are two important questions to answer.
Thank you very much, Emma. And we are continuing.
Okay, then we will go on with the second presentation. Uhrenholt from Denmark, Copenhagen. And the title of the presentation is Changes in Papillary Dilation Velocity During Delirium and Septic Shock in General ICU Cohort.
Hi, I'm Stine. I'm presenting this observational cohort study on changes in the pupillary dilation velocity during delirium and septic shock in a general ICU cohort. We know that autonomic dysfunction is part of the pathophysiology in both delirium and septic shock, but not to what extent. This study found a slower dilation velocity in the septic shock patients, but not in the delirious patients. This indicates a loss of sympathetic drive on the pupil and could likely be used as a surrogate marker for the loss of sympathetic tone on the blood vessels in the septic shock patients as a sign of autonomic dysregulation. We used PLR, or pupillary light response cameras, because the pupillary diameter has an established autonomic interplay where the constriction is parasympathetically controlled and the dilation is sympathetically controlled. We included 100 patients into this study, from acute admittance to the ICU until discharge of ICU or death, and we investigated for development of delirium and or septic shock. 83 of these patients had PLR data, and we used linear mixed models for analyzation of the association between PLR and delirium or septic shock. For covariates, we looked upon ambient light levels and noradrenaline infusions, but also age, sex, length of stay, and the usual suspects. This led to this model, where we see a slower dilation velocity by 0.25 millimeters per second in the septic shock group. But note that the upper limit of the confidence interval is nearly zero, which means that in a redo of this study, it could become a non-significant number. So, loss of sympathetic drive on the pupil could also indicate a loss of constriction on the blood vessels, leading to the hypotension in the septic shock patients. This led to the thought that PLR could be used to follow the progression of autonomic dysfunction back to normal in these patients. So it might be used as a surrogate marker for the loss of sympathetic tone on the blood vessels, as a sign of autonomic dysregulations. But this needs further studies. And this concludes my presentation. Thank you.
Okay, thank you very much for this presentation. And I have one question coming from the audience, from Laura Borgstedt, and she's asking, how was the weight measured?
It was before.
It was?
From the first one.
Okay, sorry, then I'm receiving the Okay, then I will go back to my own questions because I made I was receiving things a little bit late. Can you explain me your way of thinking? Because with septic shock, I can understand with the relation with the sympathetic tone and the loss of sympathetic tone. What was your thought on the mechanism which this will also happen with the delirium?
Yes, thank you for the question. Delirium is also a very, it has this systems integration failure theory that it's actually also a neuroendocrine dysfunction as it is in the septic shock patients, which leads to we can see also that noradrenaline and corticosteroids are elevated in the delirious patients.
Okay. But you know, delirium has a very wide range of etiology, so yes, that might be true for some patients, but we also have sometimes patients with postoperative cognitive disturbances and delirium and those sort of things. So my question, to be more specific, is don't you have, I mean, it's like ARDS, you can have 35 different reasons, and we concluded with one symptom name. Don't you have the same problem here? That was actually the real thing of my question.
Yes, exactly. And that is actually the problem with this syndrome, is that it has a wide variety of believed pathophysiologies, but we actually don't know. It's just theories. And the point of our study with the neurological consultant is that we need to look at one part of it to just be able to know something, at least.
Okay.
So
I give the word to Stefan for a moment.
Yeah, I have a question for understanding your analysis. So the table says unadjusted analysis, where you had a significant value for the septic shock. And also, it is unclear for me which time point is the specific dilation significance for a septic shock, because you measured it daily. So which time point then is the significance, or is it an overall significant value?
It's an overall significant value. It's we pooled the measurements and saw when at the point of where the patient was most in septic shock or sickest actually. There we saw the slowing of the dilation velocity.
Okay, we shall go on with the next presentation. Thank you very much for your presentation. I give the word to Stefan again.
Thank you. So the next presentation is Mr. Kobayashi from Boston, United States, on creatinine and mitochondrial metabolism in the critically ill. We're looking forward to it.
My presentation is creatinine and mitochondrial metabolism in the critically ill, a metabolomics cohort study. I don't have any conflict of interest. In summary, the conclusion of our study is elevated creatinine in critically ill patients is associated with metabolites related to incomplete mitochondrial fatty acid beta oxidation, as well as non-uremic retention substances. Briefly, our research was a post-hoc metabolomics cohort study of Vitaza ICU trial. Primarily, we examined the associations between serum creatinine levels and each of the 659 identified metabolites in 1213 plasma samples measured on 3 points. We applied multivariable linear mixed effect model to control potential confounders and autocorrelation in longitudinal data. In the mixed effect model, 334 metabolites were significantly associated with increasing creatinine level. This range plot provides an overview of the main results. Highly increased metabolites colored bright red, and slightly increased metabolites colored dark red. Greater significance level was illustrated by increased size of the circles. Main classes of significant metabolites were short, medium, and long-chain acetylcarnitin, branched-chain amino acids, dicarboxylate fatty acid, and pentose metabolism. Notably, increased short-chain acetylcarnitin, branched-chain amino acids, dicarboxylate fatty acid, and pentose metabolism had more obvious associations with increased creatinine. This figure shows the relevant metabolic pathways between fatty acid beta oxidation and the major metabolite classes we found. Our novel data show elevated creatinine during critical illness is associated with circulating metabolites related to incomplete mitochondrial fatty acid beta oxidation and uremic retention substances. Such uremic retention substances in critically ill patients with elevated creatinine may be important in impaired mitochondrial function. Thank you.
Thank you, Hirotata. I have a first question to your analysis again as with the talks before. So did you adjust your analysis because it was a post-hoc analysis of primary RCT?
Yes, this is the post-hoc analysis of the Physiotherapy ICU randomized clinical trial.
Yes, I'm aware of that, but did you adjust your analysis, for example, severity of disease, comorbidities, and other things?
So in this study, we adjusted the severity using substitute score and sex and comorbidity and the baseline vitamin D level and response of vitamin D level.
Okay, so it was not adjusted, for example, for pre-existing renal disease or something like this. My other question would be, so you measured now surrogate parameters because you measured only the plasma level in the blood for this metabolomic analysis and not the direct change in the mitochondria. So what is your plan to go forward after the study, or what conclusion already can you take from it, establishing this association in the blood?
So now we are planning to verify the association between the plasma creatinine and plasma metabolites using other cohorts. And also, we are planning to use the proteomics data to verify the association in blood samples and blood protein. But now we are not planning using the direct mitochondrial data.
Maybe.
Okay, thank you. Joseph has a question.
Just to complement that question of Stefan, I mean, we are a little bit clinicians here and we are very much thankful to the data that you produce us. But when do you think it will become, we will reach to a phase that we have also consequences at the bedside? How must we see this for the future? What are our options? Maybe the question is very early as of now, but of course it would be nice to know if there is anything to do to revert this. Do you have any opinion on that, or am I asking the question too early?
Yeah, thank you for your question. I'm also a clinician and it's very important to use bedside. And unfortunately, I'm not for sure to use this data for bedside. But I think we choose a few metabolites to evaluate the evaluate renal function, and I think it will be sooner to use it.
Okay.
Yeah, okay. I agree. To specify your question is a very good idea as the next steps. And we continue. Joseph.
Thank you. The next speaker is from UK, Bristol, Jo Hall, and her presentation is a systematic review exploring physician approaches to conflict resolution in end-of-life decisions in the adult intensive care unit.
Conflict is unfortunately well documented in the adult intensive care unit. In the context of end-of-life decision-making, it commonly occurs when a consensus cannot be reached on the best interests of the critically ill, incapacitated patient. Families of critically unwell patients may favour preservation of life, whilst physicians may be reluctant to provide life-sustaining treatment which may be potentially inappropriate. Whilst literature has identified potential routes for conflict resolution, such as communication strategies, clinical ethics consultation, and legal input, it is less clear how these approaches are perceived and utilised by stakeholders in the end-of-life decision-making process. Through this review, we aim to investigate the following question. What does existing qualitative research reveal about physician approaches to addressing conflict arising in end-of-life decisions, specifically the withdrawal and withholding of life-sustaining treatments in the adult intensive care unit? Through our search strategy, we screened 1,101 records, and 7 studies from the UK, USA, and Canada were included in the final synthesis. We analysed these studies using the methods of thematic synthesis and developed 4 themes. First, physicians built a trusting therapeutic relationship through what we have described as PEACE, providing patient-centred care, exploring the patient's values, assessing the family and their needs, consistent communication with clinical continuity, and emotional support. This provided a foundation from which conflict can be anticipated and addressed. Second, physicians determined the cause of conflict by identifying the nature of the conflict, such as misperceptions about what can be achieved in ICU, differentiating stakeholders' views of the disputed decision, including family members, but also others like the referring clinician, and distinguishing emotional components of the conflict, such as a family's fear or the ICU team's frustration, so these could be managed. Third, physicians would coordinate an individualised response to the conflict by tailoring negotiations and involving others. Participants gave a number of examples, and we found that the best approach sat somewhere between 2 bad approaches, drawing on Aristotle's concept of the golden mean. For instance, participants suggested it was important to give the family enough time, but rushing end-of-life discussions would make the conflict worse, and giving them too much time could prolong patient suffering. Physicians could also spend time correcting, for example, misperceptions of ICU, or they could involve others close to the patient for their views. Fourth, physicians had to balance their personal and professional values in resolving the conflict by maintaining professionalism, managing their personal beliefs and values, and responding to the uncertainty created by working within what they described as unclear ethical and legal frameworks. Our take-home message is this: prevention is the best cure, and we can try to both prevent and prepare for end-of-life conflicts using PEACE to build a trusting relationship with the patient and family. When conflicts do arise, this relational foundation allows an individualised approach to be taken to resolve the conflict. Thank you.
Thank you very much. If I may ask a challenging question, you have said, actually you have given 5 points which we should be doing. Can you give me very shortly 5 things that we should not be doing?
Yeah, absolutely. So through the kind of analysis that we did, we identified both objectionable and appropriate approaches to resolving conflicts. And some of the things that were objected to, for example, were inserting your own values too much into the decision-making process. So for instance, if you have suggesting what you would do for your family member rather than focusing on the patient and what their family members should be doing. Also neglecting the views of other members of the MDT, such as nurses or physiotherapists, who often spend more time with the patient at the bedside than the physician does. Other examples were avoiding the input of others. So for instance, it may often be the case that palliative care specialists are more experienced in having end-of-life discussions, and they have a huge wealth of experience in these discussions that we can use. And similarly, it was a point that was made later in the themes, but it was the avoidance of kind of ethical and legal input. And I think what can often happen in end-of-life conflicts is that the conflict becomes so prolonged and so entrenched that we pass the point at which, for example, ethics consultation would be of great benefit, because the 2 conflicting parties have become so entrenched in their views. So I think earlier involvement of ethics committees and seeking legal recourse could improve patient outcomes.
Okay.
I'm not sure if that was 5. Sorry.
No, that was, I mean, 5 was a symbolic question, and I think you can add a couple of things there, just speaking the language that the patient will understand, don't bring your telephone with you, and that sort of things, which makes quite a big impact. I don't have any further questions. Stefan, you have one question, I think.
Yeah, I would be interested. I understand that it was a qualitative systematic review, but did you find any information, because you said, you know, an appropriate time frame? What would be an appropriate time frame for the patients to have this discussion? Any signals in the literature about that?
There weren't very many at all. In fact, I can't recall any off the top of my head. But what was important was that the assessment of the family and their patient would start from kind of the point of admission in ICU. And you can gauge a good idea of what the patient's trajectory is likely to be quite early on. And at that point, you can start to lay the foundations for end-of-life discussions by, for example, making sure that you have a trusting relationship with the patient and family, and that you're clearly communicating with them, making time with them at informal bedside discussions before you have the formal end-of-life meetings.
Okay, thank you very much. We go on with the next one, Stefan.
Yes, so we have Taba from Brisbane, Australia. Epidemiology and determinants of outcomes of hospital-acquired bloodstream infections in the ICU, the Europact 2 trial. Looking forward to the presentation.
Hello, and thank you for this opportunity to present the first results of the Europact 2 study. This was a multinational core study of hospital-acquired bloodstream infections managed in ICUs, and the study was supported by both ESICM and ECMID. Our inclusion criteria were very simple: adult patients with a hospital-acquired bloodstream infection. So that's a new positive blood culture acquired more than 48 hours after hospital admission, stringent criteria to exclude contaminants, and that was treated in the ICU, so that could be acquired in the ICU, or if hospital acquired, the transfer to the ICU should have been directly related to this infection. A true multinational study, as we had 333 ICUs in 52 countries, most of them in teaching hospitals, and most of them in mixed medical surgical ICUs with a median of 14 ventilator beds. We had 2,600 patients with full data to be analyzed. A bit more than half were acquired in the hospital before the ICU. Very high severity, as admission substitute was 49. At the time of BSI, the SOFA score was 8, and 69% of the patients were ventilated. By day 28, 37% of the patients had died, and of the survivors, 24% were still in the ICU, 22% still in the hospital, and 16% discharged from the acute care setting. Most likely sources were principally respiratory, followed by catheter in 16% of the cases. There was no definitive primary source. 15% were intra-abdominal, 7% urinary, 55% required source control, and in 82% of the cases, it was considered as satisfactorily achieved. Pathogens, mostly gram-negative, principally Klebsiella, followed by Acinetobacter, E. coli, and Pseudomonas. Very high resistance rate in those. 31% of gram-positives, firstly Enterococcus, Staph aureus, 9% of coagulase-negative Staph, and 2% anaerobes, and 8% fungus, of which half were of non-albicans species. So this was really a team effort during this extremely difficult year, and I would like to thank all the investigators at each site for all the work they did, the national coordinators and the steering committee for their important work, and the management committee. And I would like to acknowledge the funding that made this possible from ESICM and ECMID, the Norval Dahlia Foundation, and Redcliffe Hospital. So thank you, everyone, and there will be a lot coming in the next few years. Thank you.
Thank you, Alexis. My first question to you is, 37% mortality. I mean, I would expect that in septic shock, which is the common denominator for this kind of patients. So why do you think you have such a high mortality rate in this kind of patients? An explanation?
Well, if we take the new criteria of septic shock, we had 60% that had sepsis and only 35% that had septic shock, because you need the lactate to be elevated at that time point. But I think there is much more to severity, and the SOPA score was 8, which is pretty high. I think what makes the high mortality of this cohort is they're all hospital acquired. So that's patients that are coming to hospital for something else, and then they acquire a very severe complication that's higher than the first Eurovac study about 10 years ago, which was 33%. So we have a very high severity of illness and mortality risk, and that's something that is really expected in this cohort.
Yeah, and also I realized and 24% still in the ICU at day 28, so also there. So how much patients were on VV ECMO in this cohort then?
Well, actually very few, and that was I was expecting a lot more, and we have about 350 patients with COVID-19, because the study started before the pandemic but went across. And there's about, I think, 20 patients with ECMO or something, quite a negligible number for this cohort.
Just for clarification, if I have followed all right, but you have shown us various sorts of infections, starting with respiratory catheter and urine infections in the urinary tract. And did you analyze the mortality of all these separately from each other, or is it only one big number that we have?
No, we have stratified by sources, and I think the mortality of respiratory infections is much higher than, for example, catheter or urine, and that's also in keeping with the previous literature. For a pneumonia, it's 30%. For a urinary source, it's 6%. Primary infections have a mortality of around 18%, so it's very different according to the sources. What I must remind is that's the source of a positive blood culture for all the cases.
That's why I wanted to ask it, because I was expecting this to happen instead of one single number, but thank you for that.
Yeah, so it will be. We were looking forward to the publication of your results with the more details, and we are continuing, Joseph.
Yes, the last speaker will be Misset from Liège, Belgium. The prevention of ventilator-associated pneumonia by noble metal coating of endotracheal tubes, a randomized, controlled, double-blind, multi-center prospective pilot study.
Ladies and gentlemen, I am presenting you a multicenter trial assessing the efficacy of tracheal tubes coated with noble metals to prevent ventilator-associated pneumonia. Prevention of VAP is based on bundles. Usually, coating the endotracheal tube is not part of these bundles, despite at least one large trial which was positive in 2008. Recently, coating urinary catheters with noble metals was proven to prevent bacterial adherence and colonization in a very large Indian population. The present trial was a multicenter trial in the area of Liège in Belgium. We planned to include 300 patients. The tubes were provided by Bactiguard, and they involve continuous aspiration of the subglottic secretion and coating with silver, gold, and platinum in the intervention group, and no coating in the control group. We use bundles for VAP prevention. The trial was blind. The principal endpoint was the diagnosis of VAP, and this diagnosis was established by an independent physician who was not in charge of the patients at the time of the trial and who established his diagnosis on the patient's records. On the right of the slide, you can see the flowchart of the trial, and we included 323 patients. Here you can see that the population was similar in the two groups in terms of severity at inclusion, and please note that about 75% of the patients received antibiotics at the time of inclusion. Here you can see the results. The main endpoint was the occurrence of VAP. You can see that VAP was twice lower in the quoted groups, but this did not reach the statistical significance. On the right of the slide, you can see that the time to VAP occurrence was longer in the quoted group. And in the lower part of the slide, you can see that in multivariate models, coated tubes and antibiotic at intubation were independently preventive of VAP occurrence. In conclusion, in this randomized trial, the time to VAP was delayed in the group of patients intubated with a tube coated with novel metals. We believe that the trial was probably underpowered for the principal endpoint, and we consider that a confirmatory study may be necessary on a larger population and in other centers. Thank you for your attention.
Thank you very much for this presentation. If I see the noble metals here, silver, gold, platinum, it must be a very expensive study happening there. Stefan, I thought you had a question. You go first.
I have one very quick question from my understanding. So the VAP bundle was in both groups, right?
Yes.
Okay. And my main question, so you said most likely it is underpowered. Have you made a power calculation now? How big of the study would you need, or number would you need, so that you would be adequately powered for a next study?
Oh, in fact, we have not yet done an estimation for a future study, but what we found was we did not expect exactly this kind of results. We did not know at all whether we would have something significant. At this time, we have to discuss a new trial with the company, which is supposed to commercialize this kind of device, because, as you said, the device may be only commercialized by one company, the one which is able to provide the tubes, and so we do not have, but I expect that probably the number of patients to include would be around 1,000 or so.
Okay. Can you briefly explain what precisely the noble metal is doing to have this effect?
It is supposed to, I believe, just to prevent the colonization of the tubes. That is what has been observed in the particularly the urinary catheters. So that's just to prevent the colonization of the tubes and the survival of the bacteria.
The interesting question, so if you say 1,000 patients, so what is the effect size you estimate for this catheter, because that would be the important question, because these will be more expensive than the normal ones.
The effect size depends on the endpoint. If we look at mortality, it's not the same as if we look at the incidence of VAP, of course. So as you know, the mortality of VAP is probably low, and it's difficult to be sure that we have a clinically pertinent outcome endpoint. If we if we want to reduce the number of VAP, I believe that we should plan to reduce by half of the number of VAP. That is what we observed here. And for this kind of reduction, we probably need about 1,000 patients, two groups of 500 patients.
But at least, I mean, such an effect reduction would be clinically meaningful. Okay, thank you very much. So thank you all very much for this very interesting session of the best oral presentations too. And we say thank you, and we hope you enjoy continuing watching our Congress.
Thank you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community. Hello everyone, and welcome back with us. A great pleasure to host this session about fluid management in COVID-19 with my friend and co-host Jean-Louis Teboul. Jean-Louis Teboul needs very little introduction when it comes to hemodynamics in intensive care. He's also the current treasurer of the European Society of Intensive Care Medicine and future chair of the Congress Committee. So hi Jean-Louis.
Hi everyone.
And we have a great panel to discuss with us, so I would like to welcome Nadia Aissaoui from Paris in France. Hi, Nadia. And Flavia Machado. Hello, Flavia, from São Paulo in Brazil. And Daniel De Backer, another friend, and also past president of the European Society of Intensive Care from Brussels in Belgium. So welcome all. And before we start and ask you your view on fluid management and COVID-19, I was chatting with my co-host before starting actually, and I was wondering, we've been given this task about this session, but Jean-Louis, do you think there is a real difference between fluid management in non-COVID patients and in patients with COVID-19?
I prefer that they answer this question, otherwise the session would be too short. I will give my opinion after.
Okay, maybe we can start with the panel then. Nadia, can you give us a brief overview of what you think about this topic?
Not easy. Indeed, in the first wave, we had many patients which were very dehydrated. On the other side, we should be careful because many of such patients have ARDS. So according to the last recommendation, I think we should manage such patients as usually, and the COVID-19 patient, COVID-19 does not change anything.
Okay, that was a very clear, short statement, so thank you for that. Daniel, do you agree?
Oh, more or less. I mean, it's clear that we should pay attention to every aspects of these patients. And in the first wave, we had perhaps a little bit more patients with acute kidney injury, because indeed these patients were kept very dry because everybody was afraid of giving volume. And on the subsequent waves, we faced a little bit less of this because we were treating these patients more classically. But when I say classically, we're still very, very cautious with these patients, and still more cautious with these patients with a marked increase in permeability due to this diffuse endothelial function. And compared to, let's say, another septic patient, these patients have a more pronounced lung involvement, so that indeed at some point we need to be more cautious because the security to fill this patient is much lower compared to others.
Yeah, that's, it's very interesting because when I ask these questions to friends around the world, I get very different answers, and everyone says the first wave was very different from the second wave. But for instance, in the first wave in my hospital, we had very little renal failure, but we were trying to manage the patients not differently from the others. And then maybe, things change on the second wave, and we can talk later maybe about secondary infections and so on. So I think the truth that there was a lot to do, and also now as a team in your hospital, in your institution, you were trying to approach a problem that we didn't know, and where we really had to put a new strategy in place for something completely unknown. How was it in Brazil, in São Paulo specifically, Flavia? I think you're on mute. Flavia, you are on mute, I think.
Sorry about that. I don't think that we have first or second wave. We have this same wave up to now, and now we are actually finishing our first wave. But I used to say that COVID patients should be treated like non-COVID patients. But regarding fluid management, I don't think so. I think we need to keep it simple, but they are different. I think that we have a very nice paper coming from the group of Jean-Louis Teboul saying that extravascular lung water and the permeability index are quite different in this patient. They have so much more frequently acute cor pulmonale and right ventricular failure. So as my colleagues already said, the risk it's so higher. And by contrary, I think that hypoperfusion and hypotension are equally dangerous for them. So what I think is that we need to do this wisely. And we haven't done this at the beginning. We were so afraid of giving fluids that we kept them very dry. And for this, I think we had a lot of renal failure that we didn't need to. And as we treated them more wisely, we probably protected them more nicely from hypoperfusion and from hypovolemia. And we learned with them, and we are doing better now. But we had a lot of renal failure. In my hospital, for instance, we have a publication. We have the data, and our patients have 35% of renal replacement therapy. But it's because we were a reference center for transplant patients. So it was quite hard to manage fluid on this patients, trying not to lose their new kidney.
It's very interesting, the topic about renal failure, because it is, of course, to do with hemodynamics and fluid management, but also, as we know, maybe also with intrathoracic pressure and, maybe PEEP levels that I suspect were used a little bit more generally at the beginning, at least. That was a common practice, speaking with some colleagues. So I think it's multifactorial there. But Jean-Louis, now you need to give your answer.
No, I think that everyone, I agree with everyone. In my opinion, we should treat these patients as we treat the other patients, and we need to assess the benefit-risk ratio of giving fluids before giving fluids. That's it. So this is what we do for other ARDS patients. So we do this for this kind of patients. This kind of patient can be dehydrated, I said by some of them. They can be dehydrated at the beginning. They could have some secondary infection with sepsis, with relative hypovolemia, or also absolute hypovolemia. So we have to consider they can be hypovolemic relatively or absolutely. And also we know that the majority of them have ARDS with a risk of severe hypoxemia if we continue to give fluid or if we give fluid. So we need to assess the benefit-risk ratio. This is very important, and this is as we do in other situations, to personalize our treatment, not to consider that we have to avoid to give fluid or we have to give fluids. Anyway, we have to assess the benefit and the risk.
Yeah, very important. We're also getting some questions from the audience and from social media. People are following us. Maybe I jump to a slightly different topic, even if I would like to come back later to how we approach these patients. But we also have some questions about type of fluids. And some people may argue that we talk too much about COVID-19. Maybe we should talk also about sepsis in this context to remind people about this. What's your practice? Is it just crystalloids? Do you use albumin in these patients regularly sometimes? Again, maybe Flavia, you want to start. You recently published a paper, not on this group of patients, but on balanced crystalloids. Maybe you can give us a little bit of a view on this.
Yeah, usually I don't think that we need albumin at all. I think we can manage them with crystalloids, but of course, some people still think that albumin has a role when you give a lot of crystalloids. What I think is that we never give a lot of crystalloids anymore, so maybe the role of albumin is very restricted. Regarding the type of crystalloids, I think that with the recent results from BASICS, of course, I have to say that I think we don't have any preferred crystalloids for the general population of the ICU. We have the results from the similar subgroup of septic patients. We have, this morning, the excellent presentation from the Surviving Sepsis campaign and the systematic review and meta-analysis for the current data suggests that maybe in septic patients, the balanced solution can still play a role, and the Surviving Sepsis campaign now suggests balanced solutions instead of saline, but the results from the basic study are not there. And we have 2,000 patients, septic patients, on the basic study. We don't know what is going to happen when we add these patients to the Surviving Sepsis campaign meta-analysis, and we do not know either what is going to happen when we add the plus results that I think we will have available soon. It is still possible that in the sepsis population, balanced solutions might be better, but I think we have to wait. However, as I always say, I think it depends. Again, it depends on the baseline mortality, and something that changes mortality in a place might not help in another one. In this basic study, the balanced solutions did not help in the subgroup of the 2,000 patients they had. There is no difference in mortality for the septic patients in the basics. This was a pre-specified subgroup analysis, and now let's see the meta-analysis. But we have also to say that the baseline mortality of our 2,000 patients is 49%. And the mortality for the similar, the Brown study on sepsis is 26-31. So maybe something that can change mortality in US with the baseline quality of care cannot change our mortality because we are still seeking for quality of care. So let's see. We have to put this all together.
I have to say that even in the similar study, the signal on mortality was significant, however small. So, you know, I think it's also important to remember that. I saw Daniel maybe raising an eyebrow on albumin before.
Exactly.
Sure.
Exactly. So in our practice, we're really very liberal in using albumin, because when you see this patient with lung edema and you have and sometimes edema where you need to give some volume because indeed these patients are hypovolemic, tachycardic, whatever, and we have very low albumin levels. I think that, well, albumin has a place has a place there, and so we use quite liberally albumin there. As we previously demonstrated in other septic patients, when you give albumin, you can raise albumin levels, so indeed everything is not leaking to the interstitium, and it gives us the feeling that you can at least limit the amount of fluids you have to give to these patients without giving liters and liters that you have to give when you just give crystalloids. So I don't say that initially you don't give crystalloids, of course, but at some time, after 2-3 days, when these patients still may present some requirement for fluids, then it's not unusual that these patients have very low albumin levels, and we give albumin in this context. Also, in the stabilization phase, giving furosemide together with albumin is something we also practiced a bit on the following of the Greg Martin trial, which was published, I think, 15 or 20 years ago in RDS patients. So I think that the place for albumin is still there in these COVID patients.
Nadia, I think then Jean-Louis is also a question for you, but Nadia, do you want to also to weigh in?
Yes, sure, thank you. I don't know. I was saying we have to do as usually. I think many of us tried to do differently because of specific physiopathology and protocols of centers, but when you have a look at the result at the end, and we have some publications regarding the topic, the mortality seems to be the same during the last 18 months. So I don't know. We perform balanced crystalloids, so I recommend to do that and not to change the usual management of IRDS patient with septic shock. And I think nobody has a right answer now.
suspect you're right with this statement, but Jean-Louis?
Now I have one question to Daniel, but finally you almost already answered. You base your strategy of giving albumin on the albumin concentration, right? And do you have a number in mind, or just it depends on the context?
Or usually below 25, we think at giving it at that point.
Comment, in fact, I go back to the first question. Do you do differently if the patient is intubated or not? For example, if in terms of fluid management, I say, do you consider a patient with a high flow oxygen nasal oxygen, if you consider the same as a patient with mechanical ventilation, sedation, ventilated, and that's it? Or do you refrain to give fluid to the patient with high flow compared to the others? For you, it is the same. You do exactly the same. It's not my case, to be honest, because I'm more comfortable when the patient is ventilated to do to monitor the patient, and it is more comfortable situation for the physician. I don't know for the patient, but for the physician, it is more comfortable, and probably we are more reluctant to give fluid when the patient is not intubated because of ARDS, and we do not want to worsen the situation. What do you think about this?
I just think that on the non-intubated patient, if you already have problems to assess fluid responsiveness in an intubated patient in low resource settings, we will have even more in a non-ventilated patient. So, but in a balance, the benefits and risks, it will be more difficult. What I'm trying to say, we have to construct a protocol for the Minister of Health in Brazil. And then we have to say to people what they have to do in every setting, not in the most nicest ICUs in Brazil, where they have everything, where they can measure pulse pressure variation, where they have an echo at the bedside, but on the UPAs. UPAs are emergency services without a hospital. They have to transfer patients. They have to give the first care, and sometimes it would take 1 or 2 days until they find a hospital to transfer a COVID patient, even if the patient is intubated. So when we have these guidelines, we have to say to them what you have to do with the hemodynamics of a patient in a UPA outside of a hospital if the patient is on high flow, in non-invasive ventilation, or intubated. So what we said to them is, if you are able to assess fluid responsiveness, go to this flow. So assess fluid responsiveness. And if your patient are needing fluids, and if he is fluid responsive, give fluids. If you cannot access fluid responsiveness, and he has signs of hypoperfusion, give 500 ml and see if he has a clinical response. If he has, give more 500. But if you cannot access fluid responsiveness, don't give more fluids. So I think, Jean-Louis, it will always depend on your resources. And of course, if the patient is not intubated, if I don't have the resources, I will be much more afraid of giving fluids to a non-intubated patient if I am in a place with no resources.
It's a very important question. Thank you for your answer, Flavia. I think, Daniel, you have a comment there. I think, Jean-Louis, you're absolutely right on your question, because, you know, in my mind, I only thought about intubated patients because of the number of beds that we had. Basically, all the other patients were managing level 2 ICUs. But Daniel.
Well, I mean, I agree with the fact that it's much more complicated in low resource, but these patients are low resource even in high resource country, because these patients are almost not monitored. You cannot really apply the dynamic measurements. I mean, these patients are with high flow, but they're also prone. And so doing the passive leg raising is not really something you can do. So a lot of things make more complicates the fluid management in these patients, and also perhaps slightly more risky, because indeed the consequences in an intubated patient is to perhaps have a worsening of gas exchange, but in a non-intubated patient, worsening of gas exchange may mean intubation. So the risk-benefit is not that well in these patients, and the major problem we sometimes face in these patients is that they are so sick, they do not eat, they do not drink. We are depriving them for fluids because we are afraid. And then at some point, we realize that when we intubate these patients, well, these patients are really very hypovolemic at that time.
This is exactly what I mean. When we intubate this patient too late, not too late, or I don't know, too late or not too late it's another question. But when we intubate this patient after 2 days, for example, and we observe that they are very dehydrated, absolute hypovolemia due to the fact that we did not give a lot of fluids, they do not drink, they also are dehydrated due to the high flow oxygen, nasal oxygenation, and so finally they are very, very hypovolemic. This kind of patient who stay a long time without intubation. And so we have to be very careful.
Absolutely, and they're very different, especially in this initial phase, from when they come to the hospital and they deteriorate, coming to our attention. There is a huge range of presentations there. I think when we refer to conservative liberal management, we have more in our head the patient that is being stabilized and is now being ventilated, but that's a different situation from the first 24, 48 hours. Yeah, I think you're absolutely right there. Nadia?
Yeah, thank you. I do agree with Daniel. I mean, we are often very careful regarding giving fluid in non-intubated patients, having the fear to worsen their state, but indeed they are often dehydrated. In the other side, patients requiring mechanical ventilation at the beginning are often more severe. So as Flavia said, we have to monitor what we do. So does my patient need fluid volume? And actually, it seems to be more difficult to assess patient with a high flow volume, because it's easy when the patient is under sedation and receives mechanical ventilation. We can go inside the room, we have some monitoring. In other patients, we are often a little bit sorry to go inside the room to perform echo and other assessment. Regarding the resource of the ICU, there is a nice review published in ICM 2019, conducted by Daniel and Maurizio, and there is a lot of parameters which can be useful to assess patient and hemodynamic status without very nice tools. So I mean, in emergency room or in ICU, which does not have a lot of resource.
Yeah, I would like to elaborate a bit more on the question on intubated patients, because it is actually known more and more now that even these patients, they do require often very high level of sedation. And we found that sometimes the vasoplegia has a dual aspect there. One could be related to the hemodynamics and to the interaction with the ventilator, and of course the disease, but also to the level of sedation. Can you tell me a bit more, how do you judge whether you should give fluids in this moment, or maybe adding a little bit more vasopressor? Because in my experience, I've certainly used a little bit more vasopressor than what I was doing before, exactly for the high level of sedation that I had to use. Daniel, I see you nodding there. Maybe you want to start?
Well, I fully agree with the fact that treating vasoplegia induced by drugs should be treated by vasopressors. Fluids are not really the solution there. The most difficult part is when you correct blood pressure, do you mask some degree of hypovolemia that needs to first be corrected, or we just you just go back to the initial state if you were not treating this patient with these drugs. And so this is often the most complicated aspect. But as you mentioned, we give very liberally vasopressors there, often very low doses that just counterbalance the impact of the drugs that we give for sedation, which is indeed often heavy sedation. But the same is true for the high P, which is still quite used in many of these patients. And then the question comes to the right ventricle, which will be probably the next question for the panel.
So, Flavia?
I think I agree with Daniel for sure that damage done by drugs should be treated by drugs. So vasopressors is the first choice. The tricky thing is if it is only sedation. So if it is just a slight hypotension, okay. But this is not the pattern that we are seeing with our patients. We are seeing a lot of shock, really shock. And not only on the beginning, maybe on the first day or the second day, it might be that it's just sedation and peak. But at least in our settings, we are facing multiple organ dysfunction and refractory septic shock as the main cause of death. So here we have, on the 6 first months, we have 600 patients, and 65% of the patients died. Of those who died from refractory septic shock. So it doesn't seem so easy for me to know that it's just sedation. And we have this very nice paper coming from Stephen Hollenberg showing that he measured and he did echo in 150 patients that were COVID patients using vasopressors. And at least 40% of those patients have a ejection fraction, a normal ejection fraction, and a low cardiac index, showing that they were hypovolemic. So the problem is, as Daniel has already mentioned, to be confused by vasoplegia or hypovolemia. So we need to be sure that we are not treating hypovolemia with a vasopressor. And I think this is quite tricky.
And we were discussing with Jean-Louis before this, actually, how the presentation was different, at least for us, according to different waves. Because, for instance, I remember my first wave of patients, I had very few patients with shock. And then during the second and third wave, I had more patients sometimes coming with secondary infection after prolonged treatment at home, and with septic shock from other reasons, not necessarily related to COVID. And that changed completely. I was wondering, maybe Nadia, if you want to make a comment there.
Yeah, I do agree with you. We have the experience of, at the beginning, the issue was more hypoxia and respiratory failure. And during the other waves, we tried to keep patients at home or at other wells. And when they came, they were more severe with more secondary infection, acquired infection. So, as Flavia and Daniel said, regarding hypotension, we have to know the cause. And first, if the hypotension is induced by medication, we have first to correct the effects by vasopressor, but if hypotension remains, we have to investigate that and to make assessment to see what causes the hypotension. So as usually, echo or other parameters, do we have any hypovolemia, and we have to manage that.
I wanted to comment on what Flavia said, and Daniel also said about the risk of creating some confusion about true hypovolemia, which was masked by vasopressors. A way to do very simply at the bedside is to look at the diastolic pressure, which is a marker of tone, and in general, when you have a low diastolic blood pressure, you can do you can give vasopressors because the tone is low, and this is very simple to do. And I agree that we should not mask hypovolemia, but we also should correct vasoplegia, and vasoplegia can be created by sedation, of course, but sometimes with septic shock due to secondary bacterial infection. We use now dexamethasone a lot, of course, as you probably also. And we have more, I don't know if it is because of dexamethasone use, but we have more secondary bacterial infection and sometimes septic shock. And what is your experience about this? Compared to the first wave, or maybe there is only one wave in Brazil, but the beginning of the pandemic in Brazil, for example, and in other countries, do you have more secondary bacterial infection with the consequences on hemodynamics and kidney function?
The question is for you, Flavia.
Can you repeat what he said? If you think the difference in the country, Jean-Louis, can you say it again?
I noticed, but maybe it's not true, but I noticed that since we use dexamethasone, corticosteroids, we observe more secondary bacterial infection and sometimes septic shock than at the beginning of the disease, beginning of the crisis. Do you observe these kind of things in Brazil?
I'm not sure it was the corticosteroids or the IL-6 inhibitors, Jean-Louis. I think that in Brazil and in other settings, we just have more problems with nosocomial infections, as we already had. As we all know, the incidence of nosocomial infection in ICUs is different among countries. And maybe it's not only the way we're treating patients, it is just the baseline rates of nosocomial infections. And then we are treating more severely ill patients because the COVID patient is much more severely ill than our usual patients. And of course, all the bundles and the prevention and everything we did to prevent nosocomial infection, which were not so nice because our rates are high, were even worse during the pandemic. And this happened everywhere. So I don't think maybe corticosteroids and IL-6 inhibitors might have played a role for sure, but I wouldn't say it's a major role. And you know that the incidence of nosocomial infection was not increasing only in resource poor settings. We have data now coming from the US showing a huge increase in 2020. We have this nice paper coming from Italy showing 45% of nosocomial infection in COVID patients. And I think it is coming from the first wave, but Mauricio can say it better. Mm-hmm. So I think it's not treatment. It's us.
Okay, we have other questions coming from the audience. Maybe Nadia, I think this is the $1 million question. It's about fluid balance, so I guess related more not to the first day. How do you actually measure fluid balance on a daily basis? Do you use scales? Do you take care of insensible losses? I can tell you I asked these questions when I used to round intensive care units around the world, and I got very different answers. So I'm very interested to hear yours.
Thank you for the question. So we are, as I said, very easy people. So regarding fluid balance, we have in one side the weight of patients and how we have some easy bet to do that. And we carefully pay attention about all fluid we give, the food, and the diuresis. So we don't think about assessing something we can imagine. For example, my patient has fever, so I can imagine that it may increase, so it may change the fluid balance. So very easy tool.
Daniel? Well, I'm really frustrated when I would like to look at fluid balance in these patients because it's very difficult. You have patients that do not pass stool for 3 days, then they have with diarrhea for 3 other days. So where do you count these fluid losses there? Was it 2 days before? Was it nowadays? So, I mean, it's very hectic to look at fluid balance because you know what you give, sure, you know what is coming out easily measured, but you have a lot of other potential confounders, which make things much more complicated in these patients, especially because of the gastrointestinal problems they present and the high fever they often had, at least for the first 2 or 3 days. So we pay attention more to what we give to try not to give excessive fluids through medications, and we give a lot of medications in these patients, especially when we come to antibiotics and others. And so often we try there to pay attention to fluid balance, but we are not too rigid and too strict on it because we know that what we measure is not really what exactly is the real fluid balance of these patients. And for the weighting the patient, it's the same. I mean, if the patient retains stool for 2 days, well, he will inflate when he will pass the stools and it will decrease the weight. But what is exactly is the true fluid balance there? So it's a little bit more complicated again.
Well, I'm glad I'm not the only one finding it difficult after many years of intensive care. Flavia?
I'm not sure I have anything to add. I fully agree with both. It's difficult to measure, and we will make it wrong if we try to keep it simple, but I can't see any other way to do it pragmatically, either doing it simple.
I have another question about de-escalation, or maybe the late phase. When do you decide, and on which basis you can decide to remove fluid, for example, by diuretics or by ultrafiltration or any other means? But when do you decide on which basis in this kind of patient with ARDS, of course? I speak about ARDS patients with COVID-19. Yes, Daniel?
As soon as a patient begins to be stable, we try indeed to, at that point, first limit the amount of fluids and then to try to indeed get off of some of the edemas that the patient may have. However, we have to admit that, especially in COVID-19 patients, because of these secondary infections, we have often these hiccup phase, meaning that for 2, 3, 4 days you will go for trying to de-escalating and to try to remove fluids, and then the patient gets infected again, and then you have to give more volume at that point. So, and we know that these patients will stay in the ICU for 1 month. So it's really these kind of up and downs we have to admit. But I think it's, in my opinion at least, it's better to try to retrieve the fluids when the patient gets better, even though when the patient will get worse later on, well, we have to give more volume at that time than to keep the patient overhydrated for a more prolonged period of time. But this is my way to do.
Nadia?
Yes, as Daniel, as soon as the patient is stable and does not require any vasopressor, because I have some experience with a beginning fluid removal a little bit early, and the end of story is mesenteric ischemia. So when the patient does not require any vasopressor, except if he has an history of systolic cardiac dysfunction.
Which?
I think we, sorry.
No, carry on. You please carry on, Flavia. I was just, I think we have another question which leads a little bit to what Nadia was saying about cardiac dysfunction, but please finish your comment, Flavia.
I think we are more aggressive than Nadia. We start the resuscitation phase with diuretics as soon as the patient recovers from hypoperfusion. So as soon as the patient is now without any sign of hypoperfusion and it's stable in the doses of vasopressor that he is having, we give him some hours to just stabilize, and then we start to resuscitate carefully, meaning not letting him with a very positive fluid balance on that day. So if today I normalize lactate, capillary refill time, everything, so maybe on the next 24 hours, I will let him with a regular positive balance, and then I will start in the next day to resuscitate and take out off. But I will guide this using ECO, using, we are now using the Vexus score, trying to look at congestion on the vein. So we are trying to modulate how we resuscitate patients.
Thank you, Flavia. We have a very interesting question. It's maybe two questions in one here, but how often did you see cardiac dysfunction on top of what you would expect, with sepsis cardiomyopathy, if we want to bring back what we knew from the past? And in this group of patients, did you use different blood transfusion thresholds? Daniel?
For the cardiac dysfunction, the left heart dysfunction is not increased. The right heart dysfunction should not be neglected in the more severe patients. It's often something that occurs, perhaps more frequently than in the others. But again, in the more severe, we are combining some septic-like effect like in the other sepsis and quite severe respiratory conditions also in these very severe patients. So perhaps the conjunction there is made to have the right heart dysfunction. So the statistically is not really that different, but these patients, the very severe patients, are as the very severe septic shock patients, so they have it quite frequently.
And do you transfuse them a little bit more liberally, these COVID patients with profound hypoxemia? Daniel?
Not really.
No. Okay. I see Nadia agreeing with you with a big no there. And Flavia?
Exactly so.
Just going back to the literature, that paper from Steven Hollenberg, they found a low ejection fraction with a normal cardiac index or not in around 20% of the patients. And they have a huge population. They have more 150 COVID patients with vasopressors. So I think this is a good characteristic. So I think it's more frequently than usual because they have more pulmonary embolism. I think we have seen more right ventricular failure than usual. That is for sure. I haven't seen so many acute core pulmonary in my life as I saw in the last 2 years. That's for sure. So it is different.
And the other part of the question: do you transfuse these patients a little bit more liberally?
No, not at all.
Okay.
Before concluding this session in 2 minutes, I would like to ask you, what is your message you want to give right now about fluid management? So in 2 sentences each. Nadia? Very short.
Take home message, do as usually and paid attention of the right ventricle and the lung.
Flavia?
Be very careful, monitor your patient. Look at each parameter you have access to, every parameter. That's the tricky thing, the secret of treating the patient, and let's try to not harm and be wisely.
Daniel?
Keep it simple and act wisely.
Okay, thank you very much for this very, very interesting session. I would like to thank Maurizio for this moderation, and I was very happy to be with you to chair this session. Thank you very much, Flavia, Nadia, and Daniel for this debate. Thank you very much.
Thank you. Thank you.
Thank you.
Bye-bye.
Bye-bye.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community. Hello and welcome back everyone on this session about the future of intensive care. It's a great pleasure to host it with my friend and President-elect of the Society, Elie Azoulay.
Hello everyone, very happy to be here with this wonderful panel.
So Stefan Schaller, our next chair. Hi Stefan.
Hello Maurizio, hello to all of you.
Johannes Mellinghoff, the chair of the Nurses and Allied Healthcare Professionals.
Thank you so much for having me.
And Frankie Duska, who is in charge of education in the society.
Hello, bonjour.
So, welcome everyone, and let's crack on, really. We have a few minutes to discuss about this, but I would like to hear maybe in a short sentence, what do you think is going to be like in intensive care, I don't know, in 30 years? Frankie, do you want to start?
Well, 30 years, it's quite a foreseeable future, I think, nowadays. We don't know what's going to happen, but there are things that I would bet on, like that the technology takes over at least part of our jobs, hopefully. And, well, when I mean technology, I see perhaps the separation between those who make decisions that can work from remote, perhaps being assisted by some form of artificial intelligence that process big data that are collected in a real time and analyzed and help to make decisions. And, you know, there will be people who are close to patient bedside doing manual procedures, communicating with relatives and taking care of the patients. So that's one aspect, and the other one is that we see it nowadays with the digital transformation of education. And I think our society is a classical example that we managed to transform part of our teaching into a digital form and reach the areas of the world that we would otherwise never dreamed of, you know, and other continents, and education became affordable and accessible. But of course there is price to be paid, and this is that we are slightly losing some kind of hands-on and interaction. So, and we can debate it even further.
Absolutely. So I think I take some points we will debate later for sure about you know, artificial intelligence, machine learning, but also the accessibility and at the same time losing a bit of interaction. Johannes, how is intensive care going to be?
So in 30 years' time, we still be here. So that's the most important message, I think, and you know, that's also a reassuring message that is coming out of a time of crisis that we've essentially experienced. So we earlier heard in another talk by one of our leaders that there needs to be more flexibility. So Frankie already alluded to that with regards to education. We are doing quite a lot to have flexibility in the workplace is perhaps something that we're not quite there yet to develop that. We heard from physiotherapists, for example, who are thinking about different models of working together with others, different work patterns that they have, rather than 9 to 5, do something slightly different. But I think we will still be there. We will still be the main people who will be communicating with the patient, and we will still be responding to, you know, the decision makers at the bedside.
So it's nice to know that we still have a job.
Exactly, so
important.
Yes.
Stefan.
Yeah, I agree with Johannes. So I think there will be a lot of changes with a normal ward, but the ICU and surgery are still things which we will have in hospitals. I believe in 30 years we will have high specialization, and also with the possibility of digitalization, for example telemedicine, I think high quality care can be provided, you know, from one specialist very broadly and very widely. I also believe, as you already have alluded, that digital algorithm-based decision-making systems will play an important role, because we can only see some things like vital signs, you know, but with data, heart rate variability, we cannot see, but a computer can give us much more can see much more information and incorporate it. So I think this will be something changed. I still believe we will also have the high social component. So nursing care will still be important. And I really hope that instead of now where a patient lays in the bed and looks at the white ceiling, we will have much more interaction, not also cognitive, but also nursing or physical therapy. And I believe that also technology can be a possibility to get in contact with family or with social life much more easier.
Thank you, Stefan. Eli, I think you want to say something.
Yeah, well, that's very interesting because technology, but we can consider how safe will it be. We will be here, but will we be happy? And I think that the happiness in the healthcare providers is a major issue. We will be there only if we can be there, and to be there we need to be able to work and to provide, to deliver the care we want, and for that the team needs to be happy. And I'm very interested by the algorithm-based decision making, because I would like to be sure that my residents and fellow will be more competent than the algorithm, at least when the algorithm fails and makes the wrong decision, because it happens.
Yeah.
So we are getting in the 2050 with a lot of optimism, but we are careful about knowing where we are going to.
Yeah, I think you're right. And I actually, from what Johannes was saying, I think we will still be here. When it comes to machine learning and artificial intelligence, we are a bit worried sometimes that maybe we will not have a job. I actually think that for those units that will be lucky to see this advance in 30 years, because I don't think the whole world, unfortunately, will see the same pace. I think the only people that will not work will be the people that will not embrace the technology. But at the same time, there was a quote from a book of Eric Topol that I like very much about the fact that machines, hopefully they will free the time from bureaucratic tasks and electronic health records so that we can actually spend time with patients, because I would find it boring and actually not the job that I would like if actually it's the computer speaking with the family or with the patient.
That's very true. If we are giving more freedom to people, is it to deliver more care and to care for more people? But then what will be the size of the planet in 2050? Or are they going to do more teaching, more research, or maybe getting to better improvements? Or are we going to be less? So we will be there, but how many we will be? What will be the ratio? What is safety? Maybe safety and happiness are not going the same way, and we need to consider that. So what's going to be 2050? From a nurse perspective, I'm interested that we know that across countries, and if we compare the different places where we work, the ratio, so the number of patients per nurse, differs. And outcomes may be associated with this ratio, and we have seen the recent publications that have emphasized how much this is true. So what do you think? Do you think that nurse satisfaction and happiness is also associated with the ratio? If we are taking the ratio and consider the different outcomes with it, what's your answer about that?
I think it's a cultural question that you're asking, and therefore you can see that there's a country difference, essentially. So if you come from a culture where you have a 1-to-1 ratio, like you have, for example, in the Netherlands or in the UK, and it's more or less stipulated by guidance that you should follow that ratio, it's very difficult to backtrack from that, regardless of whether you have technological change or not, because it's got to do with the model of nursing that is being implemented primarily. That's my impression, having worked in 2 countries, even though Germany is a long time ago now, where we had a different ratio and where we had a different model of nursing care provided. So I think for the UK, the reason why people do go into intensive care is because they can actually do this full care rather than the partial care of just doing certain tasks, which Frankie alluded to a little bit earlier, where he said probably it'll be a little bit more task orientated. If it goes that direction, I think you get less job satisfaction, because what we want to do, we want to move away from task care, because we can see now with the pandemic, with the changes in staffing models that we had during the pandemic, introducing actually this type of care is actually causing a little bit of trouble for us in the current situation.
Well, I just want one point that compensates partially, at least, okay. And that is that now you've got a bit of a trade-off. You've got cultures when there is a lot of space for doctors to make individual-based decisions, which is okay as long as you have the best trained doctors. They perform better than something, good for all. And then, like in the UK, there is more culture of standardization of protocols. And when we speak about this algorithm-assisted decision-making, it could bring together better pieces of both. You've got still a lot of individualization, but still standardization which is safe enough, and this would make the feeling of healthcare professionals that they do good, they feel safe and data supported, and yet they are able to individualize treatment a lot. So this is one of the aspects.
Yeah, I think this is an important point, and I also want to answer to you. We have to be aware that also such decision-making systems, they will not failure-free. I mean, they are man-based and they are made by us. We are not failure-free, they will also. But the combination of us with them, I think, is the way to go. And another very important point, what you also alluded is, for example, patient management system. At the moment, we are putting a lot of time, or at least in the ICUs I've worked in, a lot of time for putting data in without something getting really back. Even for science, sometimes it's very difficult because it's not adequately framed so that you immediately can use it for using in science. So I think there has to be much more advantages that we really can use the data immediately and easily for quality improvement and for science.
But Stefan, if you can stay there, I'm going to put you on the stage again.
Mm-hmm.
You know, when we ask the question what the future of intensive care will be, it seems that is almost something that is just going to fall on us. But you represent also the young generation of intensivists in Europe. What way should we shape intensive care? What do you think it's missing today that you would like to see for the benefit of patients, families, and also healthcare workers?
Yeah, actually, when Eli was talking, I realized, you know, we talk a lot of, very often about nursing ratio, but we were not at all also talking about what you said, how many patients should a doctor really take care of. I think this is something we really should start a discussion, and it's on several levels. For example, you know, as a resident, for an attending, and also for telemedicine. I think this is an important thing, and it's because there are no regulation, at least I don't know if there is in Italy, but for Germany it's not. It's something where we can really discuss it on a European level.
We do have a little bit, and also when I was working in the UK, it was roughly, you know, you can talk about one doctor every 8 patients, one resident doctor every 8 patients. That's something like that. But it's changing a lot because, you know, with especially COVID shows that unfortunately we cannot control the demand. And when we have so many patients coming, we're still trying to do our best for caring for so many patients. Indeed, my next question is, ICU capacity is going to increase. I mean, whether we like it or not, I like it because I think it means that intensive care is going to have a bigger role in our hospitals. But are we prepared to scale up our workforce, or what shall we do to cope with this?
There is a way to address this question by saying, what would people in 1980 would say, what will be ICU in 2021? And I believe that there are different issues. One is manpower. I think we addressed it very directly, and I think there is a lot to do because I'm concerned about the different outcomes associated with that. When we say there is one doctor for 8 patients, which is easy to accept, and at the time of surge we have to increase the number of patients, but we also know that at the time of surge mortality is higher. For many different reasons, it's quite difficult to address the different confounders, but we can accept that when there's a surge, there's an increased mortality for many different reasons. So the other thing is, let's take an ideal ratio, 1 for 8, which is, I think, in the ranges of what we can hope for. I would be interested to know what are the outcomes. For the administrative people, it would be the length of stay. If you are enough doctors, you are going to take care for patients for a shorter time period, so then you can increase the number of patients you admit. And obviously, with the time going, we will need to admit more patients in the ICU. But from my perspective, and let's go back to the algorithm-based decision, I believe that in the ICU, we're going to have more patients treated less invasively. But at the same time, as the algorithms have worked in the community and in the emergency, those patients getting to the ICU will be sicker. So we need to see that there will be changes also in the typology of ICU patients in 2050. I would like to share this with you.
Yeah, I think you're right. Maybe Frankie, you want to comment?
Well, we started in 1952 saving children by, providing them 2 weeks of mechanical ventilation. So that was a clear cut, that was a breakthrough, because
and it was a pandemic.
The number of quality of adjusted life of years that this intervention saved was huge. Now we are getting into more and more challenging environment because we look after patients who are being more frail, who are being more elderly, and we need to focus more and more on functional outcomes, because sometimes we have to ask ourselves questions, and let's be honest, who did not go through this, whether we are doing any good. So, and this will continue. I have absolutely no doubt about it that a lot of the operations go to outpatients regimes. There will be little stay on a normal ward, but the patient that comes to, and we as intensivists will be exposed to, will be more and more elderly and frail, and we have to also work on to refocusing perhaps even our research and trials into number of quality of years, we say, as opposed to not providing intensive care or finding other models of how to support such patients.
So if I understand you correctly, you're saying that the gain in outcome is diminishing in the future, so it's becoming smaller for each input that you're putting in?
Well, 28 days mortality is for some intervention not a good primary outcome with regards of research. We should look at whether the patient is alive at 6 months and whether he fails functionally or not. That would be my take of it. And I think this refocus needs a bit of mental reframing in community of researchers as well.
This is an interesting discussion because we are getting more moving from global people and populations to more personalized approach. We discussed a lot with the publication of the Surviving Sepsis Campaign guidelines about, I have an expert of fluids in this roundtable, so about the 30 milliliters per kilo as a fixed way to provide fluid expansion to patients with shock or with septic shock. And we said we need to personalize this. So will the ICU, maybe based on the algorithm-based decision-making, be more personalized in 2050? So in that case, we will find the appropriate outcome for every single patient rather from global population. I still believe that for a global population, we are committed to increase survival. But maybe for different patients, we cannot have the same expectations for a frail and vulnerable one or a patient age 80 than for people who can have and get back their life expectancy after ICU discharge. So what's about this personalized approach that you were yourself considering? Are we going to be more personalized in 2050?
Yes.
Yes,
I believe that. But also would like to go back to the level of care. What you did, no, you said it. So this is was also something what we realized, or what we did, for example, in the pandemic now with telemedicine. So we had, different levels of care, and if we provided telemedicine consultation, but when we realized that it could not be handled then in a level 2, we changed it. And I think this is also the same what you said. We have the different populations. There's some which do not need so much, and others which are really then much more critical care. And I cannot agree more with your thing. I believe that we have to look to provide appropriate care to discussion, and back to your question. So I think this is something where ESITSIM also has a task to do, and how to bring things forward.
And look at the pandemic. In this challenge there have been also so many opportunities, because we've never done research so fast as during the pandemic. We are traveling this weekend, we have our pass checked by different people and see whether we are vaccinated or not. And this connection will grow more and more. So far we've been missing opportunities about getting outcome data from patients. Yes. We will be more and more connected. And I think even trials and research will change the way we do research. Very recently we were talking about digital twins, a new concept for us, on how we can recreate a digital twin of ICU patients. And that could be really going to very granular level of detail. So maybe in the future we will be able to simulate trials, treatments, but not just for drugs, even for organizational issues, for communication issues. And I really think that's something that we should embrace as a society and be an active part on how this can move forward.
Stephen, for the next generation, do you think that teaching will be different in 2050?
Yes, I believe so. So, I mean, there are already concepts that you go to much more simulation, and also like virtual simulation. So you even can do it like from home and try different scenarios. And the first step is, of course, the medical things, but also like communication, crisis resource management. I think all these things will be much more free available. Look at C19 space. We had the goggles at home, and this is the first step, and it will improve. In 20 years, the technology will be much more further. So I believe, yes, there will be a lot of changes.
Yeah, well, I just wanted to point out that it's very dawn, this data sharing, and we still have to be considerate about it. We haven't managed to convince our community, and I'm speaking about Europe, to fully recognize and emancipate our discipline, and not mentioning to allow us and overcome all those legal hurdles to be able to share and process record level data of our patients, whilst obviously maintaining and keeping and protecting their privacy. So I think there is a lot of challenges, and if you say that it's a scope of 20, 30 years, perhaps I'm not entirely sure that it's going to happen.
But maybe we should put efforts to do it, and I think as a society we have the duty to work on this, and we are trying to have an active role now, at least with European institutions about this. At least we start to talk about intensive care now after the pandemic, and I really think this is something new.
We have a period.
You've all given us these views, but if we have to maybe look in practice, in the practical intensive care unit of 2050, is there something that is present now, a device, a technique, a way of working that will not exist in 2050?
I hope paperwork. And perhaps even, I don't perhaps even know keyboards. That would make things very easy.
What do you think about catheters?
In 2050? Yeah, I think we will have catheters.
Yeah, you cannot go wireless with everything, I think.
No, it's not about wireless. I think we can have the development of new drugs that can be administered through other ways. We know that there is a burden associated with ICU-acquired events, and we have reduced a lot with everything related to mechanical ventilation, and I believe safely over years. Now we are considering making different with fluid expansion and maybe giving vasopressors. So we can imagine that everything will be more and more non-invasive. A line is still invasive. It's simple, etc. We have made it very safe over the last years, but we can imagine that there will be no line anymore in 2050.
Let's start with the cables for the vital signs and then the arterial line. I think if we manage to get all the data what the arterial line gives us without it being invasive, that's the first.
Maybe Johannes can tell us from a nurse's perspective, what would you like the doctors don't bring?
Well, perhaps you're not bringing a stethoscope anymore, who knows? I mean, because we've got other devices that are much better, where we can actually listen to the resonance of the chest, for example, that may fully be possible. The paperwork, I think, for an NHP perspective is a huge burden. It stops us from providing main care. Yeah. I would say that is very true.
Source of errors?
Yes. But there need to be some system in place to make sure that we are safe and that we are working within boundaries. I don't know what the system will be. The whole idea of the intensive care unit with cameras where people kind of look at you and see what you're doing, if that is implemented as part of the strategy, I think there needs to be a lot of work done with regards to individuals to convince them that is actually the right thing to do. And I think at the moment there is hesitancy with regards to that.
We have spoken a lot on mobility and how ICU specialists from one country can work in another one. And this is how the society is promoting the free movement of intensivists. You, as a nurse, would you be very happy to have, for example, someone from Germany coming to a UK ICU working with you?
Absolutely. I mean, so
this is a very important perspective.
For me, it's very important, but I think, you know, there is a conundrum, isn't there? Because we haven't got enough people. We are standing essentially at a crisis point, also in terms of older professionals leaving the profession, and then we are going out into, you know, the global ICU kind of group of countries, middle and low-income countries, and recruiting away the healthcare staff. There's a moral and ethical question to be asked, and actually that is also one point, Moritz, in terms of, you know, political decision makers and how we, as a community, can actually influence the decisions that they are making and keep attractive our professions overall. So, you know, we're at the height because we've been gaining quite a lot of publicity, so we need to use that publicity for our purposes.
Well, I agree. And Maurizio, since you're a president, you have developed these guidelines. Do you think that we can align professionals to work the same manner in all our countries so that this free movement will be also accompanied by a kind of homogeneity in the way critical care is delivered in our countries?
Look, if in 2050 we're still talking about the free movement of intensivists, then we've done something wrong.
No, I think
that should be sorted. And in a way, you know, we wrote together our position paper about this, which says basically we believe in the free movement of intensivists. We value how diverse intensive care training is in Europe. As long as competencies are achieved, we think you should be an intensivist. Whether it's a super specialty, it's a primary specialty, a specialty within your specialty, I think that's what we believe. And if we achieve that, Ellie, as a community, the standards of intensive care can only rise. Because my best experiences is when I worked abroad and then I was able to go back to Italy when I got fellows coming from my unit. It enriches you so much, not just for people coming to see how you work, but they tell you how they work. And you find that actually the competencies are very similar, but maybe culturally you go into the problems in a slightly different way, and that can only be of great use for the patients.
Well, I hope that we will have the e-portfolio in a way that you can track your education in much sooner than in 30 years. But it is not to say that there are no differences, but this is perfectly fine as long as we have the well-defined core competencies and however you call them, and as long as the doctor or a nurse, and I'm speaking inactive now, can achieve them, it is perfectly fine that after a period of introduction we have full mobility as any other discipline, and I really appreciate Mauricio's and others' effort to talk to European Commission about that, because it's really important for the future of our discipline.
And it's not just about physicians, of course, it's nurses, physiotherapists, pharmacists. It's really, we have to grow these in all parts of the team.
Because the standardization will also raise those standards, as opposed to encapsulating local practices and local therapeutic rituals, as we call them.
This is what we hope for, obviously.
So, do you think that there will be a job that does not exist now in our teams in 2050? A new figure that should join our teams? Or it would be a new way of working for us?
Robotic technician.
A robotic technician.
Yeah, well, yes, bioengineers will expand, but there would be no kind of these doctors rushing in to provide you a help, like, you know, cardiologists doing TOE for us, because hopefully there will be somebody who takes the images and would be able to consult them online. That's
so greater technical staff will be developed. So I mean, we can see that in some countries that is happening. So that, you know, allied healthcare professionals are, for example, increasing their remit. We just were hearing today about advanced critical care practitioners being one of those groups, but we've got them in diagnostic areas such as sonography, radiography, and so on. We will see that, I think, in the future, and that is driven by the economy, essentially.
You know, I think there will also be the need for new skills also from new physicians, new nurses. With all this technology, we always assume that the technology will be so easy to use that we don't need to know how it's developed. But I think if we want to embrace this change and lead this change, probably we need to be more aware of how these algorithms are done and so on. Do you think medical schools are ready for the next generation, of course, of physicians, but also intensivists? And should we actually have a role also in that way? Frankie?
Well, we are going through a tough time because there is a big shortage of doctors, in part of outlooks due to free mobility. So we are facing more and more students, and at the same time we are trying to offer them the best in terms of contact with patients, hands-on medical simulations, and these two trends are kind of going against each other, don't they? So this is the main challenge we face. So for me, it's difficult to dream at this stage when I have to.
I still dream on that, I must say. I still dream on that because I think that if we are changing the way medicine is provided and critical care is delivered, more people we get into our specialties. If I am able to train in the Czech Republic, spend 2 years in Italy and have a job for 5 years in Germany, there's a lot of chance that I will get into this profession because of that. The problem in many countries is that when you are in a place, you're there for 30 years. So life becomes boring and you need to invent things or maybe to get to some addictions. I don't want to get in this aspect because in 2050, mental symptoms will still exist. I believe that we need also to make our specialty attractive for everyone. And I'm very attracted by the idea of being trained, going to the medical school here, getting for 2 years of residency, and then working in another place. I think that will take me to critical care, and I'm sure that this is one of the major differences. We said diversity, and I'm sure that this includes this diversity too.
Yeah.
And you're a very good example of that.
I agree. Ellie, we talked about all perspective, but we're all healthcare professionals here. What do patients and families expect from intensive care in 2050?
Well, there are data about that. I think it's more about family members. I think that family members expect more that nurses will be more considered. Patients expect that we are going to give more time to family members. And I believe that we need to train to be able to be trainers, to be coach for family members. When we look at the qualitative data of semi-structured interviews between researchers and families and patients and healthcare providers, we are expected to coach family members. There is a new job in the nursing care that is called the facilitator. The facilitator is someone who is doing mostly or only family-centered care. So he is making or she is making the interface between the family and the healthcare team. So this new job, the facilitator, is actually a coach. So we know that no one knows what is intensive care. So when someone is in the ICU and the family member don't understand, is anxious in 70% of the cases, has depressive symptoms in 30% of the cases, acute stress disorder, etc. We need someone who can really coach family member to help them, to empower them to share the decision making, because we know that the long-term outcome will be better for those family members who are able to grasp the situation and be part of the decisions.
And do you think that there will be technology that will help to make things more human? We always, before with Stefan, we were referring to the virtual goggles of the Scene and Think space. Would it be possible to do the opposite, rather than bringing home to the intensive care, bringing your house and your family at the bedside, maybe with virtual reality? I know there have been some experiments in this. For me, any technology that makes more human what we do is something I would be very happy to try. But
of course,
what are the opportunities and the challenges there?
There are many opportunities. You mentioned virtual reality or remote interventions like remote communication. It exists, and during the COVID-19 pandemic, we have used that, and a lot remained in our ICU. So we are still communicating using new media. But the other thing is that we are also able to bring to family members a lot of platforms and interactive media that can help to provide post-ICU care. We know that family members, in about 50% of the cases, and if the patient died and family is into a bereavement process, has symptoms of post-traumatic stress disorders or sometimes complicated grief. And we know that these family members cannot work, cannot care for the family, are with addictions, are with depression, and there is a huge financial burden with that. So we are able to use all the technology you just referred to manage family members. It is being developed. It does not exist today. Of course, we are not going to wait 2050 for that. I hope it will be in the next 5 years.
Well, the question will be how close the family will be integrated. For example, will they stay with the patient as an option? Or in 20 or 30 years, will we have ICU care at home so that the family is being part and then a nurse will be there and the rest is done virtually? So there are different scenarios possible, but that is very vague, of course, because it depends on a lot of how technology will go forward. But it's not, not something we cannot imagine.
It's, I agree that it's more human and it's to be supported, but it's at the same time also much more resource intensive.
Yeah, completely agree.
And this comes to the completely different topic, or the same topic, and it is dying at home. If the patient is on end-of-life care, then most of them would like to die at home, and it's not impossible. It's just logistically very challenging.
Absolutely.
And very resource intensive. So will we go this way?
Stefan, you just mentioned different levels of care. So we may consider some of the different options, like ICU at home, for some of the levels, but of course not for the very high resources demanding critical care.
But perhaps what Frankie just was saying, we can also say that we can create a virtual environment which is much more human for patients. So this is something that I envisage that can be done in the future. We are using virtual environments all the time for simulation. Why can we not do that for patients?
We have the last few minutes. I also would like to focus on how ESIC is going to be in 2050, because we recently did massive changes in the SOPs. You've all done it. We realized we have to bring more diversity. I think that this will be the last table with an executive committee in our position just with men. I think we need to have more diversity, and it's going to be probably the last one because we've seen a lot of changes and new candidates coming forward. And I think the society needs to embrace all these ideas. There is a question for you on this topic, Johannes. As a clinical physicist, I have been a member of ESIC for 4 years now. The job of the clinical physicist is to use physics and technology to support good diagnosis and therapy. Our experience is that it helps to support clinicians hands-on with new technology. How can we make this work more common in our intensive care unit? I think it's a question for you, but maybe it's for everyone. I admit I don't have a physicist in my unit. I would like to have one. I start to have some support from data scientists, but otherwise I still would like to expand my team.
I have not come across that particular specialist area, but as we mentioned before, I think everything that encourages specialization and change with regards to different individuals who we are working together with as a team, should be very welcome. So, I encourage that member to actually come forward and actually make contact with us and then have a discussion on how we can actually do this, because they probably have personal experience with regards to how to do that and how they are being embedded within their unit. And actually on the question, how are we going to look like in 2050? So I hope that all the actions that we've been taken over the last 2 years will lead to a big increase in members for the nurses and allied healthcare professionals. So to perhaps not, in utopia, I would say parity between the medical profession and the NHP profession. I don't think in 2050 we will be quite there, but I can see that happening in the future.
I agree with you. So we have the last 5 minutes of our future of intensive care in 2050. Before we go to 2050, if you have to wish a quick change that we can do in the next 2-5 years, I know my answer, but I will give it as the last one. Which one would you be your wish, Eli?
Well, we said diversity, and I think that we spend a lot of time saying the word, thinking on it, and making changes. As you just mentioned, the next committee is very diverse, and diversity is much more than what we think. I think diversity is also a very good way to attract the next generation by showing that we are like them. In the medical schools, there are people who are diverse in terms of every aspect of diversity, and I think it's an important thing. The second thing is a way we should, it's one of my topic of interest. I think that family members should be included inside the ICU team as partners. We are not doing that. We are pushing the movement, but it's not yet there. We have to, and the COVID-19 has taught us how much not having the family members is a trauma for healthcare providers. So then, having them more as partners for the decisions, if they wish so, of course, not all of them, and it should be a model that is forcing family members, but we need to learn from day zero, not when the decision has to be made, but when patients are getting to the ICU, we need to learn how we are going to empower family members to be able to work with us and to tell us more about who is the patient and what were his or her preferences and values. And I think that this is a hope for tomorrow, not for 2050.
I agree. Your hope, Stefan.
Yeah, I will not repeat yours, so I will go in other directions. So one thing I would envision or hope for is, as a member, you immediately have free access to an individualized training pathway. So the pathway then realizes, MCQ question, whatever, what are your competences, where do you want to improve, where you should improve, and then you get virtual training, from home. You do not have to go there. That I would really envision. There are already computer systems in place where you can do this really, I think, fantastic technology already possible, and I envision something like this. And the second thing is, of course, research, that ASITSIM brings much more together research like, ASITSIM has the ICU data server and we can all access the data, do research on it, something like this I would really love to see.
Before we go to Johannes, there is an interesting question, is on, do you believe on a geriatric ICU for the future? That's an interesting question. I think you mentioned something about outcomes before. Do you think geriatric ICUs?
Well, absolutely. And, it may not be geriatric ICU as a standalone specialty, indeed. It could be a wisdom or knowledge incorporated to, because all our ICUs will be geriatric, perhaps from pediatric ones. So it is the wisdom and the knowledge to be present in all ICUs where we can incorporate the data about how to support elderly patients through their surgeries, how to do it the least aggressive way, and simply focus on not who is alive in 2 weeks, but who is alive in 6 months, and in what functional capacity, how we share the decisions, because in elderly patients we need whole the team. We need our surgeons with us, we need our geriatricians, the medics and all other specialties to put heads around to create an individual patient for such for somebody who is that frail and that elderly, because our schemas for
it's about being proportionate but giving the best chance.
Work.
Yeah.
So yes.
And your wish, Frankie?
2 wish. I'll be very brief because we are running out of time. Intensive care is on Annex 5, recognized in all 27 countries.
Very good wish.
And we've got approval to share the identified record level data.
Yeah. Johannes.
So I think the main wish that I have is that the people have an open mind and stay and have an open mind, and they will embrace flexibility in the workplace. I think this is something that we have learned over the last 18 months that we'll need to take forward and not just to revert back to what we've been doing before.
And me, if I can say the last word, it's a wish, but it's a certainty that all the values that we decided together with the leadership and with the members, diversity, respect, inclusiveness, division and excellence, will guide our actions and will come to the free movement of intensivists and to raising standards of intensive care for patients and families everywhere. Thank you.
Thank you. Thank you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Because your patients can't wait, because your mission is to buy time and save lives, we are here. To face emergency, we have adapted our manufacturing facilities and increased our production capacities. We are here to support you, offering access all around the world to the latest articles and sharing recommendations from the most experienced experts. Assisting the ICU community on how to manage critical patients is always our priority. Aspen delivers more than anesthetic products. It is because you are there for your patients that we are here for you.
Innovation drives breakthroughs in healthcare every day the world over. Thankfully so, because as the world urbanizes and ages, and as lifestyle disease grows at serious rates, the need for healthcare innovations that support quality of life has never been greater. This kind of life-changing innovation is what we live for here at Fisher & Paykel Healthcare. We're invested in problem-solving that changes clinical practice for the better, reduces healthcare costs, and ensures better patient outcomes. There are two words that mean everything to us: care and design. We care passionately about improving lives. Care focuses and inspires our people to put patients first, to purposefully keep innovating and simplifying until we create an original solution that answers a human need. Design enables our researchers, scientists, engineers, and designers to apply their inherent curiosity and desire to do meaningful work.
So, hello everyone. Very happy that you join us.
And we will discuss the daily highlights, and I will have a discussion with the section chairs. And it meant that it helps you to make your choices in the program, and also that you hear already from the experts what they consider as one of the most important things that you should know. And I have the pleasure to talk with 4 wonderful people who also helped to make this Congress as it is. And I will speak with Marlies Oosterman, with Xavier Monet, with Geert Mevrouw and Claudia Sandroni. And I will start off, if I may so, with Marlies. Marlies, are you there?
Hello, Amand.
Ah, good to see you. Good to see you all. Good afternoon, Geert, Claudio. So let's start with you, Marlies. You are the chair of the section of acute kidney injury. And can you tell us what you consider as most important, what you have heard in terms of the developments that we have over the past years, especially the last year, and which things have changed in your opinion?
Thank you, Amand. It's a great honor to participate in this highlights discussion. I want to start saying that the Congress truly reflects and lives reflects what has been happening in critical care nephrology. And when I look at lives, it stands for linking innovation, vision, excellence, and science. And this is, I hope the audience will agree, reflected in the various sessions. So the last 12 months, I've had many landmark papers related to the management of acute kidney injury. Fluid remains of major interest, and we've seen the results of the reverse trial published. I'm very pleased that the key author of the reverse trial is presenting the keynote lecture at this Congress, Suvi Vara, and she's an expert in the fluid management of acute kidney injury. We've also got papers published again in the last 12 months related to timing of renal replacement therapy. And again, the key authors will discuss their results. The papers were the START AKI trial and the AKIKI 2 trial. And again, they will be summarized in a whole session related to the practice of renal replacement therapy. And overall, there has been a lot of innovation in critical care nephrology related to earlier diagnosis, biomarkers, biomarker analysis, and attempts to diagnose kidney injury continuously, ideally at the bedside. And these various attempts to progress and advance the management of critical care nephrology and acute kidney injury, again, have all been summarized in a fantastic session which relates to new advances and progress in acute kidney injury. There are still areas which are of major debate and controversy, and the good thing is that the numerous experts in the fields, including authors of landmark papers, will be available throughout the whole Congress in the coffee rooms for discussion with the audience. So it's extremely exciting, and it is so exciting to see that key authors of the main papers are present at the Congress.
So Marlies, if I may interrupt you, so you told us something about what has changed perhaps is the fluid management in relation to acute kidney injury. In the past, it was the common sense that you should give patients a lot of fluids to make sure that there would be no pre-renal problem for the kidney, and we forgot about all the edema that provoked. Can you tell us a little bit about the importance of the fluid management that will also be dealt with during this Congress?
Sure. So it's been recognized that too much fluid is also harmful. So we've always known hypovolemia is harmful, but we now we've learned to appreciate the concept of renal congestion, and we have learned that the kidneys, like any other organ in the body, they don't like to be swollen and congested. And in fact, acute kidney injury can develop and progress in patients who are fluid overloaded. We believe it's due to the fact that the kidneys have a tight capsule and that fluid overload leads to high intrarenal pressures. And if that is true, then clearly the question is, can you prevent acute kidney injury, or can you prevent progression of acute kidney injury if you prevent fluid overload? And this was the hypothesis of the REVERSE trial, which was led by Sugi Vara on behalf of the AKI section. And it looked at patients with early acute kidney injury who were considered to be euvolemic by the clinical team. And patients who were considered to be euvolemic were then randomized to usual care, according to the management by the clinicians at the bedside, versus attention to preventing fluid overload. So patients were remained euvolemic. And it's a feasibility study. Really, the aim was to show whether our protocol worked. The good news is that the protocol was very safe. The protocol allowed us to prevent fluid overload. There was a major, significant difference in fluid balance between the two groups. And more importantly, patients in the intervention arm had less progression and needed less renal replacement therapy. So it gives us support to progress and continue with an appropriately powered clinical randomized study. But it supports this idea that renal congestion is harmful and that the kidneys, like any other organ in the body, do not like to be overloaded.
Well, thank you very much. There is very much more to say about citrate and heparin and early and later start of renal replacement therapy. But you have all indicated that, and there is a lot of that to find in the program. Thank you very much. For the sake of time, stay with us. We will go to the next chairman, and let's go to Belgium, to Geert Meijfroy. Very good to see you. You are the chair of the section of neuro-intensive care. And, well, some people are sometimes a little bit cynical about the neuro-intensive care, that nothing is changing. But you like to be challenged on that subject, isn't it? So
yeah,
tell us a little bit.
It's true. We always get a hard time for that, but actually, I think this is true for most of what we do, right? I think the major advancement and the major jumps in mortality or outcome benefit have been made over the past decades. And what we now do is we improve in small steps, but that doesn't mean that we do not improve and that we don't advance. And I was very happy with the program here as well, because for us as well, it's a nice representation of let's say the broad spectrum of neurocritical care and how we've been able to improve. And in particular, the idea of precision medicine, it actually is something that comes back in several areas where advances have been made. It comes back when we discuss neuromonitoring. I think neuromonitoring was, I think 10 years ago, was maybe seen, especially multimodality monitoring, was seen as something sort of toys for more advanced centers, but there's now more and more guidance on how to actually use neuromonitoring to improve the management of your patient. And we've seen the BOOST 2 trial on PBTO2 monitoring, brain oxygen monitoring, and now BOOST 3. Also in neuroprognostication, we have more and better biomarkers, I think, and there will be a whole session that we do together with the TEM group on neuroprognostication, which is quite interesting. Because that's often what you see when people become fatalistic about neurocritical care, is that they often tend to underestimate the prognosis of a patient. And the best prognosticator for a neurocritical care patient is when we decide to give up. That takes over in all risk models, and I think we can do better.
With underestimating the prognosis, you mean that doctors think that the outcome is worse?
Pessimistic. Yeah, we're too pessimistic, I think, in some cases. On the other hand, we want to avoid to treat patients with whom with a bad prognosis. So this is a very, very difficult balance to make, but also there advances have been made, and we've selected a couple of speakers from the Neurocritical Care Society, where we are also involved in their Curing Coma campaign, which is sort of an international moonshot campaign to try to improve neuroprognostication in coma. And this is a global initiative, but I think there's a lot to come from that. But here as well, precision medicine and also artificial intelligence will probably learn us more in the future.
And can you tell us a little bit about what you think of the program where people should focus on this, having this in mind?
Yeah, with this in mind, I think we have a live as well as a video on demand session on precision medicine in traumatic brain injury. There's a big interest in traumatic brain injury. We've seen that last year in the huge attendance on our case-based fundamentals. And I think people who were triggered there should definitely go for the live session tomorrow afternoon at 4, but also watch the video on demand. In the live session, there's a presentation of the Center TBI results. Again, the Center TBI is an EU-funded prospective registry of TBI patients with better. There's almost every week there's a paper coming out from Center TBI. It's such a valuable source of information for epidemiology and classification of traumatic brain injury patients, and also will learn us a lot about management. Then the Synapse ICU results are presented by Giuseppe Citerio. Synapse ICU was an ESICM funded trial on how we manage intracranial pressure in Europe. Also very valuable results. And then on the video on demand, we have Marcel Arias, who will present the results of also the ESICM supported Cogitate trial on autoregulation management, another example of precision management in neurocritical care. And Pierre Bouzat will also talk about nutrition management and more specific novel nutrients such as ketones and lactate, and how they can be used in neurocritical care. So that's definitely something you should watch. I think the sessions that I talked about neuroprognostication are also important. And this year as well, we have a case-based fundamental. We're very happy to be selected for that. And the topic this year is subarachnoid hemorrhage. And subarachnoid hemorrhage is a fascinating disease because it's also a multi-system disease. I mean, it will affect not only the brain, and there's a lot of interesting complications there as well, but also the cardiovascular system and other organ systems as well. So this is definitely going to be a very fascinating 3 hours to follow with us, and live and very interactive. So these are really fun sessions to follow.
I think you give an excellent example of how important it is that also the different sections make common programs, as you indicate that the subarachnoidal hemorrhage also affects, for instance, the heart. And it makes it very important that these sections have a program together. Well, congratulations also with the program that you made, and thank you for this contribution. Stay with us, and I think we will now go to Paris, where Xavier Monet is waiting for us. He is the chair of the cardiovascular dynamic section. Of course, a very dynamic section, Xavier, as you are. Can you tell us a little bit about the highlights that you consider as very important that we will see and will be able to see during this Congress?
Thank you very much, Armand, and thank you for giving me the opportunity to speak about this hemodynamic program, which is, of course, very, very interesting to me, but I'm sure to all of our colleagues. In fact, I think that the program reflects what are the most important questions at this moment in hemodynamics. First, it's about fluid therapy, and that's very, I'm very interested about what said Marlies Osterman about fluids and the risk of excessive fluid administration. Definitely the result of the reverse study that was supported by the society is very important, showing us that definitely having a more restrictive fluid strategy actually reduces the fluid balance and also is safe and likely and especially safe for the kidney. So the issue is about fluid administration. We know that the effects of fluid are very short in time, and in this regard, I'm really looking forward to listening to the results of one big trial that will be presented on during the hot topics session of Wednesday, regarding the time over which fluid is administered and the type of fluid that is to administer, especially regarding balanced fluids. And really, I think it will be a very interesting RCT, and looking at these results is really something that might be very interesting. So fluid administration. Then, of course, there are some sessions about, and it's also an important topic in hemodynamics, which is how to monitor the patient. I mean, how to assess the efficacy of the different hemodynamic interventions we have in these patients. Regarding, for instance, the assessment of tissue oxygenation, and there is a very good session tomorrow. I think it's in the morning, quite early in the morning at 9, regarding the cardiovascular challenges. The same regarding early resuscitation on sepsis, and on Wednesday, at the end of the morning, there is a session about resuscitation in sepsis, and the same, we will insist on the different targets. It's also the monitoring of hemodynamics. We had a session this morning in the Philips Symposium. There is another one with Baxter tomorrow regarding the ways cardiac output especially might be monitored and measured in these patients. We have many new devices, and perhaps these presentations may help us understand the role, the position, the drawbacks of each of these methods, because there are many publications about this, and all the devices that monitor these patients are definitely not the same. And also, it's about the targets of hemodynamic resuscitation, and it's linked with the previous topic. Which target should we aim to reach in our patients, for instance, when giving inotropes, norepinephrine, vasopressors, etc.? And there is another big study that will be presented during the hot topics session on Wednesday, which has compared two different oxygenation targets, low normal or high normal. You know, it's been it's a Dutch study that will be presented, and really I'm really looking forward to listening to the results, because it's an old debate we had in the early 90s about should we reach high or low oxygenation targets in our shock patients. And here it's a big study that I think asks this question again, and in a new and in a more modern way. So very interesting again. Finally, of course, as always in hemodynamics, there are many issues regarding the understanding, the way we understand the different cardiovascular disease, and especially shock. I truly recommend a VOD session about microcirculation with a big lecture that will be given, a keynote lecture that will be given by Vanina Edul, an Argentinian colleague, which is always makes some very good lectures all about microcirculation. And another one, which is also a VOD session about basic physiology. All what you should know about basic physiology regarding the lungs and the hearts and heart-lung interactions. And this is also a VOD session that I really warmly recommend. So understanding the disease, looking at the ways to monitor the patients, and looking into details what are the effects of fluid administration and the ways we should perform. And these are the three main topics I see that are covered by this great program.
Yeah, You contributed, of course, very much to make this program as it is. So if I understand correctly, Xavier, so one of the keys that we had, I remember, let's say 25 years ago, people were saying about fluid management, keep them dry and watch them die, and therefore you should give a lot of fluids. That the focus is now much more on giving, well, just enough fluids. The same holds true for the inotropes. Do you agree with me that that is the way that we are going, the direction that we take?
I totally agree. In fact, what we did during the last years is that we understood that fluids are drugs. I mean that their effect is not it is not that common. I mean that in some patients there are no effects on fluid administration and cardiac output, so a constant effect. And on the other side, these are dangerous drugs with many side effects. And so all the question today is to know how should we perform that fluid administration? Okay, it should be restrictive, but in which way? Is it dangerous for any of these organs? And that's why, again, the Rivers AKI study is interesting. Which fluid should we give in this patient? I mean to refine the ways we consider fluid therapy in these patients, again, considering these are drugs just as antibiotics, for instance.
Okay, well, thank you very much. Thank you also for mentioning the study that comes from our department where it was started. So this is a good moment to stay with us, Xavier. So we will now go to Claudio Sandroni. And, well, he's the chair of the Trauma and Emergency Medicine section. And, well, he seems very happy. He's already smiling. Tell us about your section, Claudio. Very eager to know.
Yeah, there is many reasons to smile. Post-resuscitation care has dominated the scene last year with results of new randomized controlled trials. The PURE study on coronary angiography after cardiac arrest, which with COACT study demonstrated that there is no benefit for coronary angiography on a known ST elevation myocardial infarction following cardiac arrest. And the TTM2 targeted temporal management trial that has been published on June 17, which compared temperature control targeted to controlling fever versus hypothermia, which again didn't demonstrate any special advantage, and meaning that we rather control fever rather than performing hypothermia in patients who are comatose after cardiac arrest. And another big bunch of evidence came from the revision of the evidence concerning observational studies, because in this case, no randomized trial will be appropriate, concerning neuroprognostication. Gert has mentioned neuroprognostication in acute hypoxic brain injury, and indeed there is an entire session dedicated to that in this Congress, together with NIC, that showed all the new evidence coming out that completely scrambled our views concerning prognostication. That there is a new role for clinical examination, a new role for EEG, and new biomarkers showing a very high accuracy for predicting outcome after cardiac arrest, and not only poor neurological outcome, but referring to what Gert said before, there is also a chance for predicting good neurological outcome in being less pessimistic in patients who have a massive hypoxic brain injury after cardiac arrest.
Well, you're absolutely right that there are very important things to mention, and you highlighted some of them. Let me pick out one, and that is the mild therapeutic hypothermia. Can you tell us a little bit about it? Do you think it is now definitively settled? Is it now? Do we need more evidence, or is it now completely clear for everybody what we should do?
Yeah, indeed. After the publication of the TTM2 trial, the usefulness of hypothermia as a routine treatment in patients who are comatose after cardiac arrest has been questioned. And the TTM2 trial enrolled and 1,900 patients were comatose after resuscitation from out of hospital cardiac arrest. It was by far the most comprehensive and the most well-conducted trial on this topic and showed no benefit. But this is out of hospital cardiac arrest. So there is very little evidence concerning in-hospital cardiac arrest. Immediately after that trial, Shannon Fernando, Jerry Nolan, and myself conducted a systematic review and network meta-analysis, which is now published this month on intensive care medicine, which show no benefit and potential harm due to arrhythmia from hypothermia versus fever control. But again, this is only on out-of-hospital cardiac arrest. There is evidence concerning in-hospital cardiac arrest because part of the patients enrolled in recent trials, for example, the Hyperion trial, concern in-hospital cardiac arrest, but there is just a part of the population. There is one completed trial, which is the HACA-HOCA trial conducted in Germany, and these results have not been published yet. I'm looking forward to seeing the results. And so for that specific subpopulation, there is no evidence. So not the last word has been told concerning targeted temporal management with hypothermia after cardiac arrest. But for the moment, the International Liaison Committee on Resuscitation has recommended replacing hypothermia with fever control for 72 hours or more after cardiac arrest, but also recognized and acknowledged that we cannot exclude that there are some specific subpopulation who can benefit from hypothermia. But the fact is, we don't know yet.
So there is very much to learn still, Claudio, and that's why the Congress is there and that we should discuss this with everybody. So if I may come back to all of you, and we are coming to the end of this, this session, if you would just in 40 seconds give a general advice for our audience, how they go through the Congress and what they should do. What would be your advice, Claudio, first? What would you advise the people who join the Digital Congress? And you just have 30 seconds.
For the topic of cardiac arrest management and brain injury, I do recommend following the joint session with ERC cardiac arrest from initial management to rehabilitation. There is everything about extracorporeal CPR. New trials have just been published from hypothermia and from prognostication.
Fantastic. That is a very clear advice. So if I now may go to Xavier. Xavier, what would be your advice on this?
The keynote lecture on microcirculation and the basic physiology session that could be for sure with very good speakers, and the hot topic session of next Wednesday regarding the two studies I spoke about.
Yeah, well, that's a very clear advice. We go to Belgium. Geert, what would you advise?
I would recommend, because I think you will all find the sessions of the fields that you're interested in, but I would advise people to go through the program and pick out talks on subjects that you're not that familiar with. Just go through it like you would zap on your TV, and because there's I've done it, and there's in many fields. I usually go to to talks of fields that I don't know that much about. They're very good talks, all of them, also in the non-neuro field. But if you're not interested in, or you don't do that much neuro, I would. Of course, advise you go to the neuro session, but go through something that is outside your scope as well.
Well, I like that advice very much. Thank you very much, Geert. Well, you started the session, and it's also you have also the last word. Marlies, tell us, what is your advice?
I would go to the keynote lecture on fluid management by Suvi Vara. I would go to the renal replacement therapy practice session, and it covers all aspects of renal replacement therapy, including the latest studies, and it will be presented, they will be presented by the key authors. And then I would go to the what is new in AKI, because it touches on all the latest advances and innovations. And then in between, I would visit experts in the coffee room for chats to ask the questions which you've always wanted to ask.
Thank you. That is fantastic. So we have come to the end of this first meeting that we had with the section chairs, and I hope to see you all back again tomorrow.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand. We made significant changes to the European Society of Intensive Care Medicine in the last few months. We made these changes because we realized that we wanted a society that had to be more representative of the membership, of the community, of the diversity of this society. And indeed, we stick to some key values to make these changes: diversity, respect, inclusiveness, vision, excellence. These key values are what is driving our society and the action of this society now. And we think that with these values, we can really achieve what is important for our patients and their families in intensive care, which is excellent clinical care, a good experience in intensive care, and we will do this by fostering research and education for our global intensive care community. Hello and welcome back for this last live session for the day. I am very, very excited for the first Hot Topics. Hot Topics is a tradition of our live conference where we release some important data from important studies. In particular, today and on Wednesday, I will have the pleasure to have with me one of the associate editors of JAMA, Chris Seymour. Hi, Chris. And welcome. Chris Seymour is an associate professor of critical care at the University of Pittsburgh School of Medicine. He's a member in the Clinical Research, Investigation and System Modeling of Acute Illness CRISMA Center in the Department of Critical Care, and as I said, an associate editor at JAMA. Chris, how are you? Welcome.
Very good. Thank you, Professor Sezioni. It's fantastic to be at this ESICM Hot Topic session. We're very excited to partner with you today and wish I could be there in person. To get started,
we would love to have you in person, but we're still very grateful for this. And just before you start, let me tell you on behalf of the ESIC family and on the intensive care community, thank you so much to you and to JAMA for all the work that you've done in the last 12 months. We've been following you, all the updates and everything that was there to support the research and clinical community. You've done a tremendous job, really. Thank you.
You're welcome, and that thanks goes both ways to ESICM. Okay, so to begin, we'd like to introduce our two other panelists that are here today that happen to be co-authors on this amazing trial we're going to discuss. Professor Escort is from Radcliffe University. She's from the UK, and she's a consultant hematologist and a senior clinical lecturer in transfusion medicine. She will be presenting the results of the trial, Effect of Convalescent Plasma on Organ Support Free Days in Critically Ill Patients with COVID-19, a randomized clinical trial. And joining her in commentary in our panel afterwards is Professor Manu Shankahari. He's a professor in critical care medicine and an NIHR clinical scientist at Imperial College London. Welcome to everyone, and we're very excited to share these results.
I'd like to thank the organisers of ESICM for inviting me to give this talk on the immunoglobulin domain of the REMAP-CAP trial. This domain assessed the effectiveness of convalescent plasma on organ support-free days in critically ill patients with COVID-19. I have no conflicts of interest to declare. I'd like to start by talking about the background of convalescent plasma and its use in previous diseases as well as in SARS-CoV-2. Convalescent plasma is plasma collected from individuals who've recovered from an infection and has high levels of antibodies against that infection. In the case of SARS-CoV-2, this is high levels of neutralizing antibodies. Neutralization of a virus is the main method of action of convalescent plasma. It does this by the antibody binding to the virus and stopping it infecting further cells, halting the progression of infection within the body. However, it may also have other effects by enhancing the patient's own immune system. This may be via antibody-mediated cytotoxicity or phagocytosis. Convalescent plasma has a long history of use in infectious diseases. Indeed, Emil von Behring won the first Nobel Prize for Medicine for his work using convalescent sera to treat children with diphtheria. When we look at evidence from other previous pandemics, such as influenza and SARS, this meta-analysis is looking at all-cause mortality and the effect of convalescent plasma. As we can see, overall, there appears to be a protective effect of convalescent plasma. However, the studies included within this meta-analysis are of poor quality and high risk of bias. And the majority of studies, patients who received convalescent plasma were more likely to survive for other reasons. I therefore want to go on to looking at the evidence for convalescent plasma in COVID-19. This meta-analysis is looking at severity of illness and is from the Cochrane Haematology Living Systematic Review. Here, individuals with severe disease of a group of patients that are being assessed in the REMAP-CAP trial. As we can see, there are two small trials looking at the effectiveness of convalescent plasma, and there's a suggestion of a beneficial effect with a hazard ratio less than 1. However, the confidence intervals are very wide, so we're very uncertain whether this effect is true or not. We therefore need definitive evidence from the REMAP-CAP trial to say whether convalescent plasma is beneficial. Therefore, I'd like to talk about the trial design. REMAP-CAP is a randomized, embedded, multifactorial adaptive platform trial for community-acquired pneumonia and has a pandemic protocol. Over 14,000 patients have been randomized with suspected or proven COVID, testing multiple interventions. It is a platform trial in that it has a core protocol and it can assess multiple questions about the effectiveness of interventions for a particular disorder, in this case, treatment of COVID-19. It also has an adaptive element in that evidence collected within the trial can affect the way in which participants are randomized, so that if a treatment is seen to be beneficial, more participants are randomized to the intervention. Multiple treatments have already been assessed in the REMAP-CAP trial. These include corticosteroids, IL-6 inhibitors, and therapeutic anticoagulation in the intensive care. However, there are also multiple interventions continuing to be assessed, including thromboprophylaxis strategies in intensive care, simvastatin, and vitamin C. However, I want to concentrate on our hypothesis for convalescent plasma. So our hypothesis was treatment with high-titer, ABO-compatible convalescent plasma improved survival to hospital discharge with reduced use of ICU-level organ support in critically ill patients. We included adults with confirmed SARS-CoV-2, and the positive test result could be either in the community or after admission to hospital. Patients were critically ill, requiring ICU-level care, and this was either respiratory support for high-flow nasal cannulae, non-invasive or invasive mechanical ventilation, or cardiovascular support with vasopressors or inotropes. Participants had to be randomized within 48 hours of admission to intensive care and within 14 days of hospital admission. The intervention was 2 adult units of convalescent plasma, which is equivalent to around 550 mils. The first unit was given as soon as possible after randomization, and both units were needed to be given within the first 48 hours of the trial. The majority of convalescent plasma, around 95%, had a Euroimmune titer of at least 6. This is much higher than the FDA definition of high titer convalescent plasma, which is a Euroimmune of at least 3.5. All our convalescent plasma was ABO compatible, and our comparator was standard care. Our primary outcome was an ordinal composite outcome, which was made up of in-hospital mortality and number of days free of ICU-level organ support up to day 21. The worst outcome was death during the index hospitalization, which could occur up to day 90, and was assigned a score of -1. The best outcome was 21, which was 21 days free of organ support. This composite outcome reflects both utilization of critical care therapies and survival. The analysis was a Bayesian primary analysis modeled with cumulative logistic model. Our covariates included site, age, sex of the patient, region in which the patient was randomized, time period of enrollment, and assignment to other interventions, as these are important covariates that can affect the outcome. Our trial had a responsive adaptive randomization based on the probability convalescent plasma is effective. Our adaptations were driven by Bayesian posterior probabilities, and at each adaptive analysis, the following were evaluated. Superiority of the intervention with more than 99% posterior probability that the odds ratio was greater than 1, and futility with a more than 95% posterior probability that the odds ratio was less than 1.2. I'd like to move on to the results. So within the immunoglobulin domain, we randomized patients from May 2020 to January 2021. We included 2,011 critically ill patients, and of these, 1,084 were assigned to receive convalescent plasma and 916 assigned to receive no convalescent plasma. Of those randomized, 99% of participants completed the trial, and we have results for the primary outcome. Looking at the population, the median age was 61 years, and around a third of patients were female. The majority of patients were recruited in the UK, with around 95% of patients recruited there. Other countries which recruited to the convalescent plasma were Canada, the USA, and Australia. However, in the United States, participants could not be randomized to no convalescent plasma due to the emergency use authorization, and instead they were randomized to delayed convalescent plasma. When we look to time to enrollment from hospital admission, we can see that the time period was short, so people were developing rapidly critically ill patients, and patients were randomized within 43 hours of admission to hospital, which included the time within the emergency department. And it was also within 18 hours of admission to the intensive care unit. For those patients who were randomized to convalescent plasma, participants received the convalescent plasma usually around within 5 hours of being randomized. So the total time for patients to be included within the trial from presentation of the emergency department was within 2 days, which is well within the 3-day criteria thought to be important. When we look at the severity of illness, we can see that PACHI score was around 13. Around 46% of patients were on non-invasive mechanical ventilation and 33% on invasive mechanical ventilation, with the remainder receiving high flow nasal oxygen and vasopressor support. The majority of patients were on concomitant steroid therapy, and this was because nearly all patients were randomized after the findings of the recovery trial and steroid benefits of steroid therapy were released. We also assessed at baseline whether patients were antibody negative or whether they still had detectable virus at the time of randomization. Around 30% of patients were antibody negative at baseline, and around 80% of patients had detectable virus at baseline. About 6.5% had immunosuppressive disease or were receiving immunosuppressive therapy according to the Apache criteria. As we can see here, the viral load could be very high, and there was a difference between people who were antibody negative with a higher viral load, receiving invasive ventilation, which also associated with a higher viral load, and if they had immunosuppression. I'd like to come on to the primary outcome. We met the criteria of utility within the trial in January 2021 with probability futility of 99.4%. The adjusted odds ratio was 0.97 with a 95% credible interval of 0.83 to 1.15. In-hospital mortality was around 38% in both arms, and the median days alive and free of organ support was 14 days. When we look at the secondary outcomes, the results are similar to the primary outcome, with 28-day survival, 90-day survival, length of intensive care stay, and length of hospital stay. An important safety outcome was the venous thromboembolic events at 90 days. There had been concern at the start of the trial that use of convalescent plasma would increase the risk of thrombosis, but there was no evidence that this risk was increased within the trial. When we look at the secondary outcomes, we can again see that there was no difference within the subgroups apart from the immunodeficiency subgroup. In this subgroup, there's possibility of a benefit, but this did not reach statistical significance. The posterior probability of convalescent plasma being superior in this subgroup was 89%. When we look at antibody status, which was felt to be an important category, especially after findings for recovery trial, although the possibility there may be a slight benefit, it did not reach statistical significance. So, in summary, this trial with REMAP-CAP is the largest trial of convalescent plasma in critically ill patients with confirmed SARS-CoV-2. Treatment with 2 units of high-titer ABO-compatible plasma had a low likelihood of improving organ support-free days. That had a 99.4% probability of futility. Secondary and sensitivity analyses were consistent with the primary outcome, and the subgroup analysis suggested a benefit in adults with immunosuppression. And so REMAP-CAP is reopening convalescent plasma trial in this subgroup to assess it further. I would like to say a huge thank you to the large number of donors, laboratory staff, and blood services that have enabled this to happen, as well as all the funders and research groups around the world who've helped with the trial. I'd like to now ask if there's any questions about the trial. Thank you for listening.
Lisa, congratulations on a fantastic presentation and also on this amazing result of completing this trial. And before we ask you some questions to you and also to Manu Shankahari from London that is connected to. Chris, can you tell us, this is not the first REMAP-CAP study that you have handled at JAMA. Why was this study important, and can you tell us how it has been since receiving the manuscript, your perception of the study?
Sure. So thanks again, and congratulations to the team for their fantastic effort. This was a number of months of enrollment and a really remarkable achievement. So from the JAMA perspective, we were quite excited to get this trial. Ever since our early report case series of 5 patients in Shenzhen treated with convalescent plasma, we've had interest in this area. And the U.S. experience, at least, has been an adventure, I think, with our treatment of many thousands of patients and through the U.S. federal government support. So I think we've had some randomized trials. We've had a meta-analysis that we saw as well earlier in the year. And so we're very excited to get this well-done clinical trial amongst the critically ill, which is a very distinct population. And I think that's what makes the REMAP platform unique compared to many others. So it was, again, we love clinical trials, and this one may have a neutral result, but certainly lots to discuss.
Very important, and maybe I start with the first question, and Lisa or Manu, I think what was very strong about this study was that you selected high titer plasma, which was one of the criticism of some other studies that came out before. Can you elaborate a little bit more? I think you mentioned it, but what threshold did you use for this? And this was in line with what you were expecting from centers that say that you should always use very high titer with plasma?
So we aim to select plasma that has at least a 1 in 100 neutralizing antibody level, which when we did our tests shows was equivalent to a Euroimmune of 6 or above. And that was felt at the start of the pandemic to be high titer plasma. We found actually when we looked at our donors within the UK that only a very small number of donors actually met those criteria. We were very strict in actually rejecting most of the convalescent plasma that we collected. So only about 10 to 15% of the plasma we collected was suitable for the trial. The rest had antibody levels that were too low.
Thank you for clarifying. I think that that's very important and add even more strength to the study. Manu, another negative study, but the importance actually of doing trials on this. I know that one of your field of expertise is the immune response. Do you have any data that has not been published yet or that you're analyzing about cytokine levels in different groups of patients, and there's something that you will be working on that?
Maurizio, thanks. First, thank you for the ESICM for the invitation, and JAMA for kind of doing the hard work of getting this in time for ESICM. So to answer your question, Maurizio, yes, we collected quite a number of biological samples, and we are working through them. The two things that I would like to highlight from a biology perspective is the antibody levels in patients. We had antibody levels in all of the UK recruits and quite a lot of the recruits from other countries. So the participant antibody status was available to do the hypothesis that if you're antibody negative, you get a better treatment response. And the second thing that we did, I think was fantastic, was the viral load. In a subset of patients, we have collected plasma to do deep immunophenotyping, so watch out for these results in the next few months.
Thank you. That's very interesting. Chris, any comments or question from your side?
Yeah, sure. So I know time is tight, but I was wondering if there was any comments from either of you about the different variants of patients that may have been enrolled during the trial. We had a very different landscape here in 2021 than perhaps when some of these patients were treated.
So if I can answer that, we actually did respiratory sampling of all the patients in the UK in the trial, and actually anybody who was positive we sent to do viral sequencing to see which type of virus they had. Most of the patients were recruited over the autumn and winter of 2020, just starting 2021. And we saw that the patients were either had wild type or the alpha variant. Now, when we had a look at in the lab about the effect of plasma against both variants, that there wasn't any change in the effectiveness of the plasma against the alpha variant versus the wild type. However, as you said, the landscape's changed significantly. And now we're looking at the Delta variants and other variants that may be coming along. We've been doing some work over the summer that's looked at plasma from vaccinated donors, so people who've had a natural infection and then been vaccinated. And their plasma has even higher antibody levels, so up to 10 times higher than we had in the original trial, and also has a very broad reactivity. So people who had a natural wild type infection are now getting really strong antibodies against the Delta variant and also against the Beta variant. So we're seeing that actually natural infection plus vaccination creates quite a broad spectrum antibody cocktail that enables response, it's certainly within the lab, with high levels of neutralization.
Thank you. We have a question that I am receiving from social media, not from Facebook, because apparently all of Facebook worldwide is down in this very moment while I speak, but we're able to be live on all of the other platforms. Is it possible that the negative results is due to the timing of enrollment of patients? So are the patients too far ahead into the disease? And of course, it's not feasible to think about giving plasma at home, but do you have any data on the date of onset of symptoms? And was there any signal there? Manu, maybe?
Lisa, do you want to come in or shall I?
Yeah, Manu, do you want to go?
Yeah, okay. So thanks, Maurizio. So we had the days from hospitalization. So one of the questions here is that if you come in a point at which your host response is producing antibody, is there any value in giving convalescent plasma? In our population, we had a distribution of time from hospitalization to randomization. Most of the patients were randomized within the 0 to 3 day time window. In fact, we have a subgroup analysis which highlights that there is no treatment effect heterogeneity across the duration of administration of convalescent plasma from the time to hospitalization.
Thank you. And another question, maybe very practical, Lisa or Manu, or even our editor, Chris. Is this the end of plasma for the moment outside of clinical trials, or is it the end of plasma full stop? I need to ask this question. Lisa, maybe?
Yeah, it's not the end of plasma, nor the end of clinical trials on plasma, because of what I said previously about plasma with high antibody levels post-vaccination. We are now looking at restarting VMAT-CAP in the immunosuppressed population using vaccinated plasma. And we're also planning to do a trial on early treatment with this vaccinated plasma as well in the immunosuppressed population or high-risk patients. We think that the monoclonal therapy trials have shown that there's potential for benefit in antibody therapy, but because convalescent plasma is more variable, we need to produce much higher levels than we've previously been able to do, and also thinking about the timing. So if preferably to give it earlier in the onset of disease, so soon after people start developing symptoms.
But Lisa, if I can just ask you to clarify, is it a yes in a research setting, or would you still use it in...
It's a yes in the research setting.
Manu?
Yes, in the research setting. I think if I may add one small point, so the 1 in 5 critically ill patients have got viral RNA detectable in blood. And if you look at our manuscript, these patients have got very high levels of viral content in the respiratory tract. So the timing issue is probably not directly relevant to this trial because we have still found a population where there is viral RNA detected. I think the earlier time point is perhaps valid given the results of the monoclonal antibodies. So we are talking about pre-hospitalization or hospitalized, prior to hospitalization, acutely unwell patients who may benefit from this intervention.
Thank you very much. I would like to give to Chris the final word, but let me thank you and congratulate you before that, and also to all the REMAP-CAP family, because the pandemic has shown that we could develop vaccines very fast thanks to the research done in the previous 20 years. But what REMAP-CAP was able to do was to prepare a platform for research at very fast speed and very high quality of evidence, and really the benefit that we are giving to patients at the bedside thanks to this is very commendable. So thank you on behalf of our community. Chris, the final words to you.
Yes, so thank you, Maurizio. So I'd also just like to commend the research team, the editorial team, and everyone who's contributed to this study. It's really remarkable to think about how when planning a trial, a year later, the intervention, the patients, the disease itself is all different than when we started. And it's an incredible challenge for all of us. So congrats to this team. Often with neutral trials, we end up, in fact, with more questions than answers. And that's probably the case today as well. So thanks for joining us today at ESICM Hot Topics.
Thank you. Thank you.
As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients.
We work together as a single team with patients and families.
We try to provide the best care for you, to work in your best interest.
Bring into the care that we provide in the ICU.
I will be there every day, every night, all the time.
Il messaggio che posso mandare è un messaggio di fiducia e di speranza.
Quality of communication has an impact on the family's experience both during the patient's ICU stay and in the months that follow.
We are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
No matter how ill the patient, don't give up hope.
Some family members suffer from symptoms of anxiety, of depression. Some feel lost or even disoriented. So don't forget to take care of yourself.
Experiencing an ICU stay can be difficult. Understanding technology and treatments that you've never seen before is something not easy to understand.
Morning. Good morning, Sophie. Hello. It's 7:30 now, and it's time for me to talk to my colleague about what happened to you this night. So I'm going to tell about you and about everything around you. Is that okay? Okay. This is Alessandro, and he will take care for you in this day. Okay. Well, Alessandro, this is Sophie. She came in here 3 days ago with a septic shock, and overall she is doing well. If we look, you see she's still intubated. It's in her lungs, yes, you can see. But I managed to build it down this night. So she's not on the pressure control, she is more doing for herself in the breathing. So I think that she can further go on today. So maybe you can manage to let her breathe for herself.
Okay, she goes better, yeah.
Yeah, and I think that will be a very good step forward for her that she can work on. Furthermore, the blood pressure, that is stable, and this night we lowered down the medication to keep it stable. So I think in this morning you could stop it.
Okay, well, so you decrease the ventilator and the medication support.
Yes.
Okay.
And well, that was because she was also a little bit agitated, so that gave her the push and to give her the stability to push forward. So I think she also needs your support today to be calm and to have enough comfort.
Okay. And did she receive the visit of her family member?
Yeah, yesterday they came. Her mother comes, and she has a friend, and he also comes. And I talked to her mother on the phone this morning, and well, she told me that she is worried, but she's not communicating well enough with her boyfriend.
Okay.
So it might so be that you could consult the social worker, so that the social worker can arrange, well, maybe a discussion or maybe talk to the mother and have reassurance for the mother.
Okay, later. Okay.
Yeah, I think that will do for her very good. For the rest, I think it would be nice for her to get out of the bed, and she needs that to get out, and that will be a good point.
Yeah, okay, I think so.
Have you any questions for me?
No, it's okay. Thank you.
Okay. What we have done is to turn over my shift in the night to the day shift. And what is needed, that I tell what happened this night to Sophie, to my colleague, so that he can take very good care for Sophie with all the machines around Sophie.
It is very important to share this information with every team members of the intensive care unit for the best care of Sophie. Good morning, Sophie. Hello. How are you? Well, now we'll do the round all together, in which we discuss your improvement and the goals for today. Okay? All right.
Good morning. So, Massimiliano, what can you tell me about Sophie?
Well, Sophie has been with us for 3 days now, and she has been here for a septic shock. I think her condition is generally improving. Her drug levels are going down, and also her organ function is improving.
How about the kidney?
The kidney are also going better, and she is able to have a good urinary output on herself. I think also we are on the 3rd day of antibiotic therapy, and the condition is generally improving.
Okay, and the antibiotics are correct?
Yes, we have identified one bacterium on the blood, and the antibiotic therapy is targeted on that.
Oh, perfect. Alessandro, anything from your side?
Well, during the night with a very, very light sedation, she slept well. She's comfortable. Now, no pain, actually, and a good bowel partner now.
Okay.